to our honorable dignitaries, delegates, welcome you all the third day of our second international conference on transforming perspective of nursing research leading to clinical innovations. In association with Pushpanjali College of Nursing, Agra, UP, we are also associated with the OET, IBAC and CBS. I hope by the scientific session what we have covered the last 2 days, that will get the opportunity to test our knowledge and understanding. We also look forward to get an exposure about the best of the brain things about the dynamic issues of in this nursing field. So as per Indian tradition and culture, we will start our session with the traditional lab lighting. I request all the dignitaries, Dr. Alka Saxena ma'am, Sister Lily ma'am, Professor Naveen Ajay sir, we already have introduced them because they were with us for the last 2-3 days. So today I welcome Professor Rashmi Rawat ma'am. Ma'am has joined us today only. So I just want to give the brief introduction to our audience. So ma'am has done her UG and PG in psychiatric nursing from AIMS New Delhi. Currently ma'am is pursuing PhD from AIMS Rishikesh. Ma'am having 10 years of teaching experience in government and private institution. Ma'am has authored chapters in psychiatric nursing and psychology textbook from Elsevier publication. Ma'am is an area of research is improving communication skill of nurses. Ma'am has been faculty for training nurses in empathy communication skill at AIMS Rishikesh. Ma'am has developed a video-based learning of empathy communication skill for nurses which is under process for copyright. And ma'am has also received token of appreciation from AIMS Rishikesh in collaboration with NHM and NIMANS for actively participating in the committee of training the healthcare staff for Hilly region about the mental health. So we have a big round of applause for Rashmi ma'am and all the panelists. So now I request our principal ma'am, Dr. Deepti Shukla. Ma'am, kindly welcome to all our panelists in this session with a floral bouquet. Big round of applause, please. Now I request the head of this session, Dr. Sunita Verma ma'am, Associate Professor of Sister Niveda Government College of Nursing. Ma'am, you introduce all the panelists one by one, please.
Jai Shri Ram.
Jai Shri Ram.
Radhe Radhe.
Radhe Radhe.
Radhe Radhe.
Radhe Radhe.
Jai Hind.
Jai Hind.
Jai Hind.
Jai Hind.
Jai Bharat.
Jai Bharat.
I am Dr. Sunita Verma, and I wanted to introduce the panelists. First of all, at the very much left, Dr. Alka Saxena, and another side she's a Professor Rashmi Rawat, and Dr. Mr. Navina, and Madam Sister Lily. So they are the panelists. So today's topic is very important. The theme which is given for the panel discussion, this is the utmost needed topic, which is the very much required for to all of us. So the topic is current advances in trends and ethics in nursing education and practice. Usually what happens, whatever we study, we are not bringing into the practice. So always there should be that gap should not be there. So whatever we study in the theory, that gap to be bridged by the application of our theoretical knowledge in the clinical areas. So first of all, I would like to wanted to give little introduction about the topic. Its own way fostered the image of nurses. Nurses are trying hard to find new and better methods to help the clients, their family and community, which in turn led to the trends in nurses. Nurses' knowledge and clinical experiences will result in best clinical practices. So, the trend in nursing education and practice are the cornerstone for the dynamic nature of nursing profession. So, let's deal with the theme for panel discussion as I told about the trends in nursing practice and clinicals. So first of all, I would like to ask about the trends in general. What are the trends in nursing? I would like to ask this question from Dr. Alka Saxena, nursing.
Thank you, Smita ma'am. As you know that trends, what is trends? You can see the changes is going on in one direction. As in nursing profession also, you see there are so many changes. Since 3 days we are looking in the conference, various topics is going on, telemedicine, and each and everything, computer use. So this is the trends. This trends is going on. Last 30 years back, this was not there. Computer was not there, and telemedicine is a new concept you see after the COVID. So these are the things that is come under the trends. What are the changes is going on in this era? And as the delivery of healthcare system is changed, that's why the nursing also want to change. And it is the responsibility of the nursing profession persons that they have to look after and adopt the things like in the other countries they are adopting the things which is going on. And these are the, you can say, the trends we have to adopt so that our nurses also work globally and give the quality care to the patients. Thank you so much.
So okay, about this is the trend you have told about, but could you please highlight the issues and challenges in this recent era?
I would like to show some slides. Here you can see some trends. Can you please open? So you can see this slide that nursing is a noble profession that play a critical role in providing healthcare services to the people of all ages and in a variety of settings. But nursing is also a field where continuously changes is going on. And you can see trends that just now I have told you the change which refers to the direction towards which the different nursing events have moved or moving. And issues, what are the issues? How can we define the issue or challenges? That's something new and difficult that forces you to take a lot of efforts. Like you see in the nursing profession, there are shift duties and infection, safety, security, many things are there. These are the issues and we have to fight them, and these are the challenges also. So contemporary nursing, that is what is the present scenario, what are the things is going on, what are the challenges are there, what are the trends are there. So this is my topic which is given to me. So issues is just like that, what are the different issues, problems are there. So in the nursing profession, in every profession there are some problems, but in nursing profession is problems are there, and this is the responsibility of the nursing professionals to resolve these. That's why all this type of workshops are going on, how to take care of things, like the people, like some conferences is going on online, offline, to make the competencies among the person, among the nursing students, among the nursing personnel. So many countries or India also organizing such types of international and national workshops to update our knowledge so that these challenges can be made, these issues can be resolved. So this is the thing, and thank you ma'am. Next question.
Miss, as Madam has told, there are so many trends and issues and challenges are there. So during COVID, if we all know about the COVID, when COVID came, so there are so many things. Means we all became innovations took place. So always we say that there is something good behind bad. So of course, during this COVID, if it was fatal and very much threatening condition was there, but still we learned a lot about. So if we talk about the nursing field, though it was a very much challenging for all of us, and it was very much scary to each and every individual. But our nurses were there. 24 hours they were there without the fear that COVID can attack on them and they can die and all. But still our nursing personnel has taken active participation and they serve the human. Okay, so this was a big issue, a big challenge for the nursing personnel. So along with that, the innovations took place. So now I would like to ask Madam Alka, in case if such situation arise, like there are so many challenges took place, so how we are going to resolve it? What are the main thing which we should look forward to resolve the challenges in nursing? Because every day we are there is one new challenge. So these are the challenges. So how we are going to resolve it, ma'am?
Now, I just start from starting. So, what are the different trends? Like you see in the slide, nurses are shortage will continue. There are shortage of nurses. You see, 1.6 million nurses are less, and India also very less nurses, and 0.6 in Uttar Pradesh nurses are there with 100,000 patients. So, there is a global shortage. And increase is demand of care, nurses burnout is there. This is a shortage, you just simply understand there is a trend, it is shortage. Next slide please. And this shortage is continue and increase in aging, different things are there, so that there is shortage. But due to shortage, we have to see that the Mission Nirame has started to take care of this in Uttar Pradesh and all over India. So you see that nursing jobs is now increasing. There are some things is not there. Estimated job growth is also expected to rise 45%. In addition to the influx of job from nurses retiring, there are additional job opening up around the country as healthcare system expand their facility to accommodate a growing population. So this is there, like yesterday forensic nursing, it is a new era, new field that is there for the telemedicine and this type of area of where the nurses can work. Next slide. Then increased use of online nursing programs are there. So this is the trends. You see, like yesterday you have attended the online lectures from lecturers from faculty from the foreign places. They are coming to India all over the world. They are giving their expertise, giving expert lectures and competencies, skill-based competencies. Here also Pushpanjali college team presented in front of a demonstration. So these are the things, online teaching, the person is updating the knowledge. So this is an order. Previously it was not there. When we were the students, our teachers is teaching in the college, and otherwise we had to go to the library and see the make our notes. Now you see the students are getting more knowledge, away from your college and from abroad also. Your exposure is too much. So this is the online courses also. You have some short courses are there in yoga, medicine, forensic medicine. So many courses are now come up, and in India and abroad you can register yourself and get the higher degree and knowledge. So the trend is there, and nurses will need higher education, focus on BSN degree and MSN. Previously it was only MSc, okay, it's okay. Now you see India also PhD, MPhil, and you see the other specialization, forensic nursing and other nurse practitioner courses are coming up. So this is the trend. So it will put some pressure, some issues on the nurses also. Then next, nurses will need, there is a rise of telemedicine. That yesterday this is a very big lecture taken by the madam. So I am not going in detail, but telemedicine is the area. This is also we are adopting this, and you know the benefits of telemedicine. During the COVID time, you have seen that nurses exposed, but then the doctors and other patients got the advantage of this. By the telemedicine, they have seen the patient on the video conferencing, and by the video conferencing, they have checked and report they have sent, and they got the treatment. So this is the benefits of this, and chatbot services is also now this is a new thing, and it also give similarly chatbot service has been introduced to give patient more ownership over their care received. Different apps are there that is also used. Next, traveling nurses. Yesterday it was discussed that like in the COVID period also is a hotspot area where the COVID is there. The nurses have moved to take care of the patient. So travel nursing is a new industry. It is 30% now increasing, and this is an area where the nurses are asked to work. This put pressure on that when the person go, but advantage is there. So increased specialization and career path options is there. Healthcare needs are becoming increasingly complex. As a result, the scope of specialization, like nurses are working in the pediatric department, cardiac, intensive care, nurses can choose a path that suits them. So different specialized area is there, oncology, cardiology. So the nurses are taking the specialization in that area, and they are working in India and foreign countries. Self-care for nurses is also a trend because nurses are working 24/7. Different care models are there. So sometimes you see around that there is a hectic one. Nurses are not taking care of themselves, and they become sometimes infectious. Sometimes they get the infection. Sometimes there is a back injury, eye injury, tiredness, mental illnesses may there. So now this concept is there. Whenever you are taking care of the sick people, you have to take care of yourself also. Previously it was not there. So this is a self-care for nurses is also important. Then nursing informatics is also growing. Next is we have discussed yesterday. And speedy communication. Like speedy communication, mobile video conferences and changes in the communication technology have reduced the distance of the client and healthcare services providers. So this is the thing that if you want to take the health services from doctor in foreign country, robotic surgery, everything is there. So you can get the things easily by this way. This is the latest trend is there. Next, computerization in the patient care, you know that how the computers is using. And quality assurance in nursing. Previously, I can't say, but this is the thing that trial and error method was going on. And that yesterday Madam Smriti was telling, patient Madam Kathleen was telling, we are not paying the students and we are taking the care. Or in that case, the student is not learned, but they are studying. As patient, they are studying on the patient. So quality assurance, now the quality checklists are there, and due to this trend is there. Now, continuing nursing education, next, this is that is going on, continuing. Evidence-based practice, because researches are going on, so that evidence-based practices we are following, and giving the quality care to the patient. Next trend, intensified research is also there. So we are applying the research findings in patient care and everywhere, education and other fields, administration. Then now look after what are the issues are there. Just I address one by one. Number one, workplace violence is there. Sometimes nurses, when you have seen in the COVID time, many nurses, many health workers not accepted by the initial in the first wave. In the Indore, you have seen the cases. So this was the thing that workplaces, this is the issues are there in nursing profession. And the burnout is also then when person is, the nurses are working in a same situation in ICU, that's they are looking. Sometimes some resources are not there, long hour shift duties. So the person when working in one person is doing 3 or 4 people work. Teachers also having this problem. It is not in India. All over the world, this is the problem. So then safety of the job is there, lacking sometimes. Like you can see the picture, back injury and diagnostic injury. That is also problem. Issues are there. Improving self-care. Next, overworked and underpaid. This is also an issue. Sometimes we are working. We are not part to the other countries. Or you can see in India, private and government sectors, there is a pay difference. And in the foreign countries, if you say, the nurses are getting much more. Another, this type of issue, work is there more and pay is less. It will also create problem. Long shift is there, 12 hours, 10 hours duty when they are working. So there may be chances the person health will be there, and there may be a problem of errors. Then professional burnout, it is the same. Next, changing technology also putting pressure on the nurses, because you have to learn. how to arrange the Zoom meeting, how to do this, how to screen. These are the new technology. We are also learning. Sometimes we want help, and our new generation that is now very much acquaintance with that. But we are the old person. Not old, we can say they are just learning. We have in our area this was not in age. This was not the things are there. Now if you get the new model of mobile, you have to see how to operate it, how to send the message. When we will learn one thing, another thing will come, another technology. So this is the there. So changing this technology put pressure on that. Workplace safety and security is also issue. Next, lack of synchronicity in the teamwork. Sometimes language barrier, the person is going to other states, other countries, there is language barriers, distraction is there, physical proximity, difference in personalities, workload, varying communication style, conflict, lack of verification of information and shift changes. These are some issues that the nurses all over the world is facing. And what are the solutions to this challenge? How can you resolve these challenges which we have seen? When that you have to create the positive environment, they need to be employer-friendly work environment, safety and security of the nurses, and protect the dignity and autonomy of nurses in the workplace. Safe, empowering and satisfying environment. So environment should be soothing, comfortable, and it should be positive so that nursing can give better and without much error, so they can give the proper better care to the quality care to the person. Next, then equipment and material should be available. Sometimes you see in the hospital some supplies is not there and patient want these things, and then it will put pressure on the nurses. So the authorities will look, all the items should be in a proper in handling condition so that they will get the better care, good care. Positive teamwork is required. Together everyone achieve more. So this has to be a mantra for the good working. So positive is required for giving quality care to the patient. Then recruitment and retention policy to be there. What amount you are paying should be there. What are the leaves for everything should be should be planned so that nurses will retain in the profession. Sometimes during the COVID time we have seen many nurses left the job because they thought how can they survive. They are not getting so much and their thing is there. This is infection. Sometimes I have studied and the paper is that they are not having the kits, PPE kit, and they have to care the patient, COVID patient. So this type of things get problem creating. Then closing education service gap. This is also at 3 days we are discussing about if this gap should be reduced. If gap is there, teachers are teaching something and nurses, those who are previous nurses, who have studied long back, they are doing the same thing. So the gap should be reduced. Whatever the research is going on, that should be adopted in the clinical area so that this gap should be reduced and better care can be given. Workload balance to be there. If the person is working like 10 to 12 hours, so any person, nurses also a human being, they also want some rest, some relaxation so that they can give the better care. आपका ड्यूटी है नाइट कर लो, अभी दिन कर लो, अभी 10 to 12 कर लो, अभी संडे ऑफ नहीं मिलेगा. Sometimes our administrators, nurses itself is like doing this. So when they come to know even we are everyone is a human being, if they are giving proper care to that, so balance things to be done. Then evidence-based practice is also the thing that is all because the dilemma should not be there. If you are giving the care to it should be evidence-based, research-based nursing care to be given, so there should not be dilemma and you will not feel stress. Next is the meeting patient expectations. Like you see the patient are, those who are coming in the hospital setting, they are having the smartphone with them. And immediately when you prescribe anything, they will just see and look after their Google, whether the medicine is right or what is the one. So you have to meet these expectations. So according to that, hospital can help nurses there by making sure that there are enough nurses available on shift to everyone has extra support or extra knowledge they are having. The disease pattern is also changing. So you see the disease like COVID and dengue, different type of things is there. So we have to look after. There's a need to be sophisticated. And message is that this is the message that like these are the trends and challenge and issues are there, and how you have resolved. So this is the thing that the patient and public have the right to be highest performance from the healthcare professional, and this can only be achieved by a workplace that enable a sustained, motivated and well-protected workforce, catering to the need of nurses and combating their challenges can make nurses empowered, encouraged, challenged and affirmed to the continue doing what they do best without any barriers. So this is the thing that just it was my topic, and if afterward you can ask any question. Thank you, Sita.
Thank you so much, madam.
There was no evidence of metastasis. This patient was told about the treatment that he has to go for orchiectomy. You know that? But what he was not told was as important as what he was told. Don't you think so? Is it so? We should give the information to the patient, whole information. Isn't it? Please, next slide. So this patient was not told that he will lose his facial hairs. What image he has in front of his wife, to his sons, what comments he was getting on the racetrack, what all he has endured during this period. We do not know anything about that. But what it was reported, this patient committed suicide after 9 months of surgery. So was it not our responsibility to give him the proper information? It is not our role that we just give okay, this is your treatment, this is the diagnosis, this is the treatment, this surgery, and rest is yours. But sometimes there are the wounds created by the illness, which बहुत गहरे घाव छोड़ जाता है हमारी self image पे, patient की self image पर, जो कि it can lead him to take these kind of drastic steps. Next, this answer of the question of madam will lie in this scenario. You all know this scenario? Students, first year fundamental of nursing, you must have heard the history of Florence Nightingale, isn't it? So this scenario is from the Crimean War in 1854, when Florence Nightingale was volunteering on the floor of wards where the injured soldiers were being brought. Now what she observed has inspired her to write a letter to the British government to, she has written that if you had wanted to create a world which is worse than hell, you have succeeded in it. Because the patients were dying because of the infections and diseases caused, but not because of the injuries. And why that infection was caused? Because that is, infection is followed by the physician from bedside to bedside who has not washed his hand or who has not sterilized the equipments. Isn't it? That was, a very small thing. But in those ages, ancient ages, the conventional medicine was like whatever believed that what you cannot see, that doesn't exist. So germs were the fiction, that figment of imagination for them. But this, in spite of the resistance from her colleagues, she has implemented the policy of hygiene and sanitation among her support staff, and she had to be meticulous in her documentation, in her notes, and in her the things it is followed or not, and which has led her to prove that this sanitation and washing one's hand will drastically decrease the death rate among the patients. And this has led to the foundation of the modern nursing after that. This was a very good example of nurse administrator who has acted as a nurse advocate for the patients. Next. So concept of advocacy. In the history we have learnt about that we as a nurses plays lot of roles. As a caretaker, as a healer, as a champion of the sick, as a health educator, physician assistant, surrogate. Okay? Then next slide. But above all, the philosophical foundation and ideal of nursing is the nurse as advocate. It is not just that we are adding one more concept to the list of the past, all the concepts, and not we are rejecting those concepts, but we are embracing it. The essence of all those, the roles we are playing, it lies under the nurse as an advocate. So it involves the basic nature and purpose of the nurse-patient relationship. We all study since the beginning of our career that if you want to provide better care to your patient, you have to be very good in building a relationship with the patient. Okay, and it is up to us what kind of relationship we are having with the client. It could be of child and parent, it could be of a client and counselor, it could be of a friend and friend, colleague and colleague, and so forth. There is a lot of range of possibilities. So proposed ideal advocacy is based on common humanity. Common humanity, the shared humanity. We are human beings, our clients are human beings, and it is this shared humanity that should form the basis of relationship, isn't it? Patient is coming to the hospital, he is not coming for any kind of picnic. So, आपको दुख होगा तभी आप hospital में जाओगे, and that is the last thing we as a healthcare professional don't want to go to a hospital straight away. जब तक बहुत ज़्यादा problem नहीं हो जाती, isn't it? So you just imagine, just keep yourself in the shoes of the patient and think, okay, what he has come for. I am also a human being. If I will be in his place or her place, how I should be treated. Next. So what it means to be a human is every human being or every patient is individual identity, individual unity. Uniqueness, you might have you heard about the individualized care. हम हमेशा बात करते हैं individualized care. ये क्या मतलब है? आप एक ही डायग्नोसिस के 2 पेशेंट हैं आपके वार्ड में, दोनों की नीड्स अलग अलग हो, isn't it? Let's take an example of fever only. One will say, okay, I will have paracetamol and I will be fine. The other will be having, oh, मुझे fever हो गया है, मुझे कोई देखने नहीं आया है, मुझे ये problem है. So this is the individual differences we find among the people, and we need to understand that to cater the need of the human beings, and these human needs which makes the fundamental rights of human. Next. So human rights and nurse-patient relationship, it is seen that whenever we have a disease condition or whenever the patient is coming to us with a disease condition, the needs are magnified, isn't it? जब हम ठीक होते हैं, we can do anything on our own, but जब हम बीमार होते हैं, we get dependent on other people, our needs get magnified. Okay, तो the process of disease condition renders the individual vulnerable to be abused. आपने देखा होगा, एक एग्जाम्पल मैं दूंगी अपने खुद के रियल सिनेरियो में. आई वॉज पोस्टेड एज अ ट्यूटर और सुपरवाइजर टू माई स्टूडेंट्स इन वार्ड, एंड देयर वाज अ लेडी केम. वो हॉस्पिटल एडमिशन के, इज इट ओके इफ आई टॉक इन हिंदी? सो वो लेडी एडमिशन के लिए आई, एंड उसको हमने एक बेड पे बिठाया, एंड देन द नर्स केम विद अ ट्रे. शी जस्ट पुट द ट्रे एंड होल्ड हिज हैंड लाइक दिस, हर हैंड, एंड try to break the bangles on her hand. This was the real scenario I'm talking about. So here what we didn't respected the integrity of the person, the independency of the person. That nurse didn't respected that thing, and she was so confused. थोड़ा swelling था उसके body में, और वो village से लोग आते हैं ऋषिकेश में, तो वो बहुत ज़्यादा confused थी. तो उसने बोला कि, and she was talking very harshly to the patient, कि अगर ये नहीं निकाला ना तो सूजन आ जाएगी, फिर देख लेना. And then she went off. So this should not be there. This is a real life example. So as an advocate, if I talk about this was reported to the in charge कि this was the scenario which has happened. So then after that, that nurse was talked about that, and the similar kind of incidents have been observed in other wards also, and then there was a group training organized on communication, on how to be empathetic towards the patients about that. So that is one role of administrator, how you can be nurse advocate. Next. So we need to be sensitive enough to the human needs which are there, or the new needs which have risen because of the disease condition. Next. Okay, this I have just explained with the example that this disease will damage the loss of independency, loss of freedom of action, interference with the ability to make decision, and power of healthcare professionals. कभी-कभी ऐसा होता है ना, पेशेंट हमारे पास एडमिट हो गया, एक बंदा आ रहा है आईवी लगा के चला गया, कुछ नहीं बताया. दूसरा बंदा आ रहा है इंजेक्शन लगा के चला गया, कुछ नहीं बताया. ठीक है, अच्छा ये टेस्ट करा लो जाके. फिर पेशेंट घूम रहा है सारे हॉस्पिटल में. So all these are the example of loss of freedom, loss of independency, and are powered as a healthcare professional. Next. if I talk about the responsibilities, our responsibilities as a nurse or as an advocate for the patient is we need to give the information as and when needed. आज की डेट में क्या होता है कि there are lot of information available in internet also, Google also, but who is the authentic person to provide the information? और ये भी ज़रूरी है कि उसको कब और कैसे information दी जाए. ऐसे नहीं कि patient को अभी बताया कि okay you are diagnosed with a cancer and that patient is in shock. Then you are telling these are the treatment methods. So that is not the way, isn't it? So you need to be the nurse advocate. You need to advocate for the patient's, integrity or the self-image of the patient. So again, the whole concept is revolving around this patient advocacy. What is patient advocacy? It is not the lawsuits. It is in nursing. If we talk about, it is preserving the dignity of the patient, then promotion of patient equality, and it is supporting, protecting and speaking out for the patient, especially for those who are not able to speak for themselves. Next. So we need to facilitate the decision making by providing the alternatives to the patients. By this you can do this, you can do this, and then let him decide what is his decision for the treatment option. And if you will take the steps, if you will say something, then definitely by the hit and trial methods, someday policies gets changed with the time. And these are the skills we need to be an advocate. That is, we need to have a problem solving skill. We need to be a very good communicator. We need to have an influential personality. We should, reflect confidence and competence in collaborating with the people for the patient safety. And yes, you need to be patient. You should have a patient enough to wait for the results of your your advocacy, whatever you are fighting for. And these are the how you can be an advocate. You can be a committee member who discuss the initiative, who make the policies. Then these kind of committees work for resource development also, like medical equipment आया है नया आजकल ऐसा होता है, and then you have to give the training on that equipment or induction training or the continuing nursing education, and it is always a collaborative efforts of different team members. Now in organization, when you are working, how you can do the advocacy? If you see something is going on wrong, then definitely follow chain of command, whom you should report first. Sometimes it is physician, or many of the times for us it is our in charge or supervisor or manager. And a lot of times we face the barriers also, like this advocacy is interchangeably used with the fighting, isn't it? Fighting for the patient. So that makes people reluctant to follow the lawsuit. That is okay, ये problematic है, ये aggressive है, तो इन सब चीज़ों में हम involve नहीं होते हैं. And understaffing is one more reason, because of which we are so overburdened with the work that we overlook the small issues. And knowledge deficit is the new nurses who are who come to the profession newly and they are not sure of the things. So they are also very scared of voicing their point. And can I examples of real life scenario? ये 2-3 example है, though I couldn't get the Indian scenarios. These are of US scenarios. So this is one by one. This is Pam. He is a home healthcare nurse and working for a disabled team. Next, this is Eric. He is wheelchair bound. Pam noticed that this Eric has been taken up and down of the stairs by his dad to visit the doctors to go to the school, and he noticed there is no ramp in the house, and the state ramp program was running out of fund. So what Pam did, he called the local county commissioner, and that commissioner paid a visit to the home for the assessment, and within 2 weeks the ramp was installed, and it resulted in a happy family. Next, she is Jennifer. She is taking care of Chip, who was on ventilator since he was a baby. Now he is ready to go to school, but the state doesn't allow the agency nurses to go to school with the kids. Now this Jennifer called the senator. The senator are the elected people in the US. So with the help of her agency, he helped him to write a bill which ensures that kids can be accompanied to the school, and they also ensure the licensing and proper accreditation of the agencies. So now Jennifer is accompanying the chip to his school to cater his medical needs, and he is learning well. Again, thanks to the nurse. Next, she is Tandy, and she is working. She is a student nurse, and she is caring for the residents in an assisted facility. So what she observed in this assisted facility, the sidewalk, जहाँ हम walk करते हैं, old age people, वो broken है और warped है. And she has heard the residents that हमें डर लगता है कि हम बाहर जाएंगे तो गिर जाएंगे. So what she did, it made her sad that it is important for them to move out and have that social life and exercise and all. So what she did, she went on the internet and she found that there is bostoncity.gov. There is a link for Public Works Department where there is a form which needs requesting for the sidewalk repair. She completed that form. She got a call. She explained them the situation, and that sidewalk got repaired within 2 weeks. So here we had this happy residents enjoying the weather. So this was also the work of the example of a nurse advocacy. Next, at last, I would like to say that it is the idea of nurse advocacy or advocacy is all about someone has seen someday something and they have fought for it to make sure that others don't have to fight for the same reason again. So if you see something, say something. Next is the communication skill is a must-have skill to be a very good patient advocate. And last, be the member of committees, you overcome the barriers in the organizations to better serve the patients. Any questions?
Thank you, ma'am. So in this, if we say means first of all, what I observed through this scenario is empathy. When you have that empathy, जब आप में empathy थी तभी आपके अंदर से एक भावना जागी, और जब भावना आपके अंदर से जागी, then only you were able to find out something, solution. So then you try to find out the solution, and when you saw that this is the solution, and you got an idea to whom I should request. So then that student nurse, she did the communication with the right person, and when that right person she communicated, so ultimately finally she got the solution. Okay, so this is very good, and this is what we wanted to teach to the budding nurses. Means whatever things are there, nothing is difficult, everything is easy. And nowadays students are extraordinary, I must say, because little bit motivation and reinforcement is required to the students, and apart from that they do the wonders. Okay, so that you people have to learn and you have to do. So this is what about the role of administrator. In a right way she is teaching, and in a right way students are learning, and in a very right way they are doing it. Thank you so much, ma'am. Naveen sir, I wanted to ask you, kindly highlights the ethical and legal issues while managing for the homeless people.
Okay. Very good morning. Thank you, Sunita ma'am, and my fellow panel members. So today is the last day of international conference. I feel all of you are want to complete all these topics as soon as possible, going back to home. आप लोग घर जाओगे आज, बट कुछ लोग हैं वो कभी घर में नहीं रह सकते। ऐसे हम बहुत लोगों को देख, we have seen many people every day, every second, every minute. People are coming out of the room. So I would like to go back to the history. about Crimean War, Madam has explained, and Florence Nightingale was flourished with the care and with the treatment, whatever she has given. I would like to mention one more person. I would like to ask you people that so जब सर्विस के लिए या केयर के लिए नाम बताए तो किसका नाम पहले आता है? मन में किसका नाम आता है? यस, करेक्ट. थोड़ा जोर से बोलिए. और जोर से. मैं नहीं सुन रहा हूँ. और जोर से. मदर टेरेसा. Okay, so why Teresa has become mother? She was not by birth. Her name was not Mother Teresa. Okay, she was a Teresa and she became a Mother Teresa. She done a magic. She done a wonder, and she cared the people, especially who are in need, who are not having shelters, who are not having homes. She was going to each and every person she was caring, and that's why she got Nobel Prize for the peace. Okay, so not many people do this, cannot do. Okay, so we can dream, but achieving the dream takes a lot of passion, compassion, and also dedication. So with that, I would like to raise my topic, and one of the best topic what we have chosen in the panel by the organizing people, trends, issues, challenges, ethics of nursing practice, as well as other issues what we are seeing in the country and world. So I'll start with saying by the Roy T. Bennett, always have a willing hand to help someone. You might be the only one that does. So I want to bring the attention of my audience. How many people help होमलेस पीपल? कोई भी? कुछ भी आप लोग उनको जाके खाना खिलाया, या 5-10 रुपए दिया, या उनको नौकरी दिलाया, या बुक्स दिया, एजुकेशन? कोई है इस ग्रुप में? कोई भी नहीं है? आपने ओके, थैंक यू सर. आगरा वाले बड़े दिल वाले लगता है. लखनऊ मुस्कुराते रहते आप लोग, हेल्प नहीं करते हैं. ओके, गुड. 1 2 3 4 5. देखिए, around 200 members are there in this floor. Out of 205 members helped. Okay, not bad. कभी किया नहीं तो आज से करिए, शुरू करिए. Okay, so why this problem we need to notice? Because can anyone tell me in the world, pay attention, how many people are homeless? कोई बता सकते हैं? Just a number. चलो कोई नहीं. वर्ल्ड का पॉपुलेशन बताइए. वर्ल्ड पॉपुलेशन हाउ मच?
143 crore.
पूरा वर्ल्ड पॉपुलेशन पूछ रहा हूँ. 143 crores of India's population. Okay, so I'm asking about world population. We need to update community health nursing and nursing. We need to update our knowledge. 800 crores of population plus we have in our world. 800 करोड़ लोग हैं. Okay, so उसमें कितने लोग के पास घर नहीं है? अंदाजा लगा के बताइए. Participants are not much active, still they're sleeping. Okay, it is Sunday. All of you rise. Okay, just get up. Okay, थोड़ा सा. Okay, so turn around. turn around. Okay, stretch. How's the Josh? नहीं है. How's the Josh? लेफ्ट साइड है, राइट साइड है ही नहीं है. How's the Josh? ओनली लेफ्ट साइड. क्या मेरे कान में कुछ दिक्कत है क्या? How's the Josh? क्या आप लोग के पास जोश है ही नहीं? ओके, लेफ्ट साइड वाले वेट ए सेकेंड. आप लोग बताइए राइट साइड वाला. How's the Josh? ठीक है, कोई बात नहीं. Sit down. So out of 800 crores of population in our country, in our world, so we have seen India is having 143 crores of population. उसमें कितने लोगों के पास घर नहीं है? जस्ट एन अप्रोक्सीमेट नंबर बता सकते हैं आप लोग? हम सबके पास घर है. 150 million. Google Baba. Okay, 15 crores of population were not having homes. Okay, so this in God, what about in our country? हमारे देश में लगभग yes, now your Google Baba is not helping. हमारे देश में कितने लोग के पास घर नहीं है? ओके, चलिए. हमारे देश में कौन, which is the state is having highest number of homeless people? कौन सी स्टेट में, राज्य में ज्यादा होमलेस पीपल है? मैडम, which state? बिहार, सॉरी, महाराष्ट्र, which is the top state for having more homeless people. Shockingly, we are in that state now. Uttar Pradesh is having highest number. Okay, so we can able to say that in comparison of the population, we have highest number of homeless people. So all over the world, if we see, Syria and Nigeria are the two countries are having more homeless people. 30% of the population are not having the homes. Luckily, our country is not in that place, because everywhere we are going like highest population, highest number of TB cases, highest number of cancer cases, but homeless ज़्यादा problem हो भी सकता है. So that's why we have to concentrate on that one. Homelessness is a complex and pressing issue that affects millions of people around the world. It's a problem that requires our attention, not just because it's a humanitarian crisis, but because it raises important ethical consideration. See, we are in the home, so that's why we are getting all the facilities. Okay, even Zomato से आप ऑर्डर किया तो तुरंत आके खाना आ जाएगा, स्विगी से आ जाएगा. आजकल 10 मिनट में आने वाला कौन सा है डिलीवरी आता है ना, ब्लिंकिट. आंखें बंद करो, लो बंद करो, आ जाएगा. घर है इसलिए आता है, घर नहीं है तो कहाँ आएगा, है ना? वो भी हमको सोचना है ना. See, we get a ration card, we get a ration, we get all the facilities, voter card, everything. घर है तो आपको सब कुछ मिलता है, आधार कार्ड. जब घर नहीं है, होमलेस पीपल का स्थिति या स्टेटस क्या हो सकता है? तो उनका राइट्स क्या है, उनकी एथिकल इश्यूज क्या है? सो हमने कभी सोचा है? हम लोग देखते हैं ना, यहाँ से ये देवा रोड है ना, लेफ्ट में जाते हैं वहाँ चौराहे तक कितने लोग मिलते हैं, है ना? तो हर सिटीज में, हर जगह में हमको we can see many number of population. These are some counts we have got. More than that, we are not getting the counts of these people. As we explore the topic of the ethics and homelessness, we must approach it with compassion and empathy. So, can anyone just we can get a recap of the previous session, day before yesterday. So you have attended. What is empathy? Samarpan. Okay. The international speaker was telling that something is shown. याद है आपको क्या किया था उन्होंने? Yes. Put your feet in somebody's shoes and feel. That is for others. You have to feel. You feel yourself in other place. That is called empathy. Okay, we need to understand the challenges that homeless individuals face on a daily basis and recognize that they are entitled to the same level of dignity and respect as anyone else. By doing so, we can work towards finding ethical solution to this critical issue. So हम अभी देखते हैं ये टॉपिक हम ज़्यादा देखने के लिए नहीं मिलता क्योंकि we have a lot of problem with communicable, non-communicable diseases, poverty, hungry, unemployment. So उसके साथ साथ homelessness भी एक बड़ा issue हो सकता है. Not in our country, in many countries this is a major issue. So how to combat this one? How to care these people? Next slide. What's the background of this presentation? It's no secret that people who are homeless tend to have more health problems than people who have homes. Obviously, एक घर मतलब 4 walls are there, so we have a protection from the rain, from the wind, from the fire, from anything. Okay, so from the domestic animals, yeah, from the accidents. Okay, so we have seen many movies and popular Bollywood heroes, they have taken their vehicles and hit the street people, okay, and they are still facing the cases. What might surprise us is people who are chronically homeless have a life expectancy of 25 to 30 years less than the general population. हम लोग का क्या है life expectancy इंडिया का? Yes? कितना? 60? अपने आप कम कर रहे हैं आप, okay? ठीक है. So it's nearby, every year it is, the rates are changing. Nearby 70 years we are reaching. Like, हम compare किया तो homeless people will have 25 years lesser than our expectancy. Okay, so this is a biggest issue. Next slide. What is the reason? The reasons are many and tragic. Without a home, people often end up sleeping on the streets where they are exposed to high level of stress and physical and sexual violence, other environmental factors that take a toll on health. And while shelters provide protection from the weather, crowded conditions can lead to the violence and are often only of a temporary relief. Next. Just go back to the slide. So can anyone tell me what are the issues of the homeless people? So commonly, क्या issues हो सकता है? Why I need to make this class interactively? Because I have seen your sleepy mood Sunday, so I just want to ask the questions, get back from you, so then I can come back. Yes? Light ही नहीं होता है मैडम. The light कहाँ से problem है? Okay, there is no adequate lighting for them. Exactly, good. Infections हो सकता है, yes. Food problem. There is no sanitation, yes. Water. There is no pure drinking water. किसके पास financial issue नहीं है? सब लोग के पास financial issue है. That is coming at last. Ambani, Adani are, they are people. He face every day up and down. Okay. और कोई issues? Last ventures. Very good. Physical assault. Yes. Road traffic accidents. Sexual assaults. Lack of awareness. No education. Exactly. And now I cannot see the screen. Excuse me. Yes? They don't have the rights. Correct, madam. Good point. Okay, so today our topic is rights and ethics of these people. Go to the next slide. So, limited access to the healthcare and problems getting enough food, trouble staying safe, violence, कोई भी violence or mob हो जाए, they ultimately street people or homeless people are become victimized. violence, stress, unsanitary living condition, exposure to the severe weather. Okay, so हम लोग इतना बारिश हो रहा है, इतना आंधी हो रहा है, हम लोग जस्ट कर्टन ओपन करके विंडो से हाँ ओ माय गॉड भगवान क्या हो गया, तो हम लोग तो अंदर है घर में, इतनी प्रोटेक्टेड है, वो लोग क्या करेगा, वो किस भगवान के पास जाएगा, है ना. So this is a seriousness of the problem. So there are so many issues. Today's main discussion is we need to talk health issues. Okay, so whether they are also facing the problem or they are facing more problem than us. Next slide. The health problems, what we have seen that whatever the major problems we are seeing like diabetes, hypertension, non-communicable diseases like communicable diseases like tuberculosis, malaria first of all, क्योंकि drainages, slum areas, these people are living nearby, so mosquito, dengue, chikungunya, whatever the vector-borne diseases are coming, it will be there in a homeless population. Okay, so moreover you have worm infestations, waterborne diseases, foodborne diseases, okay, milk-borne diseases, जो भी आप लोग health issues देखोगे वो सब homeless population में ज़्यादा मिलेगा. तो homeless people का medical care कैसा है? Medical care is pathetic because they don't have 10 rupees to pay for the OPD charges also. Okay, every time they go to the government hospitals, we know the government hospitals in our country and in our state, how पहले से बेहतर है. We can say that homeless individuals face numerous challenges when it comes to accessing the medical care. According to a study by the National Healthcare for Homeless Council, homeless individuals are 3 to 6 times more likely to become ill than housed individuals due to their living conditions and lack of access to the health care. कितने ज़्यादा हम लोग से ज़्यादा उनके पास प्रॉब्लम रहेगा 3 से 6 गुना. Okay, so unfortunately many homeless people do not seek medical care until their condition has become severe, which can lead to costly emergency room visits and hospitalization. So मैं आप मेरा एक्सपीरियंस बताऊंगा. I think last week मैं कानपुर में रहता हूँ. मेट्रो स्टेशन है उधर. मेट्रो स्टेशन के नीचे ये बहुत लोग रहते हैं मैक्सिमम. दिल्ली में आप लोग देखा होगा, लखनऊ में भी मेट्रो स्टेशन बहुत सारे, कोलकाता में है, ओके, बेंगलुरु में है. सो इतने ज़्यादा लोग रहते हैं. One lady was crying a lot and I don't know what, she was having a stomach ache. Her husband was there. People are moving, coming, going, nobody was taking care of, nobody was asking. So हम लोग इतना भी नीचे गिर गए क्योंकि हम सब बिजी हैं, इतने बिजी हैं. Even nowadays we can't able to concentrate on our problems which are occurring in the home. घर में भी कोई प्रॉब्लम हो रहा है तो we are postponing it. Why we are this much busy? Yes, मैडम बताया, बहुत अच्छा पॉइंट है. We are busy technically, we are busy technology. Okay, और महंगाई तो हर बढ़ता रहता है हर साल. हाँ, exactly. You come to the point. My point is ambition. We are becoming more and more ambitious. हम लोग और कम समय में और पैसे कमाएं, और ज़्यादा फेमस हो जाए, और ज़्यादा एक मोबाइल है तो दूसरा मोबाइल. ओके, सो वी आर नॉट लाइक, मैंने बहुत सारे मेरे स्टूडेंट्स को देखा, मैंने वो लोग काम करते हैं 6 घंटे 8 घंटे और उसके बाद डबल ड्यूटी करते हैं. मैंने बहुत सारे लखनऊ में डबल ड्यूटी में पहले हम देखते नहीं थे. डबल ड्यूटी होता है ना, सुबह आप लोग 7 बजे चले गए तो रात 12 बजे आते हैं. यार किस लिए करते हो इतना काम, है ना? अल्टीमेटली यू हैव टू सी योर हेल्थ, है ना? बाद में क्या हो जाएगा. So why we are doing this one? We are not understanding where we are going towards. Our generation is going towards somewhere. सब इसमें रेस में है, सबको फर्स्ट आना है. सबको फर्स्ट आना है तो कैसे होगा? किसी एक को आना है ना. So that is not possible. We have to see our limitations. We have to see our capability according to that one. So इसलिए मैं आपको एक चीज़ बताऊंगा. So आज आप लोग take home message क्या है ना, what is your capability, do that much. Okay, in winning the race, trying to do more and more things in a less and less time, ultimately we suffer more. Okay, so we have to see where is our interest, where is our attention, that only we can see. So coming back to the topic, unfortunately many homeless people do not seek the medical care until their condition has become severe, which can lead to costly emergency room visits, hospitalization. In addition to the physical barrier to accessing medical care, homeless individuals also face social and psychological barrier. Many homeless people have experienced trauma, abuse, making them hesitant to trust healthcare providers. They may also feel stigmatized, judged by healthcare providers, which can make them reluctant to seek care. To address these challenges, it is important to provide safe and welcoming medical environment that prioritize the dignity and respect to the homeless patients. So medical care is very, very like it's a star for them. मतलब star क्यों बोलते हैं हम? We can't able to catch it, है ना? तो तारे पर देखना है, बट मेडिकल केयर उनको देखने के लिए चीज है. वो लोग अंदर आए तो अलो भी नहीं करते हैं अंदर. ओके, तुम्हारा कार्ड दिखाओ, पर्चा दिखाओ, नहा के आओ. अरे पानी दे दो भैया, अच्छे से वो नहा के आएगा. Shelter दे दो. So we are not giving them a basic facilities and we are asking them to, because they are also used to that one. They also don't take care about themselves because the situation is that one. Okay, they are compromising with the situation. So this is the problem they are facing. Next. The importance of ethical medical decisions for these people. When it comes to making medical decisions for homeless individuals, ethics must play crucial role. It is essential to treat homeless patient with the dignity and respect. So हम करते हैं नहीं. क्यों? मैं बहुत examples देना चाहता हूँ क्योंकि time कम है, थोड़ा short कर रहा हूँ. Okay, so when I was studying in 4th year BSc nursing, we were having the OBG postings. अभी 3rd year में आया ना BSc. Okay, 4th year में हम लोग का OBG postings था. Morning night duty था. Night duty में OBG लेबर रूम्स में हम लोग का ड्यूटी लगाते थे. ओके, हाउ डॉक्टर्स वर ट्रीटिंग द होमलेस पीपल ड्यूरिंग द टाइम ऑफ डिलीवरी, द डिलीवरी टेबल दे वर बीटिंग. ओके, सो आपको कौन बताया 4-4, 5-5 बच्चे पैदा करने के लिए? बच्चे पैदा करके आप लोग गैरेज में भेजते हैं, मतलब आप लोग इधर उधर भेजते हैं. तो वी आर नॉट एट ऑल ट्रीटिंग देम लाइक अ ह्यूमन बीइंग्स. कम से कम एनिमल्स का भी हम वो रखते हैं. ओके, उससे भी नीचे देखते हैं हम लोग, क्योंकि होमलेस पीपल आर लाइक दे आर नोवेयर. ओके, सो नाल अता पता लापता. सो दिस इज द इशू, not one incidences, there are thousands, lakhs of cases. We can see that we are not giving the respect, dignity. They are also human beings. Okay, so आज से या कल से जब भी हम देखेंगे, थोड़ा रेस्पेक्ट देंगे नहीं? थोड़ा सा रेस्पेक्ट देना ही चाहिए, क्योंकि वो भी बनते हैं. It is essential to treat homeless patients with dignity and respect just as we would any other patient. However, this can be a challenging in a healthcare system that often stigmatize and marginalize homeless people. Ethical decision making can help us overcome these challenges and ensure that homeless patients receive the care they need and they deserve. By considering the unique circumstances of each individual and taking into account the social determinants of health, we can make more informed and compassionate medical decisions. We need many rules, regulations, policies that need to be changed in the healthcare and also healthcare delivery system, the country, the state, and everywhere. We need to change these policies. Okay, so next slide. When we see about the ethics of the homeless people, when we think of the homelessness, we often focus on the practical concern, lack of shelter, food and basic necessity. However, it's important to also consider the ethical implication of this issue. Homelessness raises questions about our society, values, priorities and how we treat those who are most vulnerable. One ethical consideration is that treatment of homeless people by the law enforcement and other authorities. So ये बहुत जरूरी है, because we are discriminating them. So law enforcement is required. Too often homeless individuals are criminalized for simply existing in public spaces. हम पार्क में देखते हैं, रेलवे स्टेशंस में देखते हैं. कानपुर कितने लोग गया? क्योंकि मैं कानपुर से आया हूँ इसलिए मैं बता रहा हूँ. मैं कभी इतना रेलवे स्टेशन देखा हूँ. More than 50 railway stations I have seen in my personal visits. कानपुर के स्टेशन के सामने कितने लोग सोते हैं, स्ट्रीट पीपल या होमलेस पीपल, वो कोई भी स्टेशन में देखा नहीं. आई डोंट नो, many other, maybe other states or places we are not visited, maybe they are more. Why? Because we are overpopulated, okay, and poverty. These are the major reasons. And लखनऊ में भी ऐसे है क्या? ऐसे है जी, because it is a hub of the labor forces and people coming, working, they will go back. In the meanwhile they will be staying, they don't take the hotels rooms, so they will be lying there only. So these things we have to see, and this is not only violates the basic human rights but also perpetuates the cycle of poverty and homelessness. Another consideration is the way we talk about and perceive homeless individual. Stigmatizing language and attitudes can lead to further marginalization and make it harder for these individuals to access the help they need. Next slide. So best practices for treating homeless patients, क्या कर सकते हैं हम लोग? One important best practice when working with homeless patient is to establish a trust and build rapport. कभी आप लोग vaccination के लिए, immunization के लिए, polio के लिए आप जाते हैं. So how many of you people participated in pulse polio immunization? तो तुम लोग नर्सिंग कर रहे हैं नहीं? डाउट हो रहा है. पल्स पोलियो वैक्सीनेशन प्रोग्राम में पार्टिसिपेट ही नहीं किया हम लोग. टीवी में, न्यूज़पेपर में देखा, वो भी नहीं किया. Very less people. I want to know once again how many people took participation in pulse polio immunization program. Raise your hands. 2% of the population in this auditorium are participated. हम लोग तो participate किया ना, आप लोग ने किया है, हम सब लोगों ने किया है. ओके, so हमारा इंटेंशन क्या होगा? जितना ज़्यादा लोग मिलेगा उतने ज़्यादा लोग को पोलियो पिलाएं. 2 बूंद सभी जिंदगी, सभी लोग के लिए है ना. ये सिर्फ घर वालों के लिए ऐसे नहीं, होमलेस पीपल के लिए भी होना चाहिए. So for that, how they will get the vaccine या immunization या treatment from you? As a nurse, as a medical profession, we have to establish us trust and build a rapport. We have to treat them like a human beings. They are also citizens of our country. Many homeless, Many homeless individuals have had negative experience with healthcare providers in the past, so it's important to take the time to listen to their concern and treat them with empathy and respect. This can help to create a more positive patient-provider relationship and encourage homeless individuals to seek out care when they need it. Another best practice is to provide care that is tailored to the unique needs of homeless patient. For example, many homeless individuals have complex medical needs and may require additional support in managing chronic conditions like diabetes or hypertension. You know, for diabetes, hypertension, frequently we need to visit the clinic and medicine we have to take. So it's a problem. We have to use the best practices. Healthcare providers can work with social workers and other community resources to ensure that homeless patients receive the care and support they need to manage their health effectively. Next slide. So with this, we have focused on homeless people, their problems. We have discussed the ethical considerations surrounding homelessness and the treatment of homeless individuals, and also medical practices, best practices, and many issues and rates and issues of the homeless people in our country, state, and other world. Next. So no one has ever become poor by giving. So we always should support, help, or care the people. We are chosen the best profession, that is nursing profession. So always we can give the care. Okay. So enjoying giving the care, enjoying in supporting them and helping them. Thank you.
Thank you, sir. Thank you so much. Sister Lily, what do you mean by the cultural competency as well as the cultural sensitivities and values? So please.
Good afternoon to everybody. I'm going to be tall. It's not that tall. I think all are fresh, energetic. After listening to sir, homeless people, we have to spend our energy, time helping them. We are always proud of our country, isn't it? What is the main speciality of our country, India? Unity in diversity. We are a country with the most diverse cultures, languages, customs, attitudes, dress, everything different. But when we come together, we enjoy unity as Indians. Sometimes I have heard of people talking, why all these Indians are there in the foreign countries, whereas other country people are not doing much in India. What may be the reason? I feel one basic reason is we have got that inborn capacity to adjust with different cultures, with the different living situations, with the different forms of their languages or dress or food or habits. The Indians have got an inborn capability of adjusting to all these situations. That may be the reason many of our Indians are going abroad and sustains there. When from the time we were exposed to the society or when we started going to school, we are taught to say the pledge, India is my country, all Indians are my brothers and sisters. We used to repeat it. And we always sing nationals, our Rashtriya Gan, our national song, national anthem, Punjab, Sindh, Gujarat, Tamil. Ourselves we are repeating, though we are different from Punjab to Kanyakumari, different languages, different states, different food, but we all are one. So we can also expect different state people, people with the different cultures, food, habits, dress, etc. coming to our hospitals or for our nursing care in different hospitals or nursing care settings. So what do you mean by cultural competence? One of the dire need we need to have, we nurses to have, if you want to give efficient care or good nursing care to our patients. By definition, cultural competence, that is the ability of a person to effectively interact or communicate or work with or develop meaningful relationships with people of various cultural backgrounds. People from different cultural background means different beliefs, different customs and behaviors of people from various groups. Cultural competence, next slide please. Cultural competence is the ability which we acquire, which we need to acquire. How can you develop cultural competence? One is by becoming aware of cultural differences. Our own cultural differences, personal cultural differences, we are all unique. I differ from the other person in various things. Maybe my form of thinking, my attitude, my behavior, my language, my culture, or in villages or in other countries. We should have the capacity to admire or accept diversity of values. The value which I have in India may not be the value of people those who are abroad. The value of which I have in my own native place may not be the value which we have in the other state. So we have to accept and acknowledge that diversity. This from that state, in that state. So for example, the way we address each other, way we different. Some say good morning, some say namaste. The language is different, the sign is different. So that depends upon the place where I am coming from. Nothing is bad, nothing is exceptional, but all are good. We have to accept. It is worry. Next is self-assessment. I have to assess, I have to examine myself. Am I agreeing or am I accepting that diversity of people? People are different. The uniqueness of each individual. I accept my own uniqueness, but coming to the uniqueness of others, am I aware of the uniqueness and accept him or her? Next is the management of dynamic difference. We have to develop how to talk to people of different nationality, how to address them. How can we get it in, even in our wards, people may be admitted from other states or other countries. How I can adjust with them in the language, the style of their food, their mannerisms, the way they relate to the people. As a nurse, as a competent nurse, I will try my level best to understand from them or get that knowledge from themselves by asking them in a different way or with a sign language to get it from them so that I will be able to understand their needs, their ambitions or their necessities, and I will be able to care for them sufficiently. Then institutions also have got a responsibility to opt for the accepting the cultures of different states or countries or form the policies, rules or regulations of that particular institution or the hospital, even the college of nursing. Now many students are joining us from foreign countries or from our own country, from different states. There also we need to have some policies, some rules, regulations, where all of the students, all the members can enjoy the freedom of being themselves, being their own. There can be a common language, there can be a common custom, but all customs and languages and their beliefs or their policies are to be acknowledged or accepted one way or another. So our policies are formulation of rules and regulations or timetable that should consider the very diversity of culture and competencies of the people. Then next slide please. Cultural competence will enable the individuals to respect and appreciate the diversity of human experiences and work towards creating an inclusive environment. Inclusive means inclusive of all types of people, all languages, all culture. So that's a need of the time. We have to have an inclusive culture in our own institutions, even our own small communities, or in our own working situations, or in the hospitals, wherever we are. We have to develop an inclusive environment, including all types of people. Then culturally competent practitioners, nurse practitioners, they will have a sensitivity also. Sensitivity means cultural sensitivity is being aware of, which I was talking about. Aware that cultural differences and similarities between people exist. We can't stop it. It exists without assigning them, but it is our responsibility not to say that this culture is good, the other one is not good. This one is positive, other one is negative. No no values are added to the cultures in the terms of positive, negative, accepted, not accepted, accepted. We have to have a sensitive for unique cultures and behaviors of people. We are not to decide right or wrong, that's why. It has got every culture, every behavior, every language has got its own positive as well as some negative values are there. But we have to take it as a total, inclusively. So a culturally competent nurse, next one. Cultural sensitivity or talked of. Cultural sensitivity is important in fostering a cohesive, peaceful society. Usually, people differ in a large group, they make small groups within. even in our nursing boardings or in our nursing schools. People, they have got a liking for people of same culture, same language, same place, making a small groups. But that will cause division sometimes among the society. So if you want to have a group of our students or community together, we have to bring them or take them along with us. We have to have an inclusive vision, including accepting all the communities, all the cultures, languages, keeping the need of a common one. When we come together, we can have a common language, common style of food. But other places or other chances, people may be allowed to be free, to be with their own languages, their own customs, their own habits, etc. Next slide, please. The definition of cultural sensitivity is having an understanding of another person's set of beliefs or values that is attributed to the person's ethnic or racial background. We were talking about that. In addition, an individual must be agreeable to modify their behavior to accommodate the other person's cultural belief. That openness should be there to accept the other person's also, their cultures, their behavior, and we must understand them. Why do they behave like that? Why do they say, or even the nodding of the head is different in different cultures. One may say yes like this, one may say yes like this. Difference is there. Once we understand them, we will be able to accept and include them in our groups or communities. Then next slide, please. Diversity. As we in India is a country of diverse, as we have talked of languages, food, customs, beliefs, everything is diverse. But diversity has got a lot of advantages. Suppose that we all were all in this hall. We have got male, female, different people, different race, different language people are there, state people are there. If all were of same cultures, same language, same jali, there won't be any beauty in that. When cloning was started, people are wondering. You remember, cloning was there. No? Cloning, after cloning, whatever the offspring come, mostly of the same nature of it. So people were wondering whether after a few years, in our country, same types of people will be there with the same structure, same height. So, even in a garden, when we go, we look for variety of flowers, variety of these fruits. So variety is the beauty. So diversity that is present in our country, that is the original beauty of our country. But amidst these diversities, we have to have one harmonious development, harmonious unity, or harmonious belongingness to one another. So what are the advantages of diversity? Next slide, please. Diversity enhances creativity and innovation. Enhances creativity and innovation means when diverse nature people are there, when two people are different, then when we are tempted. Suppose that two people are wearing two different dresses. So the other person, oh, this one is very good. It looks very elegant. So she will be tempted. She will have an interest to adopt that dress. No matter whether it is in their place or from a foreign country. But and also innovation, we find out how to bring it up, especially of the cultures. Some culture in the countries. For example, in the culture of South Indian culture is one of the culture of the South India is wherever you enter a home, whenever you enter a home, we say namaste, namaste to everybody. So seeing each person in the house, we say namaste, not simply namaste, but with the hands folded, namaste. That means not only that we are welcoming them, we are welcoming in the name of God. We accept them because we believe that we all are created in the image and likeness of one God. So we are brothers and sisters to one another. So that culture is very good. So people also see that culture tend to imitate it. when they go to different places also. Now in this UP also, many people greet with Namaste. This is it is becoming a common form of wishing someone. Then second is, it helps us to better decision making. Different types of people are there in a community or in a group for group discussion. Different ideas will come. So we will have in-depth knowledge of that particular subject. Each person will express their own ideas and we can have a better opinion, better decision at the end. Because we can look at that same problem from different angles, different person's views. So we get a broader insight and we can have a better decision making. That is, it encourages learning and personal growth. When those who have stayed in the hostels with the people, all the students from different areas, you may remember the days you spent in the hostel and you have learned many things from your classmates or those whom you are living with. Good habits, good behavior patterns that you learn. It helps to have more learning and we grow in a better personality. Then improved performance also. Research has shown that when many researchers have done the research on this diversity of people, and they have shown that when people are from different diverse areas, they have got diverse way of thinking, and the fruit of the research or the fruit of that effort is always beyond our imagination. But it has got a tremendous effect on the fruit of that particular work. Or we get a good result after that particular work. Because people look from different angles, they have got different capacity to do. For example, we are decorating in this auditorium itself. When you are decorating the auditorium, people have got different talents, different way of doing it. So one day they contribute together and then we have got a better performance. Next is, it enhances adaptability and resilience. By living with the different people of different places or different areas, we get that ability to adjust with. We have to adjust, we need to adjust. Some people do not take food, but some people take with the hand, some people take the spoon and fork, some people use only spoon, some people use only fork. So different cultures we see, but we get an ability to adjust with. So adaptability, adjustability will improve. Then we also have overall social justice, economic benefits are there, social justice and equity also. People are considered in front of law. The Indian Penal Code, the law says that all Indians are equal in front of law. Indian Penal Code gives us that assurance. Even if we are from different states, different language, different culture, we are equal in front of the law. That equity that enables us to be strong in our character, strong in our dedication to the country, strong in our personal informatics and social responsibility. That one of the best advantage of diversity. It also helps us to have social justice out of the slide, please. Then organization, as I have talked of, this cultural competence enables us to have good human experiences and work towards including creating an inclusive environment. There are two more terms I want to say. One is culturally sensitive, cultural responsibility I have talked of. Cultural competence I have talked of. One is another term used is cultural sensitive. Culturally sensitive means we possess the basic knowledge and constructive attitude towards diverse cultural populations. We have got minimum knowledge, what are the different cultures of different people or different states. And we have got a basic attitude of tolerance or accepting them in our own personal experiences. Another word usually used is culturally appropriate. Culturally appropriate means applying our underlying background or our knowledge to suit to the needs of the people. It's very much needed for the nurses when we are working with the different types of people, whether in the educational departments or in the hospital or in the community health settings, we have to have appropriate behavior towards the people of different language, different culture. As sir was talking about the homeless people, they also may be from different backgrounds, different culture, different attitude. How we can approach them, how we can show appropriate behavior to them, how we can accept them, how we can be even if we won't be able to accept them as they are, we can have a approachability to them. How can we meet them, talk to them, attend to their needs, so that is culturally appropriate behavior. That's what we intend of it. Then one more thing I just wanted to mention, and then we'll go. What are the levels of cultural competence we can have? One is we can acknowledge from outside. That's the first level. We acknowledge you are unique, I am unique, I have got a different culture, you have got a different culture. I accept you. But nothing we may not go in. We try to avoid them. That's the first level. We accept. Second level is we understand them from their own background. As sir was saying, we will develop the empathy, or we will develop the standing on others' foot. We try to, and we will have the ability to accept them. Third level is we get energized, because I have gone to this place, I have gone to that, I know the culture of that country, I know the culture of this state. So I have got a self-confidence. I can go out. I will be able to go out to the different states, even abroad. I will develop that self-confidence. I will be able to adjust to their culture, adjust their language. I can be safe over there. I will learn it. Then finally, with the diverse culture and attitude, our own personalities will go into a broad spectrum of broad personality, which has got a chance, or which has got a place for each human person, which whom I contact with. Or in other words, we will have a generous heart, and we have a magnificent personality, accepting each and every one those who come to us. End of the session of cultural sensitivity. If you have got any doubts, we will give to us.
Thank you so much, Sister Lily. Excellent. Any challenges you are facing? What all? Please, let me know, please. Any challenges you are facing? जोर से बोलो. हाँ बोलिए please. I think you don't have any challenge. बोलो. Please. Any challenges you are facing? Yes? I think I would like to ask the question. Please you tell me. हाँ जी sir.
But it is related to nurses only.
Okay sir.
चैलेंज क्या है? हर नर्स अपनी ड्यूटी से रिलीव होना चाहती है.
Exactly sir.
बट जिसने रिलीव करा है वो आना नहीं चाहता. तो रिलीव कैसे हो गई? नॉर्मली व्हाट इज द प्रैक्टिस कि ये आपस में सेटिंग कर लेते हैं. 4 दिन मैं डबल कर लेता हूँ, तू मजे कर. 4 दिन तू डबल कर लेना, मैं मजे कर लूँगा. So this is the challenge before the hospitals. कि how hospital can relieve you until unless reliever is not there. ऐसा नहीं है कि लोग कम हैं इसलिए reliever नहीं है. अगर लोग कम हैं तो reliever नहीं है, तो that is the mistake of the hospital.
Sir, I would like to give answer regarding this, as you have talked about relieving, and we nurses should tell you hand over your patient to the next shift sister. We are not supposed to leave the patient, and if it is in a practice, there may be any legal issue may arise. Because sometimes, particularly because I wanted to share my own experience when I worked as a staff nurse in the clinical areas. So one patient was there It is about the patient as well as about one peon, means like what boy we used to call them. So that thing I would like to tell. I was a sister in charge. I was a staff nurse, not sister in charge, and I was in a night shift. And one of my colleague, he was a peon over there, and he asked me, sister, I want you to go home, and please you give me 2 hours leave in the morning. And he wanted to leave at 6 o'clock, whereas he was supposed to finish his duty at 8 o'clock. And what has happened? He told कि I am having some work at home. Please sister, आप दे दो, काम तो सारा खत्म हो चुका है, and दे दो. So I am very humble and kind, but as well as I am very strict also. And I told him कि okay, कोई बात नहीं, मैं आपको छुट्टी दे देती हूँ, and you have to go by bus from this place to that place. And you write an application, and you write on it कि 2 hours before you kindly give me the leave. I have permitted them. And above all, there is a sister in charge. What sister? I didn't intimate. He told me don't intimate to sister. And likewise, then tomorrow I will work up to 8 o'clock. Then I said no, that I cannot do because I had to inform to sister. Doesn't matter. I am giving you 2 hours before. And what incident has taken place? Can you imagine? What has happened? He has taken bus. And after maybe 4 or 5 kilometers, if anybody has heard about, from Shimla to Tara Devi, and he wanted to go to Gandalghat, only 25 kilometer journey. And when he started from Shimla to Gandalghat, in between after 3-4 kilometers, he met an accident. Bus accident took place and he died there itself. Can you think how major issue it is? On duty, you cannot leave patient because there are various types of patients are there. COPD patients are there. COPD patients are likewise. If any serious patients are there, you are talking with them. Many times it happens in the ward with us. For 16 years, I have worked in clinicals. I didn't become professor like this only. But thing is that we were very much committed. We never left patient until we hand over the that patient to the next shift sister. So this is, I am very sorry if it is happening, and any ethical issue may arise. And for suggestion sir, आपके लिए अगर कोई भी sister इस तरह से करते हैं, आप अपना एक notification निकाल सकते हो अपनी तरफ से कि अगर उनके duty time में it is their responsibility कि if anything happens after 8 o'clock, before 8 o'clock, तो जो भी कोई वो लोग वहाँ पे आ रहे हैं shift staff, so it is their responsibility. They will be answerable. Any COPD patient, you turn back और पीछे से patient को respiratory arrest हो जाता है and patient एकदम से death. And sometimes patient is sleeping and while sleeping patient will die. So this thing should not happen, my dear students. जब भी आप ड्यूटी करते हो तो आप रिक्वेस्ट कर लो नेक्स्ट शिफ्ट वाली ड्यूटी से कि आप थोड़ा जल्दी आओ, मुझे जल्दी जाना है. गिव प्रॉपर हैंडओवर, एंड ऑलवेज हैंडओवर मींस इट इज बेड टू बेड हैंडओवर, पेशेंट टू पेशेंट. It is not like that कि if you are taking care of 40 patients, because it is not in our practice, sir. I am sorry कि if anyone is doing like this. Okay? So ethical issues and legal issues, Madam has talked so much about this, and all the panelists has talked a lot about the ethical and legal issues. So always be careful about that, because nowadays people are very much aware because of this high tech. Okay? You understood, students? Yes, sure? Yes, will you do such practices how sir has told? Whether you are doing such practices? Yes. So no sound is coming means yes, you people are doing like that. You are not supposed to do, promise. Okay? And next, another thing I am asking from you, like one topic was there which was dealt by Madam Rashmi. Yes, sir. Yes, sir.
Express. So on behalf of my students, I would like to. I don't want any long answer.
Yes, sir.
I know the answers also.
Yes, sir.
Because personally I feel about the nurses, The main challenge, one is the long shift.
Yes, sir.
Everybody knows. Then changing schedule. Sometimes they are doing night duty for 3-4 days. Next day they are telling now you have to come to morning also. So changing schedule also, I think they must agree it is also a problem. Then technologies are changing day by day. So to cope up with the technology is also a challenge for the nurse.
Yes, sir. This is a challenge.
Sometimes they have very poor treatment from the patients also, patient and their wards. So they have to bear with that because they cannot behave like that. What that? These are the challenges. Even there are many challenges from physical demand. They have to shift them. They have to do the physical work. They also need to do. Even they are exposed to the illness and chemical hazard. So I think there are many challenges. And they have to cope up with all those challenges, and I think our students know this, but I think they are not able to explain these things, what are the challenges. And these are the basic challenges, and each and every nurse will face it sometime or other in any hospital. And they have to develop the idea how to cope up with those challenges. That I
Yes,
want to tell on behalf of our.
See, sir, so long shift duty regarding this, there should be an internal management, how you do. Because when we were students, we used to do night duty for 1 month. And in the morning, our night duty is from 8 to 8 in the morning. And thereafter then we used to go to the classes. And regularly we used to attend the classes. But now I must say, in case if such things are happening, and whatever practice, it depends upon individual as well as hospital to hospital practices. Is it, sir? Because it depends upon internal management. So in case if internal management means there should be it is a reciprocal. Because if people are behaving like that, as you told, like they wanted to take extra work from the students. So such things, for that means we should be very much assertive. Assertiveness is very important, and for that, like I am a teacher, my students are going to the clinicals, so I am having very good rapport with the sister in charges as well as entire team. So always I used to give them instruction कि ये पहले वाला वक्त नहीं है जब हम थे कि limited syllabus था और इस तरह से होता था. तो I used to give responsibility to the sister in charges itself कि आपने मेरे बच्चों का भी ध्यान रखना है और इनको कोई भी इस तरह से ऐसी चीज नहीं होनी चाहिए कि इनको बुरा लगे. आप काम लो, इनसे काम करवाओ, but don't speak harsh. Wherever they are wrong, you just bring in my notice. I will deal with my students. But in our practices are like that, sir. कि in case if any issues arise, so student will not fight, student will not do any bahas with the other. Directly they will let us know, means they will communicate with us, and we will, in case if some major issues are there, so we will go to the higher authority, those who are above us, and then we will have a meeting and then we will resolve the problems. Okay? So I think you all students can do that. In case you are facing any problems, be assertive. Be assertive. There should not be any discrimination with our students as well as our staff. In case if anything happens, don't feel shy. Okay? Directly you come to your madam. Means आपके clinical instructor होते हैं आपके साथ? होते हैं ना? हाँ, वो इसीलिए होते हैं कि in case you stuck up somewhere, so you just put forward. You tell to madam कि madam this problem I am facing, and one important thing always you remember, be assertive. If you people are assertive, so nothing can go wrong. Be assertive. Assertive का मतलब होता है आपको पता होना चाहिए आपके साथ क्या गलत हो रहा है, क्या सही हो रहा है. And whenever any drug you give to the patient, anything, for any small thing, in case if you feel like that it is not clear to you, so always you have to ask your teacher, you have to ask concerned, there is a sister होती है वहाँ, what sister होते हैं. अगर आपको clear नहीं है तो best approach is teacher. You ask the teacher because there are so many errors taking place. मैं एक आपको example बताती हूँ because बहुत सारे example हैं. I am having thousands of examples. One example I will let you know. पोटाशियम होता है, पोटाशियम क्लोराइड, पर हम जल्दबाजी में कह देते हैं कि बेटा इसका पोटाशियम ठीक करना है, जाओ पोटाशियम लेके आओ और इसको लगा दो. This is a right message? It is not right message because nowadays everyone becomes so high tech
कि वो अगले वाले को समझ ही नहीं आता है कि व्हाट दे सेड। पर हमारे टाइम में क्या होता था कि सिस्टर इंचार्ज जो भी होते थे, बेटा इधर आओ, ये पेशेंट का इलेक्ट्रोलाइट इम्बैलेंस हो गया है, उसमें हमें पोटाशियम को करेक्ट करना है, एंड सी दिस इज अ पोटाशियम क्लोराइड, आपने इसको 10 ml की सिरिंज में लेना है, एंड टेक 1 सलाइन की बोतल और उसमें उसको डालो और स्लो इसको दे दो पेशेंट को। तो लाइक दैट उनको पेशेंस था, बट नाउ अ डेज वो सुपरफिशियल, दिस इज अ कम्युनिकेशन गैप। सो व्हेन दैट कम्युनिकेशन गैप विल बी देयर, स्टूडेंट क्या करते हैं, ऐसा हुआ है, and I am not insulting my hospital, I love my hospital institute, it happens in our institute because of lack of communication, and one more thing I can say, because of shy or maybe because of attitude over it is sir shy की attitude कि because आजकल के बच्चों आप माइंड मत करना, आजकल के बच्चे ऐसे हैं सर कि we are from science background and this attitude is there, so patient का केयर करना है, we all are a team member and we have only one goal and it is patient, और patient जब हम लोगों का गोल है तो we are working for the same goal, so why these things are happening if it is not clear। ज़्यादा से ज़्यादा क्या होगा, अगर किसी सिस्टर ने आपको बोला कि जाओ बेटा इंजेक्शन पोटेशियम लेके आओ, पेशेंट को दे दो और ऐसे कर दो, आप सोचो उसके बारे में, जब आपको समझ ही नहीं आया, डोंट डू, बी असर्टिव, मुझे नहीं करना है, मुझे समझ ही नहीं आया। ज़्यादा से ज़्यादा क्या होगा, सिस्टर आएगी और आपको डांट लगाएगी, 4 बातें बोलेगी, बेटा आपने क्यों नहीं किया, तुमने ऐसे वैसे, थोड़ा अपना गुस्सा शो करेंगे, गुस्सा शो करके चलो मैं खुद ही कर लेती हूँ, इट इज़ बेटर टॉलरेट दिस थिंग बट डोंट डू एनीथिंग रॉन्ग। इस तरह से हुआ था, जो बात मैं आपको बता रही हूँ, ऐसे ही एक सिस्टर को बोला था, जूनियर सिस्टर को, उन्होंने फटाफट इंजेक्शन निकाला एंड पेशेंट को पुश किया एंड पेशेंट डाइड देयर इटसेल्फ, विद इन अ सेकंड पेशेंट डाइड। सो जब भी आपको इंजेक्शन देना है, कुछ भी करना है, फर्स्ट यू रीड प्रॉपरली, आप प्रिस्क्रिप्शन देखो क्या लिखा है क्या नहीं लिखा है, कैसे देना है, आप समझ भी जाते हो, देयर आफ्टर अगेन यू आस्क और यू ईट द ब्रेन ऑफ योर टीचर, जितना ले खा सकते हो खाओ, डजंट मैटर, बट डोंट डू एनीथिंग रॉन्ग, ओके। जब भी आपने कभी ऐसा करना है तो आपने कभी भी पूछने से डरना नहीं है, समझ गए? हाँ, जो भी करना है बी असर्टिव, और डरने की कोई बात नहीं है, आप पूछो, टीचर इसीलिए होते हैं। एनीथिंग एल्स, एनीथिंग एल्स? और दूसरी चीज मैं हमेशा अपने स्टूडेंट को बताती हूँ, आप गलती कभी भी नहीं कर सकते हो। जी सर, जी सर।
Emotional involvement, and if you have emotional involvement with any patient and something happens to patient, then you carry that for a long time, and it may affect your health also and your psychology also. So how to come over this? The student need to know this.
देखो बच्चों, एक चीज होती है, आप लोगों ने थ्योरी पढ़ी, तो पेप्लोस थ्योरी में उसमें 4 तरह की फेजेस बताई गई है। व्हाट आर दोस? क्या क्या है उसमें? 4 चीजें बताई गई है। सबसे पहले पेशेंट आता है तो पेशेंट के साथ हम लोगों का कम्युनिकेशन होता है, तो हम उनके साथ अपना IPR अच्छा डेवलप करते हैं कि नहीं? वो क्यों करते हैं? उसको अच्छा एनवायरनमेंट देने के लिए, बिकॉज ही केम इन अ न्यू एनवायरनमेंट, एज वेल एज पेशेंट इज वेरी मच स्केयर्ड। हॉस्पिटल का एनवायरनमेंट देख के हमें भी डर लगता है, ओके। सो हम उनके साथ अच्छा डेवलप करते हैं IPR, एंड देयर आफ्टर व्हाट वी डू, क्योंकि हम अच्छा एनवायरनमेंट डेवलप करके अच्छा कम्युनिकेट उसके साथ करते हैं, व्हाई वी डू, ताकि वो सारी चीज़ों को एक्सप्लोर करें कि व्हाट इज हैपनिंग, बिकॉज वेरियस टाइप्स ऑफ पेशेंट्स वी आर डीलिंग विद। तो हम उनके साथ इस तरह से करते हैं। तब क्या होता है, जब हम उनकी केयर करते हैं, दैट फेज इज देयर, देन वी कैरी ऑन आवर केयर, एंड देन पेशेंट नर्स रिलेशनशिप इज स्ट्रॉन्ग। व्हाई इट इज स्ट्रॉन्ग? वो तब तक स्ट्रॉन्ग है जब तक हमें उनको केयर देना है, लेकिन जब पेशेंट चला जाता है उसके बाद क्या होता है, कौन सी फेज आती है? टर्मिनेशन ऑफ आवर रिलेशनशिप। देयर इज अ टर्मिनेशन ऑफ रिलेशनशिप। तो टर्मिनेशन में क्या होता है कि आप उनको अच्छे से नमस्ते कर दो, उनको जो भी हमें डिस्चार्ज एडवाइस देना है, डिस्चार्ज एडवाइस दो, और उनसे कहो कि आपने अच्छे से अपना ध्यान रखना है, आपको फॉलो अप करने आना है, सारा कुछ करना है। देयर इज नथिंग लाइक इमोशनली वी शुड अटैच विद द पेशेंट। हमें कौन सा उनके साथ रिश्तेदारी निभानी है? No, na professional relationship, therapeutic touch, it is very important. So that thing we have to make ourselves strong. Relationship जो रहे long last रहना चाहिए, वो आपका प्रोफेशनल रिलेशनशिप लॉन्ग लास्ट क्या रहना चाहिए कि आई एम वेरी सेटिस्फाइड, एटलीस्ट आई कम्युनिकेटेड विद द पेशेंट सो वेल, और मेरे थेराप्यूटिक टच देने से, मेरे अपना इतना अच्छा रिलेशन डेवलप करने से माई पेशेंट इज ऑल राइट. सो दैट सेटिस्फैक्शन ईच इंडिविजुअल मस्ट हैव. ठीक है, वो इस तरह से रिलेशन बना के कोई ज़रूरत नहीं है कि हम उनके साथ ज़िंदगी भर चलने का प्रॉमिस करें. देयर इज़ नथिंग टू डू विद दैट. Because every day new patients are coming, going, doesn't matter. हमने भी लाखों पेशेंट्स देख लिए होंगे, लेकिन ऐसा कभी नहीं हुआ कि हाँ इतना ज़्यादा ऐसा करके वो रिलेशन बनाने की ज़रूरत हो. तो डोंट बी इमोशनल, यू पीपल आर स्मॉल, यू पीपल आर किड्स, बी मैच्योर. Because when we are able to take care of patients, it means that maturity should reflect through your behavior. That childish behavior should not reflect. Okay? Means we should have empathy. Treat each individual as if they belongs to your family. And the moment you will think about that patient as if they belongs to your family, so definitely 101% I must say patient will be all right. Okay? Because अगर मैं अपने life experiences बताऊंगी, so there is one big book. I don't want to waste the time because already there is a shortage of time. But just to inspire you people, just to motivate you people, I just would like to tell you. Anything else, sir? Okay. And अच्छा, एक हम लोगों ने डिस्कस किया था, जो सर ने किया था, नवीन सर ने, about the homeless people के बारे में. As we nursing personnel, we are dealing with the people, those who are coming to the hospital, they are homeless in detail. Sir has already told about. So homeless people के बारे में अगर मैं आप लोगों से एक क्वेश्चन पूछती हूँ कि you are in a night duty and somewhere in a PHC or somewhere, और आपके पास कोई इस तरह का पेशेंट आता है, अपने आप ही कोई गांव पड़ोस के लोग उसको लेके आ जाते हैं कि इसका कोई नहीं है, आप इसको देखो, आप ट्रीट करो, सिस्टर पेशेंट मर रहा है, आप इसकी जान बचाओ, व्हाट विल यू डू? आपने नाइट ड्यूटी की है ना? कभी ऐसा इंसिडेंट हुआ? जैसा सर ने बताया कि यहाँ बहुत सारे होमलेस लोग हैं, कोई तो आया होगा कभी? अच्छा, अगर नहीं आया तो आप क्या करोगे? बिल्कुल असर्टिव होके बोलो, गलती बोलोगे और क्या होगा? Whatever you feel, you should be dear enough to speak out. Please you tell me. जल्दी से raise your hand. Who will tell? Anyone? Please, one person, कोई तो बोलो. आप लोग बॉयज लोग बताओ, कोई क्या करोगे आप? क्या करोगे? लीगल, एथिकल एंड लीगल इश्यूज, इट इज डिस्कस्ड ऑलरेडी. क्या करोगे आप? एक पर्सन जल्दी से बोलो, देन वी विल फाइंड आउट. कोई बोल रहा है? इट मीन्स आप कुछ बोलना ही नहीं चाहते हो. बोलो, आप लोग सभी दे सकते हो इसका आंसर, बोलो. ओके, एनीवे आई विल टेल. होमलेस पीपल का क्या रहता है कि whenever any admissions comes और उनके साथ कोई भी नहीं आता है, why we are asking relation कि हाँ आपके ये पेशेंट क्या लगते हैं, आप इनको जानते हो कि नहीं जानते हो? ठीक है, तो वो कहेंगे जी हम तो एक समाज सेवा कर रहे हैं, हम लेके आए हैं, पेशेंट वॉज देयर, एज सर हैज टोल्ड कि उनको कोई केयर नहीं करता है और हम लोग उनको बॉदर नहीं करते हैं. दैट इशू इज देयर बिकॉज आजकल किसी को टच करना खतरे से खाली नहीं है. अदरवाइज सर ने ठीक बोला, लेकिन अगर हम में इतनी कर्टसी है, इतनी पैथी है, हम लेके आ ही जाते हैं, तो ऑलवेज यू आर सपोज टू इन्फॉर्म योर हायर अथॉरिटी एंड आफ्टर हायर अथॉरिटी वी शुड इंटीमेट टू द पुलिस. ओके, मेडिको लीगल केस बनता है वो, तो वी आर सपोज टू इन्फॉर्म टू द पुलिस एंड when they are coming along with police, if patient is coming, then you do care, fully you take care of patient, because now that case is in the hand of police. Okay, and whatever medico legal cases are there और उनका फाइल होती है, उनका जितना भी रिकॉर्ड्स होता है, it is always under lock and key. So you are not supposed to show this record to to the patient as well as to their attendants. Okay? समझ आया कि नहीं?
Yes, ma'am.
Thank God. Okay, so now one more small thing I wanted to tell. As Sir has talked about Mother Teresa. Okay, have you heard Sir has talked something about Mother Teresa? So I just wanted to share one small thing of my experience about Mother Teresa. I did my specialization in cardiovascular thoracic and it is from B.M. Birla Heart Institute, Kolkata. और मदर टेरेसा कहाँ की थी? कहाँ रहते थे मदर टेरेसा? जोर से बोलो। कोलकाता में। वो कोलकाता में रहते थे. धर्मतला was the place where she used to reside. And I am so happy and fortunate, and that time was the turning point of my life when I was under that training. So I was doing my specialization in cardiovascular thoracic. So what has happened as a nurse, when I didn't know that Mother Teresa, जिनके बारे में हम books में पढ़ते हैं कि वो एक patient होंगी and I will be the caretaker. So I took care of Mother Teresa by seeing my dedication by the dean of that institute. Mother Teresa was allocated to me and I am so fortunate. I served her for 17 days. I served her for 17 days when she was admitted in B.M. Birla Heart Institute, Kolkata. So can you think how I was? I was shivering like anything because I studied from a very small school जहाँ पे हम बैठने के लिए भी खुद अपने पटड़े लेके जाते थे. Okay? And after that when I studied from a small institute, and when that big shot, this much big international personality was being allocated to me, I just cried. मैंने रोना शुरू कर दिया कि how I will touch. I have just gone through in the book कि Mother Teresa is something, Mother Teresa that and that. Something I used to read कि क्या ये वही Mother Teresa, and very innocently I used to ask one madam. Her name was Madam Nirmala Yadav. She was from here only, from UP. I used to ask very innocently कि मैम ये वही मदर टेरेसा हैं जिनके बारे में हम किताब में पढ़ते हैं, क्या मैं इनको टच कर सकती हूँ कि यस सुनीता, यू आर सो लकी, यू आर गेटिंग दिस पेशेंट. ऑल द सिस्टर्स दे आर सो क्यूरियस कि हमें ये पेशेंट मिलनी चाहिए, वी शुड गेट अ चांस. एंड लॉट ऑफ मोटिवेशन शी डिड एंड देयर आफ्टर आई कुड टेक केयर ऑफ मदर टेरेसा. वो भी तब मैडम से कहा कि मैम आई विल डू एवरीथिंग बट प्लीज यू बी देयर बिसाइड द पेशेंट अलोंग विद मी. ओके, सो only thing is that whenever you have to take care, आप empathy के बारे में हम the day first onward we are talking about empathy, तो आपने empathy को कभी नहीं भूलना है. आपने उनको ये समझना है कि जैसे हर कोई मरीज, चाहे वो कोई भी हो, किसी भी कास्ट से हो, किसी भी क्रीड से हो, किसी भी नेशनैलिटी से हो, कहीं से भी हो, आपके लिए तो पेशेंट है and you are nurse and patient is patient. आपको उनको ऐसे देखना है कि as if they belongs to your family and then you take care and then you see the result. There will be a wonders on wonders. ठीक है, आपने इस तरह से केयर करनी है. Be passionate towards your nursing. Okay? कभी भी गलत नहीं करना है. दो बातें जरूर याद रखनी है. Because जो errors होते हैं, error 2-3 वजह से होते हैं. Number 1 is overconfidence. Number 2 is shy. Number 3 is attitude. And 4 is lack of knowledge. बाकी कोई reason नहीं रहता है. Attitude कभी लाओ ही मत. बिकॉज वो सारे जो भी कोई पेशेंट आते हैं वो हमारे अपने घर से ही होते हैं. तो आप लोगों ने जब भी केयर करना है, डू इट प्रॉपरली. क्लियर? ओके, सो नाउ आई विल कंक्लूड. नर्सिंग इज अ डायनामिक बाय इट्स ओन वे. इट गिव्स राइज टुवर्ड्स ट्रेंड्स. द ट्रेंड्स इन नर्सिंग एजुकेशन एंड प्रैक्टिस आर द कॉर्नरस्टोन्स फॉर द डायनामिक नेचर ऑफ नर्सिंग प्रोफेशन. The trends influencing nursing practice reflect the evolving trends of healthcare. These trends shape the future of nursing. It is crucial for nurses to embrace these changes continually, update their skills, and adapt to the needs of diverse patients. By staying at the forefront of these trends, nurses can provide high quality care and positively impact on the health and well-being of the individuals and communities. So at the end, I would like to conclude with this, and I thank all the panel people, Dr. Alka Saxena ma'am, and Dr. Rashmi, and Sir Naveen sir, and Sister Lily. Thank you very much. And once more, I would like to thank the principal, Madam Deepti Shukla, to give this opportunity to me in the international conference. And I would like to thank the director of Samarpan Institute and director of which college? Pushpanjali College of Nursing, Agra sir, and entire faculty members as well as organizers and all the students, loving students, and best wishes to all of you. And this conference, it was really wonderful and very well organized, and thank you so much. Sorry sir. Sir, I am fortunate. Thank you so much, sir. Thank you so much. It is an honor for me, sir. Thank you so much.
Now, I would, without any further delay, I would invite Director of Samarpan Group, Dr. V.P. Tiwari sir, and also Director of Pushpanjali College of Nursing, Mr. Rajesh Gupta sir. So please kindly come on and dais and felicitate our
फेलिसिटेशन के पहले मैं समर्पण ग्रुप के तरीके से सभी पैनलिस्ट को धन्यवाद देना चाहता हूँ, इसलिए मैंने ना बुलाने के बावजूद ही माइक पर पकड़ लिया। मैं फॉर्चुनेट हूँ कि हमारी चेयरपर्सन मैडम सुनीता जी शिमला से हैं और मैं 5 साल शिमला में डायरेक्टर था, कभी दुर्भाग्य से मुलाकात नहीं हुई। मैं भी पंथा घाटी में हिमालयन फॉरेस्ट इंस्टीट्यूट का डायरेक्टर था। मैं एजेंसी वगैरह आता जाता रहता था, लेकिन कभी ये नौबत नहीं आई कि वहाँ दवा लेने की जरूरत पड़े और आपकी सहायता की जरूरत पड़े, और हम खुशनसीब हैं कि आज आपसे मुलाकात हुई। मैं हमारे जितने भी पैनलिस्ट हैं, मैडम रश्मि रावत पहले से मैं जानता हूँ, डॉक्टर अलका सक्सेना मैडम, नवीना सर जो हमारे संस्थान के तरीके से सदस्य हैं, आते ही रहते हैं, मैडम लिली, मैं आप सबका हार्दिक धन्यवाद देता हूँ। और हम अपने को आनंद महसूस करते हैं कि आपने अपना बहुमूल्य समय दिया, आप इस संस्थान में पधारे, आप आए, आपने विचार साझा किए, अपने अनुभव साझा किए, और आपके इस अनुभव से हमारे जितने छात्र छात्राएं हैं इनको बहुत कुछ सीखने को मिलेगा, आगे बढ़ने की प्रेरणा मिलेगी। नर्स शब्द अपने आप में ही बहुत इम्पोर्टेंट शब्द है। नर्स को अगर आप बाइफर्केट नर्स से आप एन से नोबल भी हो सकता है, यू से अंडरस्टैंडिंग है, आर से आप रिस्पॉन्सिबिलिटी है, एस से आपके अंदर सिंपैथी है, और अंत में आप ई से इफिशिएंट हैं। तो नर्स को मैं ये मानता हूँ। इन शब्दों के साथ मैं पुनः आप सबका धन्यवाद देता हूँ कि आपने हमें ये अवसर दिया और ये गौरव का अनुभव कराया कि आप यहाँ आए और अपने विचार साझा किए। धन्यवाद।
Director sir of Samarpan Group, kindly felicitate our head of the session of this panel, Madam Sunita Verma, with a presenting memento. So also I request Principal Ma'am. By presenting a memento. Also request Nabin sir to be on the stage. I request Santosh sir, please kindly come on a dais along with her Sarika madam. Please come on a dais because they are the paper presentation evaluator. So yesterday the session already has. We're having two names in my hand right now, first and second. So I request sir to give the paper presentation first. Madam Rashmi Rawal. Madam Rashmi Rawal. Scientific paper presentation. Madam Rashmi Rawal. The second is Miss. So for the poster presentation, the second winner Pragya Singh, Mrs. Pragya Singh.
So we need to leave. That's why just I wanted to say my thanks to the complete the workforce here and the management of Samarpan Institute of Nursing and the principal madam, and every time, anytime you are asking to bring any new changes or policies or whatever the discussions in the case of workshop, conferences, Deepthi madam will be always ready. So, but today I would like to call all the organizing team members. So, if at all they are present, please come to the stage. Organizing team members of this conference, because from 4 days, organizing a conference, international conference, is not a small टास्क. आप लोग को हम देख रहे हैं, हम देखते आ रहे हैं साल से कितने काम कर रहे हैं. लाइक सुनंदा, प्लीज कम ऑन द स्टेज, ऑल ऑफ यू. यस, ऑर्गेनाइजिंग टीम मेंबर्स में सर ऑफ समर्पण एंड आगरा कॉलेज ऑफ नर्सिंग. प्लीज, ज्यादा टाइम नहीं है, जल्दी आप लोग सभी लोग आ जाइए. ब्यूटीफुल मोमेंट. और क्या चाहिए? बहुत अच्छा, थैंक यू.
हेलो, ऑडियो वाले भैया गाना चला दो. राधे रानी कृपा करो. ये सब राधे रानी है.
सर कहीं नहीं रहे बकेट लिया सर से.
ये नवीन सर की महानता है. देखिए, कोई भी संस्थान जब चलता है, काम कोई करता है, श्रेय किसी को मिलता है. चूँकि ये मैं यहाँ का डायरेक्टर हूँ, तो इसलिए जो है औपचारिक रूप से जब भी कोई ऑफ द मैनेजमेंट ऑफ सरपंच डॉक्टर दीप्ति शुक्ला एंड हर एंटायर टीम हैज रियली डन वेरी गुड वर्क, वेरी हार्ड वर्क, अनटायरिंग वर्क. And whatever success we are seeing today, it is only because of Dr. Dipti Shukla and her efficient team. So once again, extending ovation and clapping for Dr. Dipti Shukla.
आज तो महान स्त्रियों का, और सॉरी स्त्री भी नहीं है, वो तो बच्चे आज 3 महान पर्सनालिटीज का जन्मदिन है. चलिए अंग्रेजी बढ़िया है. हैप्पी बर्थडे, हैप्पी बर्थडे, हैप्पी बर्थडे जोर से बोलो
हाँ खेल को तू है
Are brilliant, and this is what we're looking to as the next in India, to have midwifery-led centres in every state. Next slide, please. This is a quick slide. I'm happy to share all my slides, by the way, so just please do let me know. I'm happy for people to take them. The standards that we're working in India are from global standards across the world. We've got a lot of global standards from the US that we've been using here in India, the Royal College of Midwives, and also from the UK. Next slide, please. Okay, just a brief timeline. So, because I expect a lot of people in the audience are nurses here, so I wanted, obviously this is great for promotion for me because it's an amazing journey to become a midwife. So I was onboarded in 2021 in December, and I arrived in Delhi in 2022. I was stationed in Wardha, Maharashtra, in March 2022. This is the first government sector hospital to take up this initiative. In the top left-hand corner there, you've got the smiling women with white coats, are my 5 Maharashtrian midwives that had started their training in Fernandez. So we worked with them for a couple of months before we were given the go-ahead to start the first batch of learners. I'm here in the Mahatma Gandhi Institute of Medical Sciences, led by the amazing Dr. Poonam, who is a great leader and great support for midwives, nestled in the Karmabhumi of Mahatma Gandhi in Sevagram. So I'm very lucky, I'm very blessed to be at this institute. Next slide, please. So this is a picture with most of the midwives. We had 30 learners. We were going to introduce the new cadre of midwives. This is what the government of India wanted us to do. The nurse practitioner midwife. We were going to introduce these into the existing health system in India, train them to global standards, evidence-based care, and they would then go back to their respective states and they would teach and they would start state midwifery training institutes where they are. So I work at a national midwifery training institute. The picture or the geography will be that they will start SMTIs. So we prepare midwifery educators and midwives in line with the ICM standards, which are global in terms with the WHO. Next slide, please. So birth begins to change, but there's baby steps. Behavior change takes a long time. Next slide, please. Okay, so the learners arrive.
They're from the states of Bihar, Uttar Pradesh and Maharashtra. So we have 30 learners, and they're placed for their 6-month residency into accommodation that's very basic, and we start training them. We go straight into the theoretical part of a learning resource package developed by the government of India and Japaigo, and this goes into a lot of training that we would have normally in the UK or the US. Upright birthing positions, kind and compassionate care, and safe evidence-based birthing practices are our main focus. And we live, I'm living away from home here in India, they were living away from their friends and families, so we really created this wonderful sisterhood, and I still find that time one of the most magical and important journeys of my life, being with the women, these beautiful Indian midwives that have dedicated their lives to do this cause. Next slide, please. So learners in the First State Nodal Centre, the NMTI, complete their training in 6 months. So it was hard training. It is, you have to be really dedicated. We had a lot of problems. You can think in 6 months they're away from children, they're away from families, but we managed to complete 80% of their logbooks. Most of them got between 20 and 25 births each. This meant that they did dedicate working night times, long shifts to maintain and get their competencies signed off. They facilitate a physiological birth conference on their own, and they worked with local ushers. Next slide, please. So what we have achieved, we have a fully functioning antenatal clinic, seeing up to 30 women per day. We have a fully functioning midwife-led care unit and midwives present in the labour room assisting low-risk mothers. Only in the last month, in August, we had 38 births, all were low risk, all done by midwives trained by us. We have an active birth workshop, so we have an education room where we provide classes for the rural women here. This has shown a reduction in the caesarean section rate, reduction in episiotomies, improvement in neonatal outcomes, and we are an internationally renowned and great focus is on us from the rest of the world, basically. Next slide, please. So ultimately, we're all women giving birth. A lot of this is empowering women in India. I, as a UK-based midwife, I will be honest with you, was shocked at the level of the lack of autonomy women had, or lack of choices or voice. So training these midwives to give kind and compassionate care was really, really such an honour. So we're teaching about choice, and physiological birth practices has that ripple effect, but behaviour change takes a long time, and something I'm learning myself. So we're creating the role of a midwife and role modelling, which is key to changing behaviour. And tiny acts of kindness, if you see the labour room as it was before to now, will break your heart. It does change basic nursing care, being kind and compassionate. Also, you can see this wonderful birth image. It's a woman on a birthing chair, and her baby's born and given straight to her for skin to skin with delayed cord clamping, early breastfeeding, following physiology. So changing birth images, placing power into the hands of women. I think as women now, we won't possibly change our sisters' births, but we will change our daughters' births if we continue with this great work that we're doing. Next slide, please. So these are just more images of showing you the birthing room, the MLCU in Wardha. So you can see at the top there, you've got Monali, and she's turned, we've got the curtain. And why I like this picture is she's turned the woman to face towards the window, so she feels more privacy. So this is a tiny little thing, but you can see what a difference it makes. You can see that the midwife in the right-hand picture, she's ready to take the fetal heart with a Doppler. She's talking to the woman, and they come down to her level, so the woman isn't on a bed. You can see in the bottom left-hand corner, I'm holding the woman's hand, giving her support and reassurance. Kind words, kind speech, touching, making her feel looked after. And in the bottom right-hand corner, you've got two of our midwives listening to the fetal heart. You can see Savita wearing the purple. There is listening to the fetal heart while the woman is on all fours, which is a very good position. And we've got Samiksha there performing what's called the hip squeeze. I'll talk about that later. Next slide. So what modern approaches did we use? So, firstly, understanding and identifying the characteristics of the biopsychosocial versus the medical industrial philosophies of care. This is hard in India. We have very entrenched ideas and we have a great hierarchical system here. So to make midwives understood, recognized on the labour room has been a long, hard battle and will take many years to come. What I've also tried to teach is to critically reflect on the principle of women's autonomy, women's bodies, respecting women, asking women, consent. Acknowledge and reflect on the importance of building rapport and a relationship with women and within the team. So when we have our antenatal clinics, we try and have continuity. So the midwife will try and bring the woman back on a day that she will be there. We will visit women that have birthed on our MLCU. We'll go and see them afterwards for postnatal care, so that we have a relationship. There's lots of relationship building. That's not only with women, but that's with the team. So we have a very close faculty, and we share and we respect one another. Also, we deliver hands-on workshops to midwives on how to support physiological labour and birth following the biopsychosocial model. We support midwives shift to increasing autonomy and accountability and following instructions to reflect critically on the specific case and apply evidence-based principles. Difficult to say, difficult to practice. Next slide. So, what is important? What modern approaches? Think about modern approaches. I'm coming from a place where midwives are recognized as medical professionals, equivalent to doctors in their specific role in normal birth. So we have to have a clear understanding of physiology of labour and birth support and avoid disrupting physiology. You probably all have been onto a labour room in India with women lying on their backs, no privacy, curtains moving all the time, people not introducing themselves, people walking in and out of a birthing space. So ultimately we're trying to create a safe space for women to feel safe. And when women feel safe and privacy is provided and kind and compassionate care is given, women give birth beautifully. Why is it important for labour and birth to happen? We've got to think of the bonding, we've got to think of the hormones. Think about when mammals give birth. They give birth generally at night when it's quiet and they don't have any people around or other things that are any danger around. So we've got to think of the mechanical, the physical act of giving birth, plus the catecholamines or the stress hormones, also respiratory, how a woman breathes. Also, which we go into depth with our midwives, is the microbiome, the immune system, and digestion. So being birthed vaginally prevents lots of other issues happening. Babies born by cesarean tend to have higher respiratory problems, they tend to have no gut biome. So there's other issues that are being looked into globally around the lack of when a baby is born not vaginally, the problems they have afterwards as adults. Next slide, please. So, what do we do? A lot of people would say we're not doing anything, but when we're looking after a woman, truly following physiology, we have something called watchful attendance. Look at your woman, listen to your woman. What works is not flashy, not expensive, but it's human intensive. So you join that woman, you communicate with that woman, you smile at that woman, you reassure that woman. This is an approach that you will see will make a huge difference to the woman that you're looking after. Watch the woman, listen to the woman, and be alert for changes. We're not just dealing with women that are low risk, because low risk can become high risk at any point, and that's when we do need doctors. This is when we need collaborative care. We need to be able to recognise those changes and be able to tell the doctor. Obviously, having one-to-one care, looking after a woman in labour, you have that wonderful communication with her, and you can sense when you need to hand over or when something is going wrong. Next slide, please. This is one of the things we do a lot of, because you can see it's a low bed, it's a low set bed. This is called side lying release. So we put a woman on her side and we use pressure on her hip to change the diameter of her pelvis. I haven't got a donor pelvis here. I was going to try and have this for this talk, but it's back at the hospital. But it's teaching midwives that we can use hands-on comfortable exercises and maneuvers to the woman with her consent to assist birth. Especially this particular position is very good for persistent posterior babies, asynclitic or brow presentations. And it's also really good for slow progress. Think about the beds that you have in labour room, that it's very difficult to perform positions like that. That's why MLCUs, or midwifery-led care centres, are built the way they're built. And this relieves women's discomfort. Next slide, please. I can go back to these. Let's go to the next slide, if we can. So, what I'm offering in a modern approach is uncomplicated, cost-effective, easy to clean. You can see in these pictures, we have rebosa, which is a cloth. Again, it's something that you need to be taught with, but it's just like using a piece of cloth to help women labour and relax. We've got a bar, a birth bar in the bottom left-hand corner. Women hold on to that bar and can do a deep squat, or they can lean forward, whatever they want to do with that bar. Just a bar against the wall. We have hydrotherapy as well, so women use the pool here to labour in. Warm water can be really relaxing. It also prevents the guard from constantly being touched, so women have a space around them. We've had one water bath here in Varta, which I'm very proud of, but we also offer this for women just to labour in as and when they want, so they can come out and give birth when they're ready to give birth. And then you've got a birthing stool on the top there with Monali, the same picture I showed you before, and below. So this creates a wonderful space for a woman. You've got upright, you've got gravity, the midwife is sitting on a little stool, you've got one-to-one care. You can see Monali looking into her eyes, talking to her and giving her reassurance. And obviously all of this supports natural physiology. Next slide, please. So what we've got to do is recognise labour rhythms. We're so busy in India with so many busy labour rooms that it's very difficult to focus on one specific woman. Often there's lots of women approaching full dilatation, and we can't recognise those signs. So it's important to monitor the pattern of contractions. That doesn't mean you just put her on a CTG. It goes back to basic nursing care, what we were taught, to place your hands on her fundus and palpate the contractions. Are they long? Are they short? How are they feeling? Look at her behaviour. When you know, most of you who have worked with labour rooms know when a woman is reaching full dilatation, because you can hear it. Her sounds change. Abdominal palpation. Where are you listening to the baby's fetal heart? That will also tell you whether she's approaching full dilatation or where the baby is in the pelvis. What signs, what sounds she's making. What we call emotional nuance reading. It's important to do that. The last point is being uncomfortable with uncertainty. Sometimes we forget that primees need a little bit more time to give birth, and we tend to rush that process. So I think everything in India tends to be rushed. So it's having an attitude of stepping back and really, really focusing on the woman as a whole entity. Next slide, please. So this is just revisiting what we are dealing with. Catecholamines, stress hormones. This inhibits oxytocin. So in your labour rooms in India, you have women who can see other women giving birth. You can see birth trauma happening all the time. This will inhibit their natural endorphins, and it will inhibit oxytocin. So what we tend to do is give women oxytocin because they're not actually producing it themselves. So what we want to encourage is endorphins, the natural painkillers a woman has. Gentle touch, massage, Beautiful words, quiet spaces, privacy, one-to-one care. All of these kind of compassionate care, speaking to them quietly. So we also need to avoid neocortical stimulation. So not talking to them, shouting at them, just gentle, gentle reassurance. Next slide, please. So one of the main things we've done in Rwanda is to change, just a simple change is to get women off the beds in upright positions. This means that they're mobilizing using a birthing ball, or we have these wonderful birthing stools. So it encourages the woman she can stand up much more easily in between, so they don't just sit on the birthing stool the whole process. They can stand up, mobilize, then sit down again. So what you're doing is following her lead, saying, would you like to stand up? You can advise, but you're less directive. You're not telling her to do something. What we're trying to get midwives to do is follow her actions. Most women know what's going on there with their body if they're left to do it. Most women will have that mammalian primal instinct in their brain to give birth if we encourage that to happen. So we limit light and noise, and we encourage oxytocin, which is the love hormone. If we have students, it's very important to only take one student and tell her to introduce herself and sit quietly in a corner. That's what we tend to do with our students. Gentle encouragement from caregivers, this reduces the length of labour, reduces the risk of episiotomy, reduces the risk of cesarean section, and you have women having a really positive birth experience that they can remember for the rest of their lives. Next slide, please. This is another demonstration of what we use. Because women are mobile, we can help the pelvis move. So this is called a hip squeeze. And I'm placing my hand, you can see, on the top of the hips. And this changes the diameter of the pelvis. If you imagine it's shaped like this, when you press in, it tends to just change the diameter. So that opens the pelvis. So often we'll have a woman with a baby with a high head, or just slow progress in the second stage. This alleviates pain for the woman, and it also tends to bring the baby's head into the pelvis much quicker. It also encourages touch and connection. It's nice, the midwives tend to be able to touch the woman, feel more confident with massage and connection. Next slide, please. So, I'm talking about midwives doing everything. Obviously, I cannot forget the importance of collaborative care, working with doctors. In this slide, I took this picture, and it's important. If you look, everyone is looking at that woman's vagina. No one's looking at that woman's face. This was early on in our NLCU. So we actually, what is cut off is we do have a midwife here just by the head talking to her. But the doctor came in because we were assessing she had had slow progress. But you can see the focus needs to change from just looking at her vagina but talking to the woman. This is what I'm going to do. Is this okay if I do this? Explain your procedures, gain consent. It's also really been important for me as a behavioural change midwife is I've had to be very brave and stand in a labour room and try and facilitate physiological birth with doctors observing that. And the sad thing is I've realised that doctors often don't see physiological birth. There were so many episiotomies. There was bundle pressure that I've seen in previous hospitals. There's lots of practices that we do to rush what is a physiological event. And to see doctors see babies born that are sometimes over 3.5 kilos with no vaginal tears or anything. A natural, normal birth has been it's been really, really good for connections and relations between the obstetric team and the midwifery team, because we're learning together. Obviously, we're developing clear guidelines. My midwives know when to call a doctor. Doctors know that they can come in and just discuss a case instead of taking over. So say you had someone with slow progress, you could say, hi, we just want to say that she's been pushing for 1 hour now. The head is still there. We're just going to try a few more maneuvers. Is that okay? So we make decisions together much better now. And obviously, the number one rule, ensure consent. Often I don't see it, sadly, in the care that I've seen in India. But it's something we really need to focus on. Next slide, please. So in summary, following physiology ensures normality. Limit the maneuvers needed if you follow your own woman's own tuition. Often I don't touch a woman, I don't have to do anything to the woman. Remember, we have guidelines that say 4-hourly vaginal examinations. Think about in your practices that you've seen how many vaginal examinations a woman has in real terms compared to what the guidelines say. Increased skin to skin. So we've seen lots more babies go straight onto the mother's chest. We have delayed cord clamping. We have babies that have good abgars, fit and well. And that's not just the baby that you're helping to give birth, but this is the adult that baby will become. If that baby receives all its cord blood, think about the adult, how much stronger it will be. Remember, it's up to 70% blood within that cord once the cord stops pulsating. We've seen increased early breastfeeding, so the baby goes on within that golden hour. Massive increased birth satisfaction. Women who have really wonderful experiences, and obviously we're trying to collate that evidence to show that in India we're giving kind and compassionate care. We've reduced the caesarean section rate here in MGIMS. We've reduced the episiotomy rate, and really good to know that we've got greater midwife job satisfaction. Next slide, please. This is the references here, and I think that's it, guys. I did leave time if anyone had any questions or anything else. I can see you all.
From audience, anyone having any questions to ma'am?
Hello, check.
No questions?
Thank you, it's been a pleasure. Thank you very much.
Thank you, ma'am.
Bye-bye.
So back to back, we are having one more online session. Ma'am already connected with us, Sudha madam.
Yes, good afternoon, I am there. Thank you, yeah. Okay.
Good afternoon, ma'am. Before we start the session, I just want to give brief introduction to the audience about you. So, I hope all can see in the screen. Madam is our chairperson for this session. Madam is Lieutenant Colonel Mercy Anthony. Ma'am has done her PhD in nursing and PhD from the SINPS Pune. Ma'am has been recognized teacher for UG and PG courses. Has guided many research students for the UG and PG students. Ma'am,
I must compliment all of you. It's a great effort taken by Samarpan Institute. And it's a real honor and privilege for me to introduce our next speaker, that is Dr. Sudha A. Reddy. She's Assistant Prof, Department of Nursing and College of Applied Medicine Science from University of Bisha, Saudi Arabia. Hello madam, you are there, I can see you.
Yes, thank you so much, Mercy ma'am, I'm here.
All the more I am happy to introduce you because I can see you are an alumnus of College of Nursing AFMC. So that makes us related. 92 batch. She has pursued her PG in OBG Nursing, MPhil from Manipal and PhD from the National Consortium RGHS INC in 2014. She is a nominated member for a Standing Regulation Committee of International Confederation of Midwives for Southeast Asia, Adjunct Prof at Thomas Jefferson University, Philadelphia, USA. She is a former chapter secretary SOMI, Karnataka chapter, and former vice president SOMI for India. She is part of the UGC NAC INC peer team for accreditation, has many international exposures, a master trainer, principal investigator for various international projects, has been associated with many national and international conferences and workshops, has numerous national international publications to her credit, and is very closely associated with hospital as well as the nursing colleges. So today I invite Madam to speak on a very relevant topic in today's time, that is simulation based nursing education. Although it is a very popular pedagogical approach these days, but we still have a lot of reservations about it, lot of doubts in our minds. So without taking much time of hers, I call upon the speaker to enlighten us more on this most spoken topic, that is simulation based education in nursing. Madam, you may please take on the stage. Thank you. Over to you, madam.
Thank you, Mercy miss, because it's a tradition to call our seniors miss.
But you are senior to me. But you are senior to me.
Okay, then. Okay, Mercy. Mercy, thank you so much for introducing me. I think I am disabled to participate screen sharing. Can someone enable me to share the screen, please, so that I can share my PPTs? And meanwhile, thank you so much for the introduction. And right now, I am not a member of ICM Bali because it's a 3-year term. So with the Bali conference recently, I finished my tenure. I'll remove it from my biography. It just happened this June, so I've not removed it. Otherwise, everything else is fine. I'm on a sabbatic leave for 2 years from my university to the University of Bisha. And it's challenging actually from an administrative course to get into teaching like a teacher, and you get very familiar to the technical, using the laptop, going to the digital world and learning those things. Because हमारे टाइम में जब हम स्टूडेंट्स थे तो हम एक फोन उठाने में भी डरते थे. एक फोन कैसे बोर्ड में फोन आता था तो we were so scared to pick up the phone. So it's really challenging in this age to adjust to these things. And on top of that, trying to talk about simulation-based nursing, a global need. I hope it will be an interesting topic for all of you. And I thank Dr. Ditik Shukla, the management of the Samarpan group of institutions, for inviting all of us. Most of them who are the host resource people, I happen to know them personally. And Dr. Alka Saxena's, many of them like here who are there, I won't take one name and leave another name. I always feel happy to connect to India, and I hope I'll be able to do justice to this topic. I would like to acknowledge Dr. Mansi from Downtown University Exam. Actually, when I went for a presentation there, she was presenting on this, and I asked her to, give me her presentation to pick up few slides. So I acknowledge her completely, and then I try to start with my slides. I hope you're able to see me, see my slides, and so when you talk about simulation-based learning, the theoretical basis for simulation-based learning is the very popular learning theory which is often used to guide and develop this. That is the Kolb's experiential learning theory in 1984. Those of us who are FAMER fellows, or those of us who have gone a lot into medical education and done those PG diplomas know about this. And even in our nursing education textbooks at UG level, we have studied about this. This theory has 4 steps which forms a continuous cycle. That is the concrete experience, observation or reflection, abstract conceptualization, and active experimentation. We will see what these are. When you talk about the concrete experience, that is engaging directly into that authentic situation. Like all of us were very lucky, especially at FMC Pune or in the army, we used to, and all my government hospital seniors and colleagues who are here who have passed out from government hospitals, like हम ही लोग delivery room संभालते थे, like हम ही सब करते थे. तो we know कि कैसे first stage, second stage, third stage होता है. What are the signs of separation of placenta? We know how to apply cord reaction. We have seen the deliveries. So this is an example of a concrete experience where you're directly involved in an authentic situation. In the reflective observation, you notice क्या हुआ, and then you relate to a past experience and conceptualize understanding. This is also very good. क्योंकि लगता है कि हाँ इस बार जो है प्लेसेंटा जल्दी सेपरेट नहीं हुआ, ज़्यादा ब्लीडिंग हो रहा है. पिछली बार तो सुबह से जो 6-7 डिलीवरी और मैंने की थी वो तो फटाफट हो गई. So this is a reflective observation. And when you talk about abstract conceptualization, it is distilling perceptions into abstract concepts. जहाँ आपने कभी लेबर रूम में कदम नहीं रखा, कभी कोई डिलीवरी नहीं किया, कभी कोई प्लेसेंटा हाथ में नहीं पकड़ा. You are just a student who is studying reproductive health or midwifery now, and we are just सिखा रहे हैं हमको स्लाइड से. We are just teaching you ऐसे होता है प्लेसेंटा, ऐसे थर्ड स्टेज शुरू होता है, ऐसे सेपरेशन होता है. You are just conceptualizing. जैसे अगर मैं आपको बोलूँगी कि I am having tea, तो मेरा चाय एक कप में है, आप एक ग्लास में पी रहे हो, कोई कुल्हड़ में पी रहा है. तो everyone has a different perception. तो ये थोड़ा सा मुश्किल हो जाता है, but this is a part of experiential learning. And the last is active experimentation, where you test new ideas, hone new skills to gain a new experience. So this is a called cycle of experiential learning, and this is what has been the basis of simulation-based learning. Circle of learning क्या है? Knowledge acquisition करना, skills सीखना, decision making करना, simulation thinking करना और clinical experience gain करना. So these are the steps which any nursing student undergoes before she enters the clinicals. मैं हमेशा ये स्लाइड जब देखती हूँ तो मुझे लगता है कि जैसे वर्चुअल कॉकपिट सिमुलेटर्स हैं, पैराशूट्स हैं, सिमुलेटर्स फॉर इमरजेंसी लैंडिंग, जो परफेक्ट जो एयरपोर्ट में जो फ्लाइट अटेंडेंट्स हमें सिखाते हैं, they give us a training, how perfect they are. So that is more important, because I wish कि हमारा हर जो नर्सिंग प्रोसेस या नर्सिंग असेसमेंट का स्टेप है वो ऐसे इतना फुल प्रूफ हो that we learn the correct way of handling the patients. थोड़ा सा हिस्ट्री if you think कि क्या क्या हुआ था. At early sim labs थे जिनको डेमोन्स्ट्रेशन रूम्स, जैसे हम लोग के भी टाइम में डेमोन्स्ट्रेशन रूम्स थे, ओके, तो हम लोग लैब डेमोन्स्ट्रेशन रूम्स बोलते थे, अभी उनको स्किल लैब्स बोलते हैं. तो this name was turned by Nickerson and Pollard in 2010, जहाँ पे nursing students would go practice, like एक डमी थी जिसका नाम मिसेस चेस था, तो उसके ऊपर सब प्रैक्टिस करते थे, and they used to learn to administer injection, insert nasogastric tubes and other basic nursing skills. फिर 1990s में बहुत बड़ा चेंज आया. There was a very big change in the world of educational simulations, which impacted the nursing skill labs. Like LADL, so we all know about LADL and we know about medical education technologies. These were the companies which developed affordable, high fidelity simulators. Like we should now also learn कि simulators होते हैं वो भी high fidelity, low, mid fidelity क्या है ये? तो this LADL developed high fidelity simulators based on some work by Kava, and subsequently nursing education has moved from a traditional skill lab into a world of high fidelity simulators. So आजकल तो nursing education is evolving in India. We know the INC step forward for simulation based training. We all know about the SGT University, the simulation lab, and encouragement to develop simulation labs across India. The dream is to have regional labs. If one particular college or university has a very good lab, it can train the other nearby colleges students, and that is what is the dream. And interestingly क्या हुआ है कि NMC बिल आया, मेडिकल एजुकेशन का सिलेबस भी चेंज हुआ, उनका भी कॉम्पिटेंसी बेस्ड, उनके एडकॉम मॉड्यूल स्किल बेस्ड जब स्टार्ट हुआ, तो मेडिकल कॉलेजेस आल्सो हैव स्टार्टेड इन्वेस्टिंग अ lot in simulation lab. Example, in my university at KLE, they invested 8 crores in a simulation lab, central simulation labs, which Sri Amit Shah ji had come to inaugurate. So what I'm telling is that इतना importance दिया जा रहा है simulation labs को, and even we all go in rotations, like nursing students go, physiotherapy students go, medical students go. So that is a separate facility other than having these small labs in a nursing college as per the INC curriculum. So that is what is the scenario today. And जब हम the pyramid of learning देखते हैं, तो we know that every one of us are very familiar with this. कि सिर्फ lecture से 5% we gain knowledge, attention. Reading में सिर्फ 10, audio visuals में 20, demonstration में 30, group discussion में 50, और hands-on training में we learn 75%, and teaching others में 80%. This is what is the learning pyramid. And क्यों शुरू हुआ need for simulation based learning in UG nursing? Because students का direct experience with patient care and opportunities to handle problem-based clinical situations have been diminished. Why? In India, we all know why, but overall, globally also it has diminished because of rapid changes in the clinical placements, patient safety issues, ethical concerns, and shortage of the number of faculty available to educate new nurses due to shortage of nursing personnel. हम इनको बोलते हैं 1:10, 1:10. 1:10 ओवरऑल स्ट्रेंथ है, पर हमारे पास अगर 100 OBG के स्टूडेंट्स हैं और हम सिर्फ 4 या 5 OBG के स्टाफ हैं, how will we maintain that strength and how will we individually be able to train the students in the clinical area? So these are some of the concerns. And so simulation में we as faculty, we ourselves need to learn to effectively design, facilitate and debrief simulation based experiences so that we can meet the objectives for the learning experiences. And we also need repeated protocol based training practice to manage a clinical situation. हमने एक बार सीख लिया, नहीं, every year I think it should be done for every teacher during the vacations. You reskill yourself in the lab. Like 4-5 teachers stand with each other and they reskill themselves in the lab, so they are skilled enough. So they are skilled enough to train the students. अभी खुद मैं एक बार करके भूल गई, तो मैं कैसे justice कर पाऊंगी students को सिखाने? So, and it also aims at reducing the margin of error for unexpected emergencies, especially those at unfamiliar locations. So you can do a normal delivery in a labor room, पर रिक्शा में डिलीवरी हो गया, तो क्या करना? तो वो स्किल्स हमारी इतनी होल्ड अप होनी चाहिए कि रिक्शा में हो या ओपीडी के फ्लोर में हो या लेबर रूम फुल है तो बेड के ऊपर चढ़ के भी डिलीवरी करना हो, तो वी शुड बी एबल टू प्रैक्टिस दैट सेम स्किल्स इन एनी सिचुएशन. सो when they talk about trainers, in every lab we have different kinds of trainers. So ये जो pictures हैं, these are of part task trainers. जैसे IV arm हो गया, या ECG task trainer हो गया, या interchangeable catheterization and enema task trainer हो गया, या airway management task. So ये जो छोटे-छोटे dummies रहते हैं, इनको टास्क ट्रेनर बोलते हैं. I also learned about all this when I used to attend the meetings with a team of anesthetists, medical personnel, dentists, because we wanted to develop the simulation lab. So they used to show quotations कि ये वाला मॉडल चाहिए, ये चाहिए. That was when I really learned कि टास्क ट्रेनर्स होते हैं, high fidelity, low fidelity, mid fidelity models होते हैं. You know, so this was what is available in the market. And then you also have standardized patients and hybrid simulation. Standardized patients के बारे में मुझे जो अच्छा लगता है, जो मैंने अपने एक्सपीरियंस में देखा है कि हमारे यूनिवर्सिटी से एक टीम को यूनिवर्सिटी ऑफ मिशिगन भेजा था. तो वहाँ पे when they came back and gave us a pre standardized patients में वहाँ पे like जैसे पुलिस स्टेशन में एक बोर्ड होता है, वहाँ पे सारे क्रिमिनल्स के फोटोज होते हैं ना, इतने लोग हैं करके. तो वैसे स्टैंडर्डाइज्ड पेशेंट्स में दे हैव अ सचमुच का हॉस्पिटल, सचमुच का कैजुअलिटी, लेबर रूम, एनआईसीयू, प्राइवेट, सेमी प्राइवेट वार्ड्स, आईटीयूज, डिलक्स वार्ड, सच का होता है मतलब. एंड वहाँ पे जो लिस्ट रहती है पेशेंट्स की, जैसे रूम नंबर 1A एपेंडिसेक्टमी, रूम नंबर 2B cholecystitis. So ऐसे this medical nursing students they go there and they pick up the patient and they go inside. कि आज जैसे कि मैं एक मेडिकल स्टूडेंट हूँ, मुझे अपेंडिसेक्टमी के बारे में पढ़ना है, तो अंदर जो पेशेंट रहता है he is well trained, he knows. So if I take a history, वो मुझे बोलता है कि हाँ मुझे यहाँ मेकबर्न इस पॉइंट पे पेन हो रहा है और थोड़ा सा बुखार भी है, you know, they are trained. So this has helped in two ways कि you have trained people and they tell you all the symptoms, you learn about it, and then unemployed लोगों को कितना जॉब मिलता है इससे, like that. So this is what I learned about standardized patients. Now we use it in the Indian scenario, like we use our own friends as standardized patients and we try to practice on them, role play on them in the labs. Like if you have a dummy of a female pelvis and the delivery model, if one of the teachers hold it and she cries and she says, मुझे बहुत दर्द हो रहा है baby. So that is another kind of hybrid simulation. When you do that, or when you have an artificial breast, you teach about, you know, kangaroo mother case. So ये सारे अलग-अलग techniques हैं simulation based learning में. और इसके अलावा जो थोड़ा सा हाई फाई है, जो हम लोगों को भी समझने में मतलब सीखना पड़ता है, that is computer based simulators, where it includes combination of computer technology and a part of whole body mannequins to provide a more realistic learning experience. These interactive mannequins are capable of realistic physiological responses, including respiration, pulses, heart sounds, breath sounds, urinary output, and pupil reaction. Additionally, the more advanced models can communicate with the student, respond to questions posed by the learner in real time during the simulation exercise. 80% of us who are in the crowd today, we have such kind of, you know, dummies. बहुत मैनेजमेंट के साथ नेगोशिएट करके एक ले लिया, दो ले लिया, क्योंकि एक लैडी का डमी 7 या 8 लाख का, अभी वो 9.5 लाख का हो गया. That's a adult dummy where, you know, it coughs, it vomits, and you can listen to the heart sound, you can check the BP. So whenever NAC inspections are there, what we do is we train our students. We don't show as teachers because we have to show the concept of slow learners, advanced learners. So intelligent students, we train them, they stand there and they perform and they show to the inspectors that this is how real-time learning is going on. So there is another very famous model for delivery, Suzy, which even I am not very expert in because I am not trained in that. तो ऐसे काफी सारा कंप्यूटर बेस्ड सिमुलेटर्स है, वे कंप्यूटर का रूम जो रहता है, we are where you change the scenario. अंदर एक टीम रहती है, interdisciplinary, multidisciplinary team who are doing एक sudden emergency है, they are doing a cardiopulmonary resuscitation for example. सब कुछ नॉर्मल हो रहा होता है, आप अंदर बैठ के फिर चेंज कर देते हो, फिर आप अपना बीपी कम कर देते हो या हार्ट रेट बढ़. Again they struggle. So this is how they do, and it is very very interesting. I always like to speak more about this because जब मैं थॉमस जेफरसन यूनिवर्सिटी गई थी, वहाँ पे उनका एक अलग बिल्डिंग ही है, उसको हैमिल्टन स्किल लैब बोलते हैं, सब 7-8 फ्लोर्स. We wanted to just enter एक क्लासरूम में जाके, it is एक तो हम देखे पर सारे के सारे एंगेज थे. इतना massively they teach this कि उस दिन कॉलेजेस नहीं होते हैं, like the day the students are posted there, every room is filled with students and training is continuously going on in different lists. So that is the computer based simulators. And जब हम fidelity की बात करते हैं, fidelity refers to the degree of realism or the ability to replicate the real thing that the simulator or actor is representing. Like you have low fidelity simulator, you have moderate fidelity simulator and high fidelity simulator. जितना ज़्यादा वो सच को दर्शाता है, लाइव सिनेरियो को दर्शाता है, उसके ऊपर फिडिलिटी की रेटिंग्स होती हैं. और we all know that we all learn through seeing, doing and thinking. क्योंकि जब मैं when I hear it I forget it, if I see it I remember it, if I do it I know it, and if I discover it definitely I will use it. So when you think of a structure of a simulation scenario, if you see the red, yellow and green bar, the red one is the pre-briefing, why and how, and yellow is the simulation, the real situation, and you see, look at the green bar, that is the most important bar, इसलिए वो इतना बड़ा है, that is the debrief and the reflection, जहाँ पे सबसे ज़्यादा potential होता है learning के लिए. Pre-briefing में only why and how, simulation में real situation, debriefing में reflection with highest potential for learning. So we will always have reactions in the pre-briefing, analysis in the simulation and summary in the debriefing. Pre-briefing में होता क्या है? Like when you, those of you who have gone to SGT University in Gurgaon, you must have seen that pre-briefing area कैसे रहता है. That's a place where there's an information or orientation session which is held prior to the start of a simulation activity, in which instructions or preparatory information is given to the participants. तो इस pre-briefing में instructor है, सारे participants बैठे रहते हैं, they set a stage for a scenario and they will assist each participant in achieving the scenario objectives. कि इस scenario में हमें antenatal palpation करना है, Leopold's के चारों manuals करने हैं, they explain to each other. फिर जब pre-briefing से when we enter the real situation simulation scenario, enactment of the scenario में real situation में as per the role description and condition given. So after simulation, you will instruct to the team members not to talk with one another, discard the old articles, arrange the room nicely and meet in another room for debriefing. And debriefing का usually scenario ऐसे होता है, hospitals में भी और labs में भी, जहाँ पे बहुत सारे लोग बैठे रहते हैं एक साथ and they discuss कि अरे हमने ये wrong कर दिया, ये करने में मजा आया, यहाँ पे हम सब चुप गए. तो that's a very learning environment for everyone where debriefing is the heart and soul of simulation based training. And here post event debriefings in healthcare are defined as then after event discussion regarding performances and through processes of team during the scenario promote reflective learning and improve clinical performance. So this is what happens in the debriefing. And why do we debrief? Because we want to be aware of the reactions in a crisis. And we want to develop tools for evaluating and analyzing these reactions. And we want to bring a positive change in the behavior. And debriefing will help in facilitating the recall and insights into the events and actions. Why they happen? What was the reason they happened? And always advantages are they clarify the doubts, they introduce key issues, they have insights into the strategies and processes. And they also, the participants can begin to develop their own evaluative skills for future critical events. Stages of debriefing में, again you have so again a revision की pre में तो why and how, simulation, then debriefing में highest potential of learning. जब हम reaction की बात करते हैं तो हमेशा emotion, how are you feeling, कैसे था, did you enjoy it, and what all did you recall? So recall करवाते हैं. फिर analysis में open ended questions, क्या हुआ, क्यों हुआ, what are the consequences that it may have led to, what could have been done to improve the scenario, and how could it be prevented in future. So all should participate during this analysis. Like they make each and every table they go to and make them participate, and then in the summary they conclude and summarize and discuss what is the take home message. आप अपने कॉलेज जाओगे या अपने वार्ड में वापस जाओगे, how will you practice it, what is the take home message for you. जो फैसिलिटेटर होता है, what is his role in debriefing. जब reactions collect कर रहे होते हैं तो he has to clear the air and guide in the questions. कैसे लगा आपको, what went wrong, so he has to be the main person here, very informally as a friend talk to them. Analysis is the bulk of the debriefing, so he has to spend more time to understand what happened and deeper meanings into why it happened. Okay, and he should also understand the frame of mind of the participants and their mental models, because everyone comes from a different background. Some people have simulations, chote labs which are functional in their college. Some people have never been exposed to it. So according to that, he tries to help in analysis. In summary, he reviews what happened, what was discussed, and try to apply it to the context. You could say something like, let us identify some take-home points from this case for future practices. Okay. So in all, it is a debriefer's job to acknowledge an emotion, diffuse them, guide them into concepts that can be more applicable into the practice. So again, जब debriefing होता है, ऐसा नहीं कि you have to sit together with each other, because sometimes जो trainer होता है, he is an anesthetist, he has to go back to his OT. The dean of the college has to go back to her place. So there are different types of debriefing. You sometimes do video assisted debriefing, you do fully facilitator debriefing, or you co-facilitate debriefing with more than one facilitator. सबसे अच्छा is the facilitator only debriefing which is effective, क्योंकि facilitator and video assisted debriefing will achieve in the learning outcomes. Again, there is a little bit detail when to debrief. Overall, post-simulation debriefing is more effective than the debriefing that occurred during simulation. Disturb हो जाते हैं. Simulation कर रहे हैं, आप वहाँ खड़े होते हैं, उनको अरे ये गलत था, ये ऐसे था, नहीं. After the whole thing is over, you must do, and there should be confidence of individuals and teams, and better knowledge के और team coordination. That happens. Okay, 5 more minutes. I will finish. Okay. So environment in which the debrief takes place. There is a significant evidence that experiential learning causes feelings of anxiety in the learner. अभी जैसे हम लोग को SGT ले जाएंगे, we are so anxious क्योंकि कितने दिन से हमने वो किया ही नहीं है. क्या पूछेंगे, हम कैसे करेंगे? So it's always important to create a safe environment for the participant. Safe in the sense, a psychologically safe environment which will allow the participants to share and reflect their feelings, assumptions and opinions, to speak up and to discuss difficult topics. And who must conduct the debriefing? Of course, it is the person who observes the simulation must do the debriefing. And जो भी debriefing करता है, he should have skills in both diagnosing the learning needs of the participants and the ability to adjust the level of facilitation needed for the group. Because for nurses, doing an advanced life support would be less than teaching it to an anesthetist. So that kind of customization, tailor-made teaching, the person should be able to do. And it also provides a means for the participants to reflect on their actions. Or if there's an expert person, he will provide constructive evaluation, he will provide adequate guidance, allow enough time, talk the right amount, teach the right amount, and reinforce aspects of the healthcare team's behavior. That is more important for an expert rather than make fun, take mistakes of the students, try to compare them with a good student. No. So never criticize them, appreciate the effort of each participant. All members should participate. I have seen during this कि 1, 2, 3, 4, 10 में तो everyone is made to stand and talk and say something. एक लाइन तो बोलना ही है मतलब. And the facilitator should be seated together उनके साथ उनके टीम में, ऐसे नहीं कि वो अलग से एक बड़े चेयर में दूर बैठा नहीं, उनके ग्रुप्स में जाके आप बैठिए और उनसे बात कीजिए, they feel more close और in-depth questioning भी हो जाता है. So advantages of simulation based learning are many which now we are coming to know because of the new syllabus which has come up for us, the competency based nursing syllabus, which helps to promote effective communication, allows learners to make mistakes, allows for an immersive experiential learning activity, and also helps in repetitive practice learning, and boost students self-confidence and reduce anxiety. So ये सारी चीजें they are almost repeating in each slide, so I'm hurrying up. And अभी जो हमारा UG nursing education है कि what all can be done in it, like if you talk about pediatrics, you can do simulation of standardized patients for immunization, assessment, neonatal resuscitation, like helping babies breathe project. Many of us have done in our universities, and many of us are working with American Academy of Pediatrics. We are doing this, the neonatal resuscitation things, NALS, PALS. So that is a very good example of simulation-based learning. Patient history taking, you can always do role play, how to, standardize patient with asthma, and transitions of care can be done as role play. Nurses' role can be done as role play. Same way, the maternal health में आप देखोगे labor room scenario, laboring mom, normal vaginal delivery, breech delivery. जब breech delivery, if you are doing on a dummy, you show them the Burns Marshall technique where you keep the baby in your hand. Like how you put your 3 fingers in your mouth, 2 fingers on the zygomatic arch, babies on both sides of your arms, how you hold the leg and you turn 360 degree. When you show, then emergency situations they will do it. But if you don't know, you can't do it, then it's difficult to teach these things. Even a neonatal bathing of a baby is a nice standardized procedure, postpartum care, newborn assessment, breastfeeding, obstetric emergencies का मुझे मालूम है. I had been to United Kingdom because we had a UKD grant we had got around. So we had elective placement of midwifery students coming there to us, and I had been there as a PI. Hospital में एक रूम है जहाँ पे multidisciplinary team आके बैठती है, and there's a head nurse, a very expert nurse who teaches. तो जैसे ही हम लोग गए, मेरे साथ एक फिजियोलॉजिस्ट थे और एक डेंटिस्ट थे मेरे यूनिवर्सिटी से, एंड उन लोगों ने हम लोग के सामने वो एंडोट्रेकियल ट्यूब पास करे थे, वो हमारे सामने रख दिया. लाइक दे वर ऑल इन अ सर्कल. हम लोग we were like big shot officials जो वहाँ गए, and जब basic skill के लिए they put it in front of us. Thank God we were able to put the endotracheal tube, because I had learned in the army that 2 white vocal cords होते हैं, उनके अंदर से you have to put the endotracheal tube. So like that we could be able to show them some skills. So that is how. And then when they had this obstetric emergencies, जैसे कि eclampsia manage करना है, तो they will keep magnesium sulfate somewhere, for catheter somewhere, and they say, okay, then get it for this catheter, get the maxilla, break it. So that kind of simulation scenario होता है. तो जब वो इंडिया आए और वो हमारी फंडामेंटल लैब में ये सिखा रहे थे हमें, तो वहाँ पे मैग्नीशियम सल्फेट नहीं था, तो बोला कि पेपर में लिख देते थे, ओके इंजेक्शन मैक्सिल वहाँ रखा लेके आओ. आई मीन जितना रियल हो सकता है they try to do. These are the tricks. सबसे ज़्यादा तो team work और communication is very important, and lot of cooperation from your management is important. These are other topics in medical surgical conditions which you can do as simulation. Like I can just take one from here, जैसे कि burns है. In AFMC Pune we used to set up a burns unit अपने advanced lab में, and जो भी team होती थी, जैसे मुझे अगर burns unit set करने को बोला, I have to take all the students to the burns ward, show them the entrance, show them which is the area जहाँ patient को receive करते हैं, उसको weigh करते हैं, उसको they give bath to the patient, how they dress, what are the different formulas, the Brooks formula and the other formulas used for calculation of fluid for the burn patient. So this is how we were taught, and this is how we must teach. Especially medical surgical nursing is a vast syllabus, and if you have to give it to the 3rd years, you can form small units and give it to them, a team of students who can set it up and show. And when you talk about characteristics of a simulation facilitator in UG, again, वो बीच में वो बेचारा simulating educator है. He should have empathy, he should be honest, he should be patient, he should know to move up with the pace, democratic, purposeful, he should be able to listen, respect the experience and prestige, and be innovative. So he is in between all these things, and we must encourage our junior teachers, the BSc clinical instructors and others to get them trained for basic skills, because we only concentrate on MSc, BSc और GNM course वैसे रह जाता है. or GNM course is very close to my heart because they are the people who are working in the hospital. So whatever we are teaching in the university system should also go to them. That is what is my take home message here, because they are the ones who are running all the hospitals across India, whether they are private sector or public sector hospitals. Most of the BScs and MScs are coming into education. All the bachelors are going away to US, UK, Ireland, Germany. आजकल तो Germany का बहुत है, and we only have majority of the GNM nurses with us. So whatever is happening, we try to stick on क्योंकि अभी BSc syllabus आया है and competency based. We must also try to transfer it to our diploma students and encourage the UT faculty. And I hope simulation is a safe way for students to learn. They can practice until they achieve the skill competency, and they learn how to reflect upon what went wrong, how to self-correct it, और वो बोलते हैं ना auto-correct more होता है computer में, and how to accept feedback. And simulation-based learning must be integrated at all levels of healthcare professionals. We have students from dental college, PGs, they come and tell, madam, we want to practice in your lab. Injection kabhi nahi diya, they want to practice. So I just used to direct them to our fundamental HOD, you know. They say, ma'am, bahut acha hai aapka lab, they taught us. So that is how it should be integrated among all healthcare professionals. Actually, the nursing college can take up a value-added or add-on course on basic skills, basic procedural skills for all medical, dental, pharmacy, and PH students, so that others also learn what students are learning. Teachers, educators, instructors, facilitators, and faculty members need to be more cognizant on simulation-based learning. वो क्यों important है? उसमें कितने issues और modalities और methods हैं, and how to deliver it and how to assess. Because if we will not do it as administrators, we will not be able to convey the message to our management that हमें ये भी चाहिए, हमें ये भी चाहिए. So to do it well, faculty need to learn to effectively design, facilitate, and debrief simulation-based experiences to meet objectives for learning experiences. So as William Osler sir said, the successful teacher is no longer on a high, pumping knowledge. He himself is a senior student, anxious to help her juniors. Thank you so much, and I hope I have not taken much time. Thank you so much. And the house is open for discussion.
Yeah, thank you. That was a very, very fantastic presentation, I must say, by Dr. Sudha. And I'm sure the house is benefited by her deliberations. She has very aptly covered the topic and cleared almost all aspects which we keep thinking about this simulation-based nursing education. Let us open the discussion to the audience if they have any queries. One or two questions we can permit since we are already short on time.
Anyone having any questions, please?
If there are no questions, I would like to thank the Dr. Sudha for that very lucrative presentation. And as nursing educators, I think it's high time we adopt these innovative methods of teaching learning. There's some connectivity issue at my end, so I would like to conclude. And best wishes to the team. Thank you so much.
Thank you so much. Thank you, Dr. Dipti and your team. Please convey my regards to everyone. And I just signed off because I have another class here. Can I leave today? Thank you.
Thank you so much for being with us, ma'am. We wish in the future also we will be having a good friendship. Thank you so much for being here. Thank you so much, ma'am. Have a great day.
My pleasure. Thank you so much. God bless you. Jai Hind.
Thank you so much. If you
Please, as a chair speaker, Madam Surbi Bhargav.
Thank you so much, Madam Surbi Bhargav. Ma'am was selected for the first batch of nurse practitioner in midwifery educators program and is an active participant in the midwifery initiative of the Government of India since November 2019. Ma'am has represented Uttar Pradesh as a midwifery leader in the midwifery leadership program in May 2021. Ma'am was nominated and funded by JAPIGO and the White Ribbon Alliance for participation in the 32nd and ICM Virtual Triennial Congress in June 2021. She has presented a paper at the 33rd ICM Triennial Congress in June 2023 and served as a keynote speaker for the Midwifery Initiative of India. She is serving in the dual role of a midwife and midwife educator to improve maternal and child health services in India. She is providing quality and compassionate care to mothers and newborns, training future midwives to global standards. She is building the skills and competencies of nurses and faculties in clinical settings and nursing colleges, contributing to multiple research projects resulting to nursing and midwifery. Ma'am was keynote speaker at the regional conference of the Society of Midwives of India, Kolkata, and the National Conference of the Society of Midwives of India, Lucknow. Presently, Ma'am is working as a national midwifery educator at NMTI Meerut, India, a role she considers life-changing and exciting, and is proud to be part of the changing maternal and childbirth practices in India. With this, I would like to tell Ma'am, please take the dais and enlighten our audience.
Thank you, ma'am, for introducing. Very warm good afternoon to all. Thank you, the Samarpan Institute of Nursing, for giving me this opportunity. Definitely, I know this is the last session and everyone is feeling very hungry and might be sleepy and tired also after these 3-4 days long international conference. I'll not take much of the time of yours because I think my colleague Kath from MGIMS Wardha have already highlighted about the midwifery practice that is being going in India since 2019, the initiative of India. So I will be just dealing with how this nursing and the midwifery has correlation with each other and how this nursing has come out with the midwifery. Definitely in nursing, we know that after doing the BScs, like I think Sudha ma'am have already studied, people are going abroad, they are not doing the clinicals here, and those who are doing clinicals are mostly the GNM students or basically. But this midwifery concept is a little different from that of the nursing. I would not say we did not provide the respectful maternity care in nursing, but it needs more passion, more compassion, and a feeling from inside to be a midwife so that we can render the respectful maternity services. It should come from the inside of a person that have that feeling to serve for that mother, that baby, and it's not that too much different from the nursing, but that concept should be a little more clear in the mind with a new few standards that have been incorporated in midwifery according to the International Confederation of Midwives of world. Like these concepts have indulged in the nursing part, and it has came to be like midwifery course, a different separate cadre. I think the audience all are knowing about the midwifery, this new initiative of the Government of India. It will be a little interactive. I am not like a speaker or teacher here. So if someone don't know about midwifery, please let me know so that I can tell you a little, just brief in 1 or 2 minutes, what actually this initiative is. Is it clear to everyone about this initiative? So, about the advanced management of the normal labor, I will be telling. This concept have this designation as the midwifery educator. People usually think that this profession is definitely of the educator, like the nursing educator we have, or the faculty of the nursing colleges. But when this program was initiated, the concept, like the doctors we have, that they will, like doctors are teaching in the college of the medical colleges, along with that they are practicing in the hospitals. So this concept was being taught in the mind by the government officials, and with this concept, this midwifery initiative have came into existence. So definitely the midwifery educators have the dual role of practicing in the clinical areas as a midwives for providing the respectful maternity care, and as well as they are teachers to teach the nursing professionals who want to become the midwifery educators. And those educators are already masters in nursing or BSc with 5 years of experience in the maternity area. So objective, this, like I have told, in the collegiate program they are educators, and when they are practicing in the clinicals they will be midwives. So as nursing advanced role, I will be just highlighting the labor or the MLCU, midwifery led care units role to you, because I think in educator everyone knows what the nursing faculty does. Same ways the midwifery faculty or the midwifery educators also teach the midwifery the educators students. They do simulations that ma'am have told. It's not just teaching, because already in nursing they have studied the midwifery part, the obstetrical and gynecological nursing in masters. It's just building the midwifery concept in that through simulations, doing acts, recognizing the complications, managing the initial complications, initial management to do, and doing the referrals. So the objective of care that we are doing is provide the mother. First, the first objective is to provide and the care for the mother and the newborn. Then, during that care, we have to support the mothers just support the mother during the whole phase of the continuity of the care. This concept of the midwifery is again continuity of care. The mothers whom we are seeing in the antenatal period, for those mothers we are doing the follow-up. We are checking that mothers, like when they are coming into the labor, helping them during the interpartum period, having the peaceful, respectful birth, and following that mother in the postnatal period. So we support these mothers during their labor and detect any complications if it arises. As an educator, we will be, or the midwife, we will be prepared for any of these such type of emergencies, and the support and respond to the need of the family in case if she is having during the childbirth or in complication, and also to find out and recognize the danger signs. Then partnership in care. Definitely this midwifery is not it's an independent practice, but anyhow it's not actually alone. Sometimes in case of emergencies, this collaborative care or partnership in care needs to be required. Partnership with the family, with community, with mother, her birth companion, and also collaboration with the obstetrician and other healthcare professionals that are already present in the healthcare team. So this partnership in care, it's supportive partnership to the mother, competent, empowering the mother, telling what are the benefits of being with the mother. They already know what beneficials we are giving, providing this empathy to the mother, like continuously we are helping the mothers in every phase of life, helping her from the informed choices, taking decisions, respecting her, telling what we are going to do, we are doing with the mothers, what means like what are the options available and how she can take the choices, how she can decide to help in the decision making. So it's a partnership with the mother and the family members also. So these NPMs is nurse practitioner in midwifery, so they must always be prepared for finding out the danger signs. Like when they are caring for the mothers, they should know what they should tell to the birth companion what are the danger signs they can have during pregnancy, during intrapartum period, or during the labor. So first of all, we have to teach, we should know what are the danger signs, how to identify that danger signs at regular intervals, how to manage these dangers or the complications that arises, and lastly, after managing it at the initial phase, do the referral. If we are working in a facility that is already a FRU or a higher specialized unit, then we should know how to collaborate, inform collaboratively to the higher obstetrical team. So definitely how we are practicing. It's an independent practice, but we are practicing it on the basis of the scope of practice that the Government of India with the collaboration of Indian Nursing Council has released. So this is the scope of practice that is being released at the time of the midwifery initiative. It has certain criteria that a midwife should be able to see, recognize the low risk mother. I think everyone knows what exactly the low risk mothers are. So during the antenatal period, as a midwife and educator, we are competent enough to recognize these types of low risk mothers. And these mothers, low risk mothers, once identified, are being followed, taken care, and if they have minor ailments during pregnancy, we are usually prescribing the medicine. So it have the medical prescription rights too. And based on these scopes, we have certain investigations that we can prescribe to the mother, certain drugs we can prescribe, give health education, recognize any high risk, and do the collaborative care if needed, or the referral within the antenatal unit only. So what will be the eligibility of midwifery-led care unit? As I already discussed, at the first initial contact, like WHO has given minimum of the 4 antenatal visits of contact to the mother. At first antenatal visit, we usually take the complete history of the mother, whether it is at the first trimester or the second or whatever time she is coming for the first time. On that basis and the history of the previous pregnancies, we are making a performer, or we are making a chart to mark the mother as a low risk and a high risk. Then at subsequent visits also, these mothers are being analyzed, are screened for becoming a high risk at any time during pregnancy. If they become the high risk, definitely the collaborative care or the referral within that hospital is being done. But if they remain low risk during their full pregnancy tenure, antenatal period, they remain with the midwife and they have the birth with the midwife. I would like to share, like 80% of the mothers who from the among 100% are low risk. And once a mother who is have a visit with the midwife or the midwifery educator, she usually finds the that same midwife or the other midwives to be have the follow-up visits, because it's the way of talking, explaining, having listening to the questions of the mother, giving at least 15 to 20 minutes to the mother to just express her feelings actually. Because for the first time moms it's difficult, it's something different. So we give them time to speak. So this makes a special bonding and they seek that midwifery services for the next time also. And since the time this NMTI National Midwifery Training Institute Meerut has been operationalized, we have around more than 3,500 successful antenatal OPDs till now. So going to the how we care actually in midwifery. The same infection prevention policies will be tackled as like that we are tackling in the nursing part. So I think everyone is known about this, but definitely these infection prevention policies are, it's it's not just the reading actually. We have seen in the this district women hospital and many hospitals of the government setting that these are, when inspection comes, that it will be followed, or when someone visit comes, it will be followed. But in the daily routine, it's not that 100% being followed. So this midwifery have that sense. We are following these infection procedures as the private hospital. If you have first picture, I think I have shown. So this is our midwifery-led care unit. It has two birthing suits, we call it. First we have called it the Rose, and the other one is Jasmine. So the first one is having bed. In that we usually, if the mother's choice is to have the birth either on the bed, we help her to have the birth on the bed. And I think in second suit, if you are able to see, there is one this mattress on the floors. If the mother wants her birth to be on the floor, then we can support her to in the squatting position or all fours position on the floors. So, and this environment is very cool, very calm. We are having not actually hydrotherapy. We have actually we can have hydrotherapy, not the water birth. Because it's a government setup, water birth is still not allowed here. But hydrotherapy we can have for the mother to have warm shower. Then we have aromatherapy with this calm, cool environment, dim light. Then having this soft music. She feels that she is at home. The same concept that was at previous to have the birth at home, as it's being the same concept. But here is a team of professionals to identify that complication, to identify any risk, any danger sign, and act at the same time to prevent definitely the maternal and newborn death. So this is the main motto of the midwifery initiative of the Government of India. I think I'm clear? Yes. Is it okay for you? Yes. Are you getting the point for this concept? Yes. Yeah. So partograph, same way that we are started filling, but I'm sorry to say, partograph is being filled after the birth of the baby in most of the settings. Birth has occurred, now the partograph started filling. No, this partograph should be filled when the mother is in active phase of the labor, ideally. So that as a midwife or as an NPM, as a person who is working in the clinicals, we should be alert and known to identify any complication like prolonged labor or precipitate labor, something like that, on the basis of the actual plotting of the partograph. So definitely as a midwife educator, we are plotting the partograph at the time when mother is in active phase, starting from that time till she have the birth. So it's not after the birth or just complete the partograph. It's a very helpful tool that we are using. Nicely is to actually I want to say using it since the time of the initiation of the labor. So now what are the best practices for the labor and childbirth? Definitely birth companion is first of the foremost important thing, because I will tell you what is the role of the birth companion to reduce the duration of the labor, help in the decrease of analgesia, and many more. Then we have different positions to be used according to the choice of the mother. Then we have this oral fluid and food intake for the mother. Definitely IV catheterization that are very leastly required if the mother is not on the orals or she is not a little well. And lastly, non-pharmacological pain relief measures we are using for having the peaceful, cool birth. Now the role of birth companion. I think the role is to support the mother, to help her to identify the danger signs what the mother is usually having, and help her to cope up with the labor process. These are the main three benefits of the birth companion. This slide has been the benefits and the birth companion role has been taken from the Cochrane review actually. These Cochrane review or the Royal College of Midwives, American College of Midwives, they are already established in the midwifery concept. So they have good researches on midwifery, actually midwifery concept. India is starting in the midwifery, so we have a less research, but definitely we are following the protocol of the Government of India under NHM guideline and also the WHO guideline. We are not following the international guidelines, but we are in collaboration with that, we are using our guidelines only to have this type of successful stories. Now this support person, I have told this will reduce the birth duration and also help in the good birth experience of the mother. So this study implies that what birthing companion have the role. I think it has that we identified the prolonged labor, precipitate labor, analgesia need has been reduced very much, need of episiotomy have been reduced. Then we have the decrease in the section rate, newborn are less hospitalized or have less intensive care because of having the birth companion. So these are the benefits actually, and it has taken place, like the reduction in these things have taken place because of the presence of birth companion. So choice of position, I think Kath have dealt with every position like sidelines, squatting, all fours position, what is the advantage of each position. I should not go brief in that. So, but definitely we will support the mother for her choice of position, and these are the choice of position that mother can have. She can be on the birthing stool, she can be on the floors, squatting she have, all fours position, she can be on all fours position. I think all fours, is it clear for my picture? So that is all fours position. She can give birth in standing position or lateral position. And I will be happy to share you that in our emerging midwifery-led care unit, we have around 80% of the mothers who have given birth in the alternate position only. Hardly there are 20%, and they were also in the alternate position just before the birth. At the time when the babies start coming, they prefer the semi-sitting position, not the supine actually, semi-sitting position. And I think it's also clear to everyone like what are the harm that the supine position have. It decreases the blood flow to the baby, it decreases the oxygenation. So the fetal distress usually occurs during the supine position, so we did not prefer the supine position for the mother. We encourage her to have any of these positions what she wishes, or she will be upright in the standing position or sitting position, but definitely no supine position is being encouraged for the mother. So I think this alternate birthing positions is being clear. When the mother feels to have the urge to push, like in this, see this is the bed, this is one of our midwifery educator. The mother is feeling happy in the squatting position. She is holding the bed and she is at the time of urge to push, she is bearing down in this position. And yeah, I can know, you can have the question like it can cause the tear, you are not supporting the perineum. I will be giving answer for that in the next few slides. Yeah, monitoring fetal well-being. Definitely, it's crucial part to monitor the fetal well-being at every phase or every half an hour of the duration of the progress of the mother's labor. When the mother is in latent phase, definitely we can have half an hour, and every half an hour this FHR usually takes. But once she is in active labor, we take more frequently this fetal heart rate. So in active phase, we take every 15 minutes. In second stage, every 5 minutes. And once the baby is out, I think it's over. Now you will again, I think the question arises in the mind, मैडम आप एक जने को एक मदर देखते हैं, हाँ जी, one mother, one midwife. That is the concept. So we are able to maintain this. Definitely in the majority of the government hospital, it's not the protocol. Only one staff nurse have to take care of multiple mothers or the pregnant ladies. At that time, it's not easy to follow these all protocols. But if for the midwifery care, this protocol is must, and we are maintaining it since we are giving one-to-one care to the mother. Fluids and food in labor, yeah, no restrictions for food or any fluid in labor is with our midwifery care. We encourage mother to have SINPS, she can have oral fluids more because it gives more energy, other to have the solid food because it can cause vomiting and she will get irritated or she will get a little annoyed. Restricted episiotomy, definitely. So again, the corporate review says no episiotomy or restricted episiotomy. In primary also, there is no need for episiotomy. If the perineum is well supported, if you have put your hand nicely on the perineum, guarding the part of the head that is coming out, there is no need for episiotomy. It can be like episiotomy is second degree tear, what is known. So might be the mother, if with good guarding of the perineum, she can have only the first degree tear and that is not involving the muscles. So why we are deliberately giving the second degree tear as an episiotomy to that mother? We have again successful births that of the primary also that have even no tear or only the first degree perineal tear. So episiotomy is not unnecessary, mandatory to provide for every primary mothers. Yeah, there are certain indications that like WHO has also recommended in 2017 for the restricted episiotomy or no recommendation for routine episiotomy. But it is suggested in any breech or any malpresentation birth or any this assisted vaginal delivery definitely, or the mother have a previous history of third or fourth degree perineal tear, or the scar is of the episiotomy or tear is not good for that mother. And lastly, any fetal distress to the baby. So these are certain indications in which we are, as a midwifery educator, we are following the protocol of episiotomy. Otherwise, no episiotomy at all. We are happy to have the tear and suture it. One basic reason I will let you know. Again, this is from the Royal College of Midwives reviews that episiotomy, perineal tear is good because it's a natural tear, and natural tear heals more fastly than a deliberate episiotomy tear. I can understand most of the people in this hall would not be agreeing with me, but please just go and refer the researches. You will also find that this is true. And this we are following in the midwifery. So how you would be proficient enough for the restricted episiotomy? I have already told, if you are able to support the birth of the head nicely, you will guard the perineum nicely. When the head is coming with the force, you should be knowing how much, means like just support the mother's perineum, and a slow head should pass from the outlet and perineum. So when this slow head is coming and we are supporting nicely, we are guarding the mother how to, with contraction, how to bear down, when not to bear down, when the crowning has occurred, just be like, take a deep breath, release slowly, don't push too hard. So these all steps or these all parts of the guard helping to guide the mothers will definitely reduce the extent of the tear also. Now, the third stage, after the birth of the baby, definitely the third stage, midwifery concept again have the active third stage management. But yeah, the physiological management of third stage is also being followed if the mother is willing. For that, certain criteria like mother's HB and this should be fine enough for the physiological birth. Otherwise, according to the WHO guideline and NHM guideline, we are following the active third stage management. As the birth of the baby has occurred, the baby is on mother's tummy. That is also very, very, very strict. Skin to skin, breastfeeding for the one golden hour. There is no effect but until and unless there was a meconium or a distress or a baby have a Apgar, low Apgar score. Just after the birth, the initial Apgar helps to make us that decision whether the baby remains on the skin or have the breastfeeding or can need to be taken to the farmer. But if the baby is doing well, It is good, the bars are very nice. Definitely there is no if and but for any essential newborn care to be done, like taking the footprints or the weight or anything else. Baby needs to remain on mother's abdomen, skin to skin, followed by breastfeeding for that 1 golden hour. We delay all the newborn other cares for after 1 hour. Just we have the birth, suture the mother if required, and do our work, this documentation work, but we never separate mother from the baby. So these, if baby is Abgara, nice. So how we are maintaining this quality? Yeah, 1-to-1 care, and there are certain standards that we are following nicely, means up to the mark to have that same quality of the care. Lux guidelines definitely. Safe childbirth checklist, that is also being monitored at every part of that birth, like what is antenatally required, what is intranatally required, everything. And last, the WHO quality of care standards and framework. I think everyone is familiar with the Lux and Safe Childbirth guidelines. I will be just little focusing on the WHO's quality of care standards and framework. So this is the framework in which, according to which we are maintaining the same quality of the midwifery services that needs to be maintained. This quality framework again says we need proper referral, communication, identification in the provision of care, and then in the second part it usually says how we will be giving the respectful choices, respectful care to the mother, her informed choices, communication within the team, with the mothers, help her in decision making. So these both components collaboratively, when we are following, we are able to render that quality services. So be accountable for our good care services. We should this is again the legal and ethical. We should prevent ourselves from the legal and ethical issues, and also serve for the mother and the baby, as like we should help her in every decision making, help do our work according to the scope of practice, do not harm the mother, do not use abusive words, all these things. So, but whatever we are doing, we are documenting it, and we are the signing authority for that as a doctor. So anything, if some comes or some issues arises, definitely we will be in trouble. So better document every part, every deviation from normal, recognize timely, document it, take prompt action, take referral, seek collaborative care, then you will be a good independent nurse midwifery practitioner. So a midwife should be present at every normal birth and do render her services in that. Thank you.
Thank you, Madam Surbi.
I know everyone is hungry. Just if someone wants to ask them questions.
Hello.
Good afternoon, ma'am, and good afternoon, one and all.
Sorry, I used full English. Sorry.
No, it's okay. मैम जैसे आपने बताया है कि आप लोग को एक मदर एक मिडवाइफ्स को अलॉट होते हैं जिससे आप उनकी प्रॉपर केयर और प्रॉपर असेसमेंट कर पाते हैं, लेकिन गवर्नमेंट जो हॉस्पिटल्स हैं, चाहे वो आपके सदर हॉस्पिटल होते हैं या डिस्ट्रिक्ट हॉस्पिटल जिनको बोला जाता है, उनकी हालत तो ख़राब है. ये PSC CSC की हालत और ज़्यादा ख़राब है, जहाँ पे नर्स पेशेंट रेशियो बहुत ज़्यादा है. इनफैक्ट हम ये कह सकते हैं कि पर मिडवाइफ इतना ज़्यादा वर्कलोड है कि वो एक एट अ टाइम एक से ज़्यादा पेशेंट को उन्हें डील करना पड़ता है, और उस कंडीशन में वो हाइजीन तक मेंटेन नहीं कर पाती हैं, बिकॉज एट द सेम टाइम सेम मैकिंटॉश को बिना एक्सचेंज किए, बिना हटाए, सिर्फ स्प्रिट से वाइप करके उस पर नेक्स्ट केस को या नेक्स्ट
कभी वाइप नहीं करते.
हाँ, कभी वाइप भी नहीं करते हैं. मैम उस कंडीशन में क्या इस प्रैक्टिस को हम लागू कर पाएंगे?
That's what I'm saying. आप नर्सिंग प्रोफेशन के अंदर उस चीज़ को आई थिंक उस लेवल पे नहीं कर सकते हैं, बिकॉज यू हैव मच ऑफ द वर्कलोड. बट अगर आप नर्स प्रैक्टिशनर, मिडवाइफ और मिडवाइफरी एजुकेटर बनना चाहते हैं, थ्रू दैट इट्स द कंसेप्ट कि 1-to-1 केयर ही प्रोविजन का होता है. सो इन दैट कंसेप्ट वी आर डूइंग. सो क्योंकि हमारे पास एक ही मदर है, तो अगर एक मदर है, क्योंकि एक्सेप्ट द एजुकेशनल पार्ट, अगर आप एजुकेटर भी हैं तो आपको इतना स्किल, इतने कॉम्पिटेंट आप रहने चाहिए क्योंकि हो सकता है मेरी मॉर्निंग में क्लास हो, बट आफ्टर दैट आई हैव टू बी इन क्लिनिकल्स फॉर 3 आवर्स, तो मैं खड़े खड़े सुपरवाइज नहीं करूँगी। मैं मदर का बर्थ हो रहा होगा तो बर्थ करवाऊंगी, अगर कोई स्टूडेंट मेरे साथ है तो मैं उसको टीच करूंगी विथ हैंड्स ऑन, मतलब मैं उसको हाथ से सपोर्ट करवा के उसे टीच करना है। तो ये मिडवाइफरी का कंसेप्ट है। तो अगर आप मिडवाइफ भी बन रहे हो या एजुकेटर भी बन रहे हो, इट्स नॉट कि आपको दूर से खड़े होकर देखना है, आपको उसके साथ जाना है। तो जब आप 1-to-1 केयर करोगे तो देन यू विल गेट टाइम, नो। तो ये मिडवाइफरी का कंसेप्ट अभी यही है कि आप 1-to-1 केयर देते हो मदर को। चाहे आपके पास लेबर रूम में 10 मदर हो, उसमें से जो लो रिस्क मदर है, फॉर एग्जांपल हम लोग अभी 4 मिडवाइफरी एजुकेटर्स हैं नेशनल मेरठ में। एक ओपीडी करता है, एक इवनिंग शिफ्ट करता है, एक मॉर्निंग करता है और एक यूजुअली ऑफ में रहता है, मतलब ऐसा हो जाता है। अपार्ट फ्रॉम द एजुकेटर पार्ट, अभी एजुकेशन का फर्स्ट बैच पास आउट हो चुका है, नेक्स्ट बैच वी आर एक्सपेक्टिंग। इन बिटवीन दैट जो टाइम है उसमें हम लोग क्लिनिकल मिडवाइफरी प्रैक्टिस कर रहे हैं। तो जब एक मिडवाइफ के लिए लेबर रूम में 10 मदर भी हैं, तो हम उसमें से लो रिस्क मदर ही स्क्रीन आउट करते हैं, इधर फ्रॉम द ओपीडी और फ्रॉम द लेबर रूम, या हमारी मदर के लिए भी सेम जो कंटिन्यूटी ऑफ केयर का कंसेप्ट है। तो उस लो रिस्क मदर को जब तक बर्थ नहीं होगी, शी विल बी माई मदर, आई विल बी टेकिंग केयर ऑफ दैट मदर ओनली। तो उस कंसेप्ट में मैं उसको फॉलो कर सकती हूँ। बाई चांस दैट बर्थ कंप्लीटेड इन 3-4 आवर्स, शी वॉज 7 to 8 व्हेन आई हैव टेकन, 4 आवर्स के बाद मैं दूसरी लो रिस्क मदर लूँगी। इट्स नॉट कि 10 मदर लेबर रूम में है तो मुझे 10 को ही देखना है, इट्स नॉट लाइक दैट। ये एक यूनिट जस्ट एडजेसेंट टू लेबर रूम हाई फैसिलिटीज़ में है, तो उसमें से हम लोग लेबर रूम में से, और अगर हम हाई मदर में से ले लेते हैं कोई भी मदर को, एंड देन वी यूज्ड टू प्रोवाइड दैट 1-to-1 केयर। आई कैन अंडरस्टैंड गवर्नमेंट जो हाईली क्राउडेड फैसिलिटीज़ है उसमें ये चीज़ पॉसिबल नहीं है।
मैम देयर इज़ वन मोर क्वेश्चन कि यहाँ पे पार्ट
डेफिनेटली फुल डायलिटेशन हो तो आप उसको कुछ नहीं कर सकते हो, या फिर क्राउन हो गया हो हेड तो आप कुछ नहीं कर सकते हैं, एकदम कहाँ पार्टोग्राफ करेंगे, बेसिक स्क्रीनिंग असेसमेंट यू हैव टू डू। बट फॉर द मदर हु इज इन लेबर विथ यू, अगेन आई एम सेइंग इन 1-to-1 केयर यू कैन डू, क्योंकि आपके पास 10 मदर होंगी, डेफिनेटली यू विल नॉट बी एबल टू मेंटेन दैट टू दैट एफिशिएंसी कि आप उसका पार्टोग्राफ एग्जैक्टली मेंटेन करें। इस प्रोग्राम के थ्रू हम, दैट्स व्हाट आई एम सेइंग, थ्रू दिस मिडवाइफरी इनिशिएटिव we are practicing, we are doing. I am not blaming the nursing who are already present in this. I know they cannot do, but through this program, if you want to do something for this mother, you can come to this program and you can do this. That's what I want to just say. I'm not blaming anyone. I know it's very hectic for a person to have that 10 words, to do all the documentation, mantra act, ye registers, 50 registers and lakshya guidelines, I can understand. It's not easy for them to do all these things. But अगर आपके मन में उस तरह का फीलिंग है, आप कुछ करना चाहते हैं, something different from that part, you can join.
Thank you, ma'am. Seriously, thank you.
Sorry to someone get hurt. I just never mean to say that nothing is not good. I just want to differentiate the difference. I'll show you the difference between this nursing and the midwifery concept, because many people don't know actually. Yes. Thank you. Anyone? Any other question?
Sir, mic please.
Good afternoon everyone. First of all, I would like to congratulate Madam for her wonderful presentation. I am coming from Tamil Nadu, ma'am. I have served as RCH staff nurse for the 6 years under the government of Tamil Nadu and primary health centers. I have seen so many deliveries. There we don't have any practices like independent practitioners since it's been not launched. But I am very happy that first time I am hearing. I have studied in books that it's supposed to be. I have passed out from 2011 batch MSc nursing. There I have studied. We need to be start soon nurse practitioner likewise. But first time I am hearing that you have started already at Meerut. My question is, how many state it's been started this nurse practitioners, especially midwifery, and why it's been not implemented this kind of nurse practitioner towards other parts of the states, especially in south side and all. We are not at all familiar about it, but I am very happy that you people are doing like 1:1 ratio care. But in primary health centers, if you are saying it's not at all possible, even we are only one staff nurse, we are extending this longevity of the hours of durations of the care towards the patients. Even we are like exceeding our duty hours. After 12 hours also we used to exceed. If other staff nurse is not coming, we have to conduct the deliveries likewise. But you are carrying nicely, but these things, how it should be like strengthened in further towards the other state. What might be the recommendations, whether it is continuous or non-governmental organization, how they pay or how the people are recognized towards your organization. That basic requirements, if I would able to get information from you, I can able to say, give the information to my own state people also. First of all, I would like to congratulate, and I would like to clear about little more doubt related to your organization and about the works, how it should be registered, what could be the recommendation to follow towards other state also, ma'am. Thank you.
Thank you for asking me. Definitely, many people will ask, I can understand, and definitely the caseload is very high. So it's not, it's like I can salute you, like, because you are working more than us. We are working for one-to-one, but you are working for more than like many of the people. This program, since it was initiated, there are many national institutes that are presently working. I have taken my training from the Fernandez Institute, renowned institute from the Hyderabad, and we are the first batch of the midwifery educators. 5 states were selected, and 6 candidates from each state were selected for this program. So Fernandez was following, being it's an obstetrical hospital, it has midwifery concept indulged in it also. Dr. Evita Fernandez, I think if you have heard her name, she is the pioneer in this midwifery field. She has taken that lead, and we have studied this concept from there. After completing it, this state government has posted at National Midwifery Training Institute, and that is at Meerut College of Nursing. It's a government college of nursing. And definitely this national institutes needs to be associated with the nursing colleges. Secondly, so we have presently three national midwifery institutes, one at Meerut, one at Jabalpur, College of Nursing, it's NMTI Jabalpur, and third is NMTI, MGIMS Wardha. So yeah, fourth is NMTI Bangalore. I don't remember the name of the college in which it is. It's government only, but I can say. The government main big college of nursing in the Bangalore. It has been in that college. These are the 4 national institutes that are presently running, and they are undergoing the trainings of midwifery educators. Apart from that, those educators who got trained in these NMTIs are placed at their respective state midwifery training institute, like SMTI Patna, SMTI Cuttack, SMTI in Andhra there are 2. One at near to Tirupati. 2 big cities of Andhra. I don't remember that there are 2 SMTIs in Andhra. No, not Visakhapatnam. I don't remember the name. One is near Tirupati that I remember. I think in Tirupati only it is there. So these are the SMTIs that are already being functional, and there are the educators who have training from these NMTIs. They are working as state midwifery educators and training the nurse practitioner and midwives. These nurse practitioners will go to the further FRUs or the CHCs to have the better maternity care. So this is the basic concept of the Government of India to strengthen and increase the midwifery training institute and have actually reform it into the midwifery cadre. I think, am I clear?
Yes, so clear. Thank you. Thank you.
Any other questions? For the both educator and also the NPMs. Definitely for this time I can say the NHM was taking the persons from those who were already an NHM employee or from the government. But I think in Uttar Pradesh they are soon taking the decision to have from the private colleges also, or the private, like if I have completed my BSc or Masters, I can apply for that advertisement also. So in, I think, near future, like within 1 year or within 6 months, I think they can take decisions very soon to release that advertisement for the public sector also. So they can apply. If they get selected, they can have this free educator. And one thing I just last want to say also, I feel myself to be fortunate enough that once I have joined this program, these are the platforms on which I am able to speak, I am able to convey, I am able to disseminate my knowledge, my things, my concept, and this midwifery initiative has only given me this chance. Yeah.
Thank you for wonderful effort you have taken for giving dignity to the women, and I appreciate you for that. And I appreciate the part you have taken about photograph. And I have different opinion. Like if we have 10 students posted in the labor room, I think we can practice to do the photograph. Why don't we teach the students to do the photograph, so that the student will be able to practice the photograph, and why not within a year she will also become a midwife and she will be able to practice the photograph.
Yeah, madam, I just want to say, I'm not saying we cannot teach to the students. We are teaching the students, but when they become more this workload, and they know it, but they are not able to plot it.
And
that's what I'm saying.
most of the facilities, students will be there.
Yeah, if they are having students, the nurses who are already posted there, they can make use of these students to start the photograph for the mother who is in the labor, and definitely we can have nice recognition for this.
That's what I have understood.
Yeah.
It's not that difficult to teach the students the photograph.
It's not difficult.
And they will learn. That's what I feel.
Yeah,
and they are able to
learn,
do that.
they know, they can learn, they can do.
And this
they
will
can
be
recognize. Just the need of the hour is to do.
Yeah. So and this will be very help to the staff nurse also.
Yeah.
This is what my suggestion.
Thank you. You are right.
Thank you, ma'am.
You are absolutely right. This concern is like, I am very okay with you, because students can make use, they can help the staff nurse who is only one or two to have all these things being performed properly.
Thank you, ma'am.
I would like to congratulate Surabhi Madam for such a wonderful present, which is supported with the evidences from Cochrane review and all. And one more thing I would like to add, that this initiative is very good from the government of India. Even myself has experienced this, not during the labor. I have delivered my child in private hospital. After that my baby got into NICU and I have to go to feed there, but the nurse there was like, I had to express the milk and then give, and I don't know how to express it. We read a lot, we have the knowledge, but when it comes to practice and to us, then we need actually sometimes the counseling and the how to do that. But that nurse was really very horrible. I don't want to name the hospital. And at that time I was so physically weak, psychologically also weak, कि it was like कि मेरा मनोबल और ज़्यादा गिर गया कि oh, I cannot take care of my baby. So this respectfully maternity care, isn't it, ma'am? You are talking about after postpartum also. We are supporting the mothers.
Yeah, ma'am.
So
that's what the continuity care of this concept is. Once we have that birth, we have that mother for 2 hours with us.
Yes.
We teach her the best breastfeeding techniques, what are the benefits, everything. Then we have her follow up on the next day, because she usually gets discharged within 48 hours for the normal vaginal birth. We teach her about the family planning also. We are starting, actually ma'am, we are practicing in a little different way. In antenatal only we are starting this through our childbirth classes concept. We are teaching her with the newborn care, family planning, a little about the breastfeeding. I know without doing we cannot have that, like teaching beta aise pakadna, aise rakhna, haath aise rakhna. It's not that. Classes we are teaching, we are showing videos, but when it comes to your baby, when you are holding that baby, तब कैसे करना है, सही कर रहे हैं या नहीं कर रहे हैं, that also needs supervision, counseling. So that also we are doing this. We are helping that mother to hold the baby, have good position, latching. ये concept हमारा है. और I just support you because I have also 2 babies, and definitely I was also being expected this likely would to have that normal vaginal birth, but no one told me that antenatal exercise can expand my pelvis. It can help in the engagement of the baby. doctor said, your baby is not engaged, it is free floating, you will have a C-section. Oh my God, I have never thought that I can have C-section. Or you won't believe, being I am from basically nursing practice background, एक सुई लगाने से भी मुझे इतना रोती हूँ मैं अभी तक भी, खुद को सुई लगने से मतलब, दूसरे को लगाने से नहीं. So it was a concept कि मैं इतना खुद रोती हूँ कि कैसे मैं cesarean कराऊँगी. Still baby free float है और cesarean होगा. And on my OT table, frankly I was saying भगवान मैं ऊपर ना पहुँच जाऊँ, बस ऐसा I was praying. तो it is very drastic कि हमें कोई बताने वाला नहीं है. अगर antenatal period से ही हम exercise करते, तो I would have done definitely मेरे baby engage होता, because I was low risk in full pregnancy. I don't have any complication at all. Touch wood. दोनों pregnancy it was uneventful. I was having nice HB, no risk factors, nothing. But still I have section. So can you believe? मतलब और जबकि मैं इतनी दौड़ती भागती हूँ, सब मुझे कहते हैं तुम रोबोट जैसे भागती रहती हो. तो सब ये नहीं कि एक्सरसाइज ये भी टाइप की एक्सरसाइज है. Still I have section. So it's very uncertain कि किसका section होगा, कौन low risk रहेगा, किसको pains आएंगे. But we can teach them, we can motivate them, we can give education, we can counsel them so that they can have the normal vaginal wall. It's our motto. हम section करने ही नहीं देते. हम last moment तक अगर पार्टोग्राफ ठीक है, we are plotting it, mother is okay, we are promoting for the normal wall. चाहे उसके लिए हो सकता है second degree tear हो जाए, हो सकता है because मदर को फोर्स कराना, हेल्प करना, टाइम ज़्यादा लगे, लेकिन वी आर सपोर्टिंग इट. वी आर नॉट एट ऑल फेवरिंग फॉर द सिजेरियन सेक्शन.
Thank you, ma'am. Thank you for your session. And this is a very good initiative of the Government of India. We hope that this initiative go a long way and whole India will be covered in the future. Thank you.
Thank you for asking so many questions. I'm very delighted that everyone have an enthusiasm. They want to know about this program, this initiative. Thank you very much.
Thank you, ma'am. Now I request our principal ma'am, Dr. Deepti Shukla, and also Sunita madam, please kindly come on stage. I also request our director sir, Dr. VP Tiwari sir, please kindly come on stage to felicitate with a memento to our speaker and chairperson, please. A big round of applause. Kindly come on stage. Madam was speaker for a pre-conference. Thank you, sir. Thank you, ma'am. So we will move towards our lunch. We will take half an hour, 45 minutes for lunch, and we will come back within 1 hour.
अपनी आंखें बंद कर लो. एक मिनट के लिए आंखें बंद कर लो. सब कर लो। कल आपसे कहा था कि जो जो राधे जपेगा उसको कृष्णा के दर्शन होंगे। तो आंखें बंद करके रखना, चीटिंग नहीं, नो चीटिंग, बिल्कुल चीटिंग नहीं। देखिए ये कृष्णा है और असली वाले कृष्णा हैं जो देवकी और यशोदा के घर में थे ना, ये वो वाले कृष्णा हैं। छू के देखना चाहते हो, छू के देख लो। कौन कौन कृष्णा के हाथ से अपने फोरहेड पे टीका लगवाना चाहता है? दौड़ के आ जाओ, क्लास शुरू हो उससे पहले दौड़ के आ जाओ, नहीं तो फिर नहीं मिलेगा आपको मौका। तुम चाहते हो कृष्णा तुम्हारे पास आए? कृष्णा नहीं आएगा। जल्दी आओ, जिसको भी करवाना है। देखिए बहुत बड़ा भाग्य का विषय है कि कृष्णा के हाथ से अगर आपको टीका मिलता है तो पैसे नहीं लगेंगे। ये मत सोचना कि टोकरी में कुछ डालना भी पड़ेगा। जोरदार तालियां। देखो एक मैम आ रही हैं कृष्णा के हाथ से। अभी अभी जन्माष्टमी निकल के गई है और गोपाष्टमी आने वाली है।
वैसे तो कोई गुण नहीं है, मैं अवगुणों का भंडार हूँ, लेकिन अगर इस जन्म में भी आपने कृपा की तो न जाने फिर कितने और जन्म मेरे व्यर्थ हो जाएंगे। और मैं आपकी कृपा से वंचित रहना चाहती हूँ, क्योंकि ये मेरा प्रथम जन्म नहीं है। न जाने कितने और जन्मों में भटकते भटकते मेरे जन्म लेते हैं, लेकिन अब की बात मैं आपकी शरण में
और आप मुझ पर कृपा अवश्य करेंगे, ये मेरा विश्वास है, ये मेरी आशा है। और उस आशा से वक्त पहले भी व्यर्थ हुआ, कई बार जीवन
finished all our session in our conference, and this is the valedictory session we are going to start. So I would like to extend a warm welcome of our chief guest, Dr. Colonel Vinod Kumar Singh. Sir is a AMC veteran, retired as a senior advisor and HOD I Department, Command Hospital, Lucknow in 2005 after 34.5 years of military services. Sir is graduated in 1970 from MLN Medical College, Allahabad, participated in 1971 Indo-Pak War and served in Jammu Kashmir and field area up to 1976 as a medical officer. Sir did DOMS and MS from Opthal in 1979 from FEMC Pune, served as eye specialist in military hospital. Sir has managed ocular injury cases of Kargil conflict brought to the tertiary hospital, Command Hospital. Sir took part in academic activities and published paper in peer-reviewed journal. And now Sir is enjoying a peaceful retired life. So big round of applause for Sir and very welcome you, sir. So now I would also like to extend my warm welcome to our guest of honor of the day, Dr. D.S. Negi. Sir is right now ex-Director General Medical and Health Service UP. Sir was a part of Ram Manohar Lohia Combined Hospital Lucknow and also Dr. Syama Prasad Mukherjee Hospital Lucknow as a Director and Superintendent-in-Chief and CMS. Sir was previously joined Director Lokbandhu Hospital Lucknow, also was a Director General Medical and Health from UP. Sir was a Director Administration from the Mayo Institute of Medical Science, Barabanki. Thank you, sir, for taking your time to be with us today. And welcome you, sir. I would also take the opportunity to introduce our next guest of honor, Madam P.T. Kaul. Ma'am is a retired Director and Professor, School of Health Science, IGNOU. Ma'am is a former Professor and Dean, State University, Gurugram. Ma'am has served as a Professor and Director, IGNOU, New Delhi. Was a former Project Director for Community Health Officer Program, developed in collaboration with the HFW, Government of India, and implemented across the country. Ma'am has been worked as a former Professor and Dean Faculty of Nursing, State University, Gurugram. Ma'am was also former Supervisor and Lecturer in Nursing Education and Administration at SKIMS, Shoda, Srinagar, Jammu Kashmir. Ma'am has received National Florence Nightingale Award by the President of India in 2017, Award of Appreciation by ASV Indian Tree Planting in the name of Professor P.T. Kaul. Ma'am was got Life Achievement Award from NSS and also Best Nurse Award from NSS. Ma'am was also awarded with Best Teacher by the NTAI 2022. Ma'am contributed to research at national level by guiding more than 18 PhD scholars who were awarded and facilitating around 35 PhD scholars for completion and award of doctoral degree across the country. Ma'am hold various positions: lecturer, supervisor, assistant supervisor, associate professor and professor and director. We welcome you, ma'am. Next, before we move on, I just request and invite our students to welcome dance.
लौट के तुझको आना है, सुन के दीवाना है। तेरा दर्शन पाएंगे चैन तब हमको पाना है
We are taking only 1 minute. Kindly keep patience, maintain a silence. I request all the delegates, please maintain silence. And have an honorable seat on the stage. I request volunteers, please kindly escort our. I also request our guest of honor, Dr. D.S. Negi sir. Sir, please kindly come on the stage. I request the volunteers. I request our chairman, sir, Dr. R.S. Dubey, sir. Sir, please kindly come on a stage and have an honorable seat. I would also invite stage. I request PT call ma'am also. Ma'am, please kindly come on a dais. I request Director Sir of Pushpanjali College of Nursing, Mr. Rajesh Gupta sir. And I request Principal of Samarpan dais. So without any delay, I request all the dignitaries for lighting the traditional lamp lighting. Thank you, sir.
And distinguished in front of us. पहले तो मैं समर्पण परिवार की तरफ से आप सबका हार्दिक स्वागत और अभिनंदन करता हूँ कि आप सब यहाँ पधारे और आपने इस समारोह को सफल बनाया। Though many things has been said about the chief guest and guest of honor, I would take only 1 or 2 minutes to say that this is the second international conference being organized by the Samarpan Institute here. Last year we organized a hybrid conference that was mainly on the online conference on telemedicine, and this year is in hybrid mode, offline and online both. The topic very well note about the transforming perspective of nursing research leading to clinical innovations. We all know how much important is the research, and many times we use many words. We use sometimes seminars, symposia, workshop and conference, and we need to differentiate between them. And I must say that this is a conference. It was not a seminar, symposia or workshop, because when we have a varied type of topics and it goes for 3, 4, 5 days, and where we have a different type of experts from varied topics from varied disciplines, then it converts into conference. The aim of this conference was mainly to bring the experts from different parts of country, from different parts of world together to exchange their ideas, to have some experts knowledge, discuss and come out with the solution what we are facing in the nursing research. Nursing research definitely helps nurses about knowing the advanced skills and how to have effective and quality care to the patients. There were about 13 to 14 topics in this conference. The important were, few of them were the advanced technology in natural birth nursing, then about the technology, strategy and solutions, about the infant feeding also. There were palliative care, advanced forensic nursing science, how to write a quality research article and paper, how to publish them. There were so many different type of topics. And we were fortunate enough to have a galaxy of eminence. If you see your brochure, you will find at least 47 people from 7 or 8 countries and about 15 to 16 states of our country. And in this 4 days we have about more than 1,000 delegates who attended this conference and the pre-conference workshop to update their knowledge. And our team, under the leadership of Dr. Deepti Shukla, took wholehearted effort, untiring effort since so many days, and they organized this conference in a 50 manner. The time was short. Before 1 month, we will have a TNI, SNI, UP state meet in our campus itself. And after finishing those things, within a span of I think 15 and 20 days, our SINPS team has done a commendable job. And we need a lot of applause. With these words, I welcome the chief guest of the lecture session, Honorable Colonel V.K. Singh Saab, who accepted our invitation at the very last moment. Only yesterday, I was not aware, yesterday I came to know from our chairman, sir, that Colonel V.K. Singh Saab is coming as chief guest. So we are fortunate enough to have you among us, and we are really, really grateful that you have accepted our invitation at a short notice, and you agreed to come over. And for that, I, on behalf of Samarpan Group, on behalf of the organizers, and on behalf of the whole team, I extend my heart welcome to you, sir. We have guest of honor among us, Dr. Negi sir, who is the retired Director General Medical Services. It has been told, I know sir, when he was in Lohia and chairman Samarpan Group, he was also in Lohia Institute since that time. So Negi sir is like our family member. Whenever we have any function, we just make a call and he never says no. Sir, you have a lot of affection to us. You are our family member and you have accepted our invitation. You came here. We are really, really grateful, sir. We welcome you in this conference. I think Professor Pitikol doesn't need any introduction. She is a stalwart in nursing. Many things have been said about her. Though I am not from nursing, but once Dr. Shukla prepared this brochure, so I tried to go through the biodata of all my speakers. And I must say that now I know anything about our speakers and chairpersons. It has been said, she is not only from nursing. I have found that she did her BSc from RKS College of Nursing about 40 years ago, in 82. And then, after that, she did not do the MSc. Then she got a degree in MA in public administration. I think many people might be not knowing. So she is a very versatile personality. And after getting that MA degree in public administration, then she did MSc in pediatrics. And finally, I am proud enough to say that she got her PhD from a very reputed university, that is Jamia Millia University, about 20 years back. Madam is a stalwart. She was in the School of Health Sciences in Indira Gandhi Open University as the director, founder and director. She is professor and dean in SGT University. Everybody knows about we are proud to have you among us. She is a rare gem in the nursing field. So I welcome you on behalf of Samarpan family, on behalf of the organizers. I welcome our chairman, Professor Dr. R.S. Dubey. Without his untiring support, unconditional support, it was not possible to organize this conference. When we told that we want to do, he told whatever you want to do, whatever your college want to do, you do. I have all my support. Whatever you want, just say, I need this, we will provide. But you go ahead. He never interfered and he supported in each and every possible manner. And this conference becomes successful only because of the support of our chairman, sir. So I welcome him. Yes. And now I think chairperson of this conference is Dr. Deepti Shukla. Because we are from not nursing field, she is from the Uttar. He is director, Puspanjali College of Nursing, Agra. When we prepared this, at very last moment, I think I told Gupta Sahab, we are going to do this conference, would you like to join us? He never took a second. He told that, whatever you want, whenever you want to do anything, you always take me, I like associate. So I am grateful that he agreed to get associated with this conference, and we have done this wonderful conference in this campus in collaboration with Puspanjali College of Nursing. He and us. I welcome you, Gupta Sahab, in this presentation. I have many people in front of you. Now in 3 days, I have come to know the name of each and every person present here, but time is short. So I welcome the experts coming from Shimla, coming from West Bengal, coming from the Tamil Nadu, coming from the Punjab, coming from all parts of the country. And we have participants, delegates from different nursing colleges in UP and from other states also. We have a faculty. I have Dr. Verma from Shimla. Many people, by the way, sitting here, the Fatima College of Nursing. So I would not please here. So there are many people sitting here, although it is not possible to take name of each and every person. But on behalf of the organizing committee of this conference, I welcome you all in this validated session of this conference, and I hope that with the input of you people, this conference has been a grand success, and the outcome of this conference must be an eye-opener, and it will be very helpful to the government of UP to advance the nursing education in the state and in the country also. With these words, I once again welcome each and everybody present in this hall. Thank you very much. Jai Hind, Jai Bharat.
Principal Ma'am, Samarpan Group, Dr. Deepti Shukla Ma'am, to present a presentation on this conference report.
Jai Hind. Jai Hind. I will have it up, A very warm good evening to respected chief guest of honor both, our chairman sir, director Samarpan, director Puspanjali, speakers from different parts of the country, and the chairperson from different parts of the country and the state, and my dear delegates, all the delegates. So it is very tough to have a conclude all 4 days conference, means 3 days conference including 1 day workshop. This conference is very tough, but I tried my level best to have 4-5 slides within half an hour to just summarize what we studied in last 4 days and how many people joined us. Yes? When it is not visible. Slides. Okay. So we started our journey on 7. That was the pre-conference workshop, and I'm proud to say I'm not going to summarize the workshop because valedictory session is already over for that. So more than 700 delegates for the workshop. This conference is held in the Samarpan Institute of Nursing with the association of Pushpanjali College of Nursing, and we planned that 3 days conference will be there. Then my expert says you have to go with one workshop also. Then we decided we have to have a workshop, and it was on the simulation based nursing practices. And nearby 700 students came and they enjoyed the time with our experts. They learned about the active management of third stage of labor. They learned about the PPICD, ICD, CPR and newborn resuscitation along with the theory block. So it was a wonderful and successful workshop. Now I am coming back to the conference. It is 3 days conference from 8th to 10th September. Today is 10th. We are having our valedictory session, and now I will move forwards. So total 580 registration for this conference, though I have a capacity of only 350 people to sit inside this hall. We have online, next we are having online registration. So it is a huge amount, 580 registration, and we have 6 registration. One is from China, Russia, Netherlands, Nepal, Bangladesh, and others from India itself. We are having more than 30 chairperson in this 3 days conference from different parts, and 24 speakers. So I can say the chairperson started from Jammu Kashmir to Kerala. So everyone gone through that in the last Lieutenant Mercy, she was from the Jammu and Kashmir. So it was only left over the Jammu and Kashmir also joined us at the end. So we are having all the chairperson from the top to bottom, and the speaker from different areas. I just took a little bit name from there: UP, MP, Gujarat, Maharashtra, Karnataka, West Bengal, Himachal Pradesh, Uttarakhand, Bihar, Tamil Nadu, Nepal, Haryana, Delhi, Punjab. So these are Nepal I am leaving, and these are rest Nepal. These are the national speakers, and then we have the international speaker from UK, Philippines, UAE, Nepal. So it was there, and the chairperson from Jammu Kashmir, again West Bengal, UK, Punjab, Haryana, Himachal Pradesh, Rajasthan, Karnataka, Madhya Pradesh, Uttar Pradesh, Jharkhand, Tamil Nadu and Delhi. There are so many people joined us in this conference, and the first day our chief guest Shri D.S. Mishra sir, IS Chief Secretary, he himself inaugurated this conference, and we are proud that we heard his voice, and whatever the thinking he is having about the nursing, it was explored. And today I just gone through his Twitter account. Everywhere Samarpan, Pushpanjali. So it's really a proud feeling. So day 1, so many topics covered. I will take the very important topic in this time, that is effective governance and leadership in higher education institutions, is taken by Professor Dr. P.T. Gol Madam. It was a wonderful presentation we had gone through with. Then we have palliative care, then effective ways of structuring writing, already sir has said. So we have so many good speakers fantastic sessions we had, and I wish that everyone enjoyed. Yes. Then along with that first day we have poster presentation. In that 16 paper and 5 poster presentations were there, and we got winners also. That is already awarded, but one is pending. We'll award afterward. Day 2 we have another advanced crisis interventions, then evidence midwifery practices, advanced forensic nursing, then practice in India and worldwide, innovative challenges, midwifery, this is evidence based, so many topics on the second day also. That was also a fantastic session, whole day. We enjoyed. I am seeing that from 9 o'clock up to 6 o'clock everyone is sitting here. Yes? Yes, ma'am. सारे टॉपिक अच्छे थे? Yes, ma'am. सीख के जा रहे हैं? Yes, ma'am. अभी मैं आपको बताऊंगी कितने कॉलेजेस ने मुझे ज्वाइन किया है, तो और भी अच्छा लगेगा कि इतने लोग हमारे वहाँ से कुछ सीख के जा रहे हैं. Then day 3, this is today. We have a panel discussion, challenges and solutions in implementing evidence-based practices in community settings, then foresting and revisions on innovative approach to the child health care, current advances, simulation-based nursing and evidence-based midwifery practices. And we do have our online sessions. I got only one picture. So we have two online sessions, yes? Yes. And we have some pictures here for the cultural eve. 1 or 3 pictures I just put it here. I think everyone enjoyed in the dancing? Yes, ma'am. So it was all about this. Just I will like to put some points here. How many colleges join us in the registration? It is 49. So some I am taking. I am starting with the Azamgarh AICC EDS College of Nursing. Thank you so much for coming here. Rajendra College of Nursing, Pushpanjali College of Nursing, Era College of Nursing, Ganesh Sankar Vidyarthi Memorial Medical College Kanpur, Sahara College of Nursing, Nirmala Institute of Nursing Hardoi, FI College of Nursing, Government College of Ayodhya, Fatima College of Nursing, Ankleites, PCM College of Nursing, B.R. Ambedkar Nursing College, St. Mary's College of Nursing, Uttaran Sambhunath Research Institute Prayagraj, Akhil Bharati Vidyapit College of Nursing Prayagraj, SN Institute of Nursing and Nirvan Jaipur. And then Deves from Udaipur, RIMS from Ranchi, IMT from Meerut, Ma Sharda from Prayagraj, Nirmal from MP somewhere, Baba College of Nursing, Model Schools, Rudrapur, Anand Nursing College, Meerut, Sultanpur College of Nursing, MSCDS, that is Bahraich, TMU, Moradabad, Koraput College of Nursing, Jeevan Jyoti, Sankar Nursing College, King George Medical College, Raghuvendra Hospital somewhere in Kanpur, Rashri Darshak, that is in Ayodhya, Ganga Shield, MS Institute of Nursing, Lucknow, Savitri Hospitals, Radha Govind, TS Mishra, Mahamaya Rajpeet somewhere, Ambedkar Nagar, Hayat, Utkarsh, RK Singh Hospitals, that is Chitrakoot, then some from Patiala, Principal Government College of Nursing, Ramanar Loya, CMS, Maheshwari, College of Nursing, Aligarh, CKD, that is Jhunjhunu, Rajasthan, Vedanta, that is Vedanta School of Nursing, where is it? Vedanta School of Nursing somewhere, this is SG in Maharashtra. So there are so many colleges that joined us in this conference. Thank you so much everyone for coming and joining us, making us proud to have more than 49 colleges along with us for this conference. It was wonderful experience with all of you, and I don't have much what to speak. I'm getting emotional actually. Thank you so much for joining, and I'm saying every year we are having one national workshop, one national conference, one international conference. So these 3 I completed in this year. I am आप लोग को आगे के लिए I am just welcoming you for again a national workshop, national conference and international conference in 2024. Please do come. Thank you so much for coming. Thank you on behalf of Samarpan. We have a chairman is in the picture because he is only one for everything behind this. So thank you so much for coming. Thank you so much for this. First, almost I will like to introduce poster presentation का एक winner हमारे पास रह गए थे, प्रज्ञा सिंह. If she is here, she can come. And I request our chief guest, sir, guest of honor, to come forward for the presentation along with the chairman, sir.
DS Negi sir, Dr. Professor P.T. Kaur, Dr. B.P. Tiwari, श्री राजेश जी, सभागार में उपस्थित सभी ज्ञानी जन, चेयरपर्सन, स्पीकर्स, फैकल्टी मेंबर्स, इस संस्थान के लिए आज एक बहुत महत्वपूर्ण दिन है और मुझे आप सबका आभार व्यक्त करते हुए बहुत खुशी हो रही है कि आप सब ने इन परेशानियों के बावजूद जो पिछले 4 दिन से हम लोग एक साथ एक भावना से, एक विचार से, एक लगन से इस हाल के बाहर साथ में बोलते, बात करते, खाना खाते, परेशानियों को झेलते हुए बिताया है, वो काबिल तारीफ रहा है। उसके लिए मैं आप सबका धन्यवाद ज्ञापित करता हूँ। जैसा डॉक्टर दीप शुक्ला ने बताया कि इस 4 दिनों में जो आप लोगों ने ज्ञान प्रदान किया है और ज्ञान अर्जित किया है, वो निश्चित रूप से आने वाले समय में आपकी योग्यता को बढ़ाएगा और आपके ज्ञान वर्धन करेगा। प्यारे बच्चों, जितने ही फैकल्टी मेंबर्स, चेयरपर्सन्स आए हैं, आप जिनका मैंने सुना है, देखा है, इन सब ने ये तभी अचीव किया है जब इन्होंने अपने फुल डेडिकेशन से, पूरी लगन से, पूरी इच्छा से इन्होंने अपने ज्ञान का अर्जन किया है, अपनी ट्रेनिंग की है। उनके द्वारा दिए गए ज्ञान को, उनकी पर्सनैलिटी के एस्पिरेशन से, उनसे कुछ सीख करके आप जा रहे हैं और कोशिश कीजिए कि आज दिन उनका है, कल दिन आपका हो। आप में से बहुत से लोग, मैं चाहूँगा कि आने वाले 8-10 साल में इस लेवल पर आप आ जाएं कि आप यहाँ बैठें, क्योंकि समय की गति है, ये समय आता रहता है, जाता रहता है, पानी का बहाव है। फादर चाइल्ड ऑफ मैन कहा जाता है। चाइल्ड इज द फादर ऑफ मैन, मैं गलत बोल रहा था। तो जो चीज़ है कि आप आज बच्चे हैं, लेकिन कल आप यहाँ पे आएंगे, बढ़ेंगे, करेंगे। हम अपनी बात को ज़्यादा नहीं खींचते हुए बस इतना ही कहूँगा कि मैं डॉक्टर दीपी शुक्ला और उनकी टीम को और अपने डायरेक्टर तिवारी को जितनी मैं बधाइयाँ दूँ, जितना कि मैं तारीफ करूँ, वो कम है। कि जिस तरह से लगातार एक के बाद ये लोग इन्होंने काम किया है, वो सराहनीय है, अतुलनीय है और प्रशंसनीय है। डॉक्टर कर्नल वीके सिंह साहब, डॉक्टर नेगी, हमने जैसे ही कल इनसे कहा कि भाई आप लोग आना है, इन्होंने एक भी क्षण नहीं लिया और विजिटली मैंने कहा ठीक है, मैं ज़रूर आता हूँ। और आपके बीच में आए, मैं 200 दिन के बारे में भी कहना चाहूँगा। कर्नल वीके सिंह एक बहुत ही रिनाउंड आई सर्जन हैं, प्रोफेसर हैं। ये सौम्यवादी हैं, बोलते नहीं हैं पर काम करते हैं। एक अच्छे इंसान है, ह्यूमन बीइंग है। जितनी की तारीफ करूं उतनी कम है। इन्होंने जम्मू कश्मीर में शुरू के दिनों में 1971 वार में, कारगिल युद्ध में, यानी आप जहाँ देखेंगे वहाँ पे अपनी सेवाओं के साथ ये आर्मी में मौजूद रहे और उन्होंने अपनी उन जवानों को अपनी सेवाएं प्रदान की। हमारे गेस्ट ऑफ ऑनर डॉक्टर DS नेगी, हमारा इनका बहुत लंबा साथ रहा है। हम लोग 1998 से साथ रहे हैं और एक कहावत आपने वो सुनी कि चोली दामन का साथ, तो हमारा इनका चोली दामन का साथ रहा है कि मैं सर्जन था, ये एनेस्थेसिस्ट से। ही इज सो एक्सपर्ट इन हिज फील्ड, ही इज सो एक्सपर्ट इन हिज फील्ड, आई कैन नॉट से यू। यानी जब भी डिफिकल्ट केसेस मुझे ऑपरेट करना होता था तो मैं इनके पास भेजता था, मुझे देखता था इसको करना है कि नहीं करना है, क्योंकि मेरे पास केस जो डिफिकल्ट आया करते थे, नॉर्मली केस नहीं आते थे। और जब इन्होंने क्लियरेंस दे दी, यस सर यू कैन गो अहेड, तो मुझे ज़िंदगी में पलट के नहीं देखना पड़ा या कभी कैजुअलिटी का नहीं सामना करना पड़ा कि हमारे पेशेंट को कुछ हो गया ड्यूरिंग ऑपरेशन या आफ्टर ऑपरेशन। ये इनकी काबिलियत है, ये इनकी ट्रेनिंग है। उसके बाद जब इनको मौका मिला तो उसके बाद आप सुना ही कि उन्होंने अभी भी आर्मी में रहे हैं। ये ऑल्सो इन आर्मी, बताना भूल गया, मेजर पर 60 में गए थे, वहाँ से आए थे और अपने काम में माहिर हैं। मैंने आप तारीफ करी थी। उसके बाद फिर समय के अनुसार अपने प्रशासनिक पद भी चले गए। तो हाईएस्ट पद होता है डायरेक्टर जनरल मेडिकल हेल्थ सर्विसेज का, उस पद से रिटायर हुए। लखनऊ के हर कॉलेज में यहाँ हर हॉस्पिटल में, बड़े बड़े अस्पताल में उसमें डायरेक्टर रहे हैं। ये भी इंसान के नाते बहुत अच्छे इंसान हैं, बहुत अच्छे वक्ता हैं और ये हर महफिल की जान है। मैं बताऊँ आपको, ये सच नाइस सिंगर। जिस महफिल पे जाते हैं वहाँ समापन देते हैं, ये इनकी खास बात है। वो आप पे डिपेंड करता है बाद में कि क्या ऐसे करा लेते हैं आप लोग। मैंने परिचय दिया इनको आपको। तो ये महान हस्तियाँ स्टेज बैठी हैं। डॉक्टर पीटी कौल के बारे में आपने सुना ही, हमारे डायरेक्टर ने बहुत बता दिया इनके बारे में। इनके बारे में कुछ कहना ही, सूर्य को दीपक दिखाना होगा, क्योंकि मैं जितना ज्ञान इन्होंने अर्जित किया, जितना इस फील्ड में काम किया इन्होंने, उसकी प्रशंसा जितनी की जाए वो भी कम है। तो बच्चों में परिचय आपको इसलिए दिया कि जो लोग सामने बैठे हैं डायस पे, डॉक्टर तिवारी के बारे में मैं ज़्यादा कुछ नहीं कहूँगा क्योंकि हमारे अपने हैं। ये कहें मेरी तारीफ की जा रही है। राजेश जी का बताई दिया लोगों ने कि एक बात पे हाँ भर देते हैं, अभी नाइन को आता ही नहीं किसी चीज़ के बारे में, ये इनकी खूबी है। डॉक्टर तिवारी के कोई काम नहीं, फाजूल है ही नहीं जो हम कर डालेंगे। तो सब भूतियाँ बैठी सामने डायस पे। और मैं इसलिए इतना बताया आप लोगों को कि जब तक आप अपना टारगेट लेके नहीं चलेंगे बच्चों, इसे हमारा पर्पस बताने का था कि आप लेके नहीं चलेंगे तो इस पद को आप अचीव नहीं करेंगे। ये समय बड़ा थोड़ा होता है। अब BSc कर रहे हैं तो 4 साल के में से 2 साल 6-7 साल का होता है, बाद PhD कर लेंगे। तो इस फील्ड में आए हैं तो आप ज़रूर सीखें, नॉलेज गेन करें और क्लिनिकल सेंस बहुत ज़्यादा डेवलप करें। मैं बार बार कहता रहता हूँ कि उस पर आप जरूर बैठने का। मैं थोड़ी देर आया था, प्रोफेसर कात्यायनी मैम कल बात कर रही थी, मैं देख रहा था कि ऐसा लग रहा था कि मेरे वर्ड्स को छीन रही वो, यानी जो मैं बोलता रहता हूँ, बात करता रहता हूँ, लोगों से कहता रहता है, एग्जैक्टली वही बोल रही थी। हम कहते कि ये बात है, ये चाहिए टू बिकम ए वेरी गुड नर्स इन दिस फील्ड। वही सेम बात आपके चीफ सेक्रेटरी महोदय ने कही थी कि आपका नर्सिंग से शुरू होता है, माँ से शुरू होता है, कहाँ कहाँ पहुँच जाता है। तो हर बातें सब मिला के बातें एक ही हैं, बस ये है कि हम कैसे परसीव करते हैं, कैसे आगे बढ़ते हैं। इन चंद शब्दों के साथ अपनी बात मैं समाप्त करूँ कि आप लोग जाने की भी जल्दी होगी। मैं इतना ही चाहूँगा कि आप लोग जितना भी ज्ञान आपने अर्जित किया है उससे अपने लाइफ में ले आएँ, अपने को आगे बढ़ाएँ। पुनः एक बार आप सबका आभार व्यक्त करते हुए, बधाई देते हुए, शुभकामनाएं देते हुए बात समाप्त करता हूँ। जय भारत।
Thank you, sir. Now I request Dr. P.T. Goel ma'am to share some experience to our audience.
A very good evening to all of you. Respected Colonel Negi sir, chief guest of the day, Dr. Colonel Vinod, respected Colonel Vinod, chief guest of the day. I will not speak the names now. I think I have Dr. Colonel Vinod, chief guest of the day, Dr. D.S. Negi, guest of honor, Dr. R.S. Dubey, chairman of the Samarpan group, Dr. Tiwari, director, Dr. Rajesh Gupta, director of Pushpanjali College of Nursing, Dr. Dipti, the principal of Samarpan Group College of Nursing. I must start by congratulating one and all whosoever was involved in this conference and also the workshop which was held ahead of the conference, maybe at the government level, maybe at the mission level, maybe at the institutional level, and maybe at the college level, and with specific reference to Dr. Dipti and her team for organizing such a wonderful conference. Because organizing such events take lot of hard work, take lot of energy, take lot of time, and also take lot of commitment over and above all the time and hard work. The commitment of nurses is very, very important. So I congratulate them all for this wonderful event. Henry Wordsworth has said that greater is the beginning, but great is the beginning, but greater is the end. So both the things are great. Great is beginning, but greater is ending. So both are wonderful. Both these events were wonderful, the beginning as well as we see in the end also. For last 3 days, I also have been here for attending the various sessions, and you had really collected a cream of experts, a cream of intellectuals among nursing and other fields all over the country, rather all over the world, who came together with torrent of information and ideas and shared a wealth of knowledge and advancement with you. But just sharing of wealth of knowledge and advancement with you is not enough. It's not enough. It is how much we all have been put across in your minds, and how much we have been able to make you, to enable you to deliver it at your own workplace or at your own institution. That is more important. You all know that with the advancement of information and technology, with the advancement of biomedical equipments, the treatment technology, the globalization, and also the internationalization of nursing and the high demand, the nurses have gone ahead of many roles. She has now changed, the role has been transformed to a greater level. There has been role transformation from a just basic nursing care provider to the multitasking roles, which could be a mentor, in addition to the patient basic care provider, that is her main responsibility. She is performing the role of a mentor, performing the role of the trainer, the teacher, the educator. These are all different connotations. The mentor, the educator, teacher, collaborator, coordinator, researcher, leader, and also the nurse specialist, nurse practitioner, the nurse clinician. And this is happening in India also. Maybe not to a greater extent what we expect of it, but it is happening. So these transformed roles, you have to get adapted to the recent technologies. I think youngsters are they are at advantage, not oldies like us. The youngsters are at advantage. They will just switch on their mobile and then they will find the world information, worth of information. So they don't have to hop here and there to go for the information. So you have whole wealth of information with the evidences in your mobile.
So you can use them, and you have, we know that, you have the students at many places have really excelled. They are doing much, because you can question your teachers. You have more information than the teachers who are in the class. I think teachers in the present era is feeling very anxious when they are going to the class, because they never know what type of questions the students will be asked, because teachers, like the patients and others, they are more informed than all of us. So only thing is that you have to organize whatever you read, whatever you see. You have to do mental mapping of all those things. That is very, very important. The evidence-based nursing should be, we talked about so much about the various areas of evidence-based nursing. It should focus on the person. It should be patient-centric. The evidence-based practice should be patient-centric. Person-centric for the interest of the patient. You know, it should be person-centric for the patient of nursing. And all of you are doing every day the evidence-based practice. You don't need to learn so much and so much for understanding what evidence-based nursing is. Every day, all of you, from the beginning, from a staff nurse, from the student level up to the higher level, you are doing the evidence-based practice. But only thing you are thinking that it is something, some giant is there. No, it's nothing. If you go back to the Florence Nightingale's era, you know what did she do? The evidence-based practice started from there. And that also, she did not only influence nursing, she also influenced medical sciences. Because when she was moving during the Crimean War, when she was going with the lamp to see the condition of the soldiers, what happened? Many of the patients could die because of the problem of hygiene, because of the problem of infection, because of the problem of the environment. And then, when she started using certain simple interventions, she by her own self started using certain simple interventions with the soldiers of the Crimean War while going during the nights with the lamp. She just focused on nutrition, she focused on hygiene, and she also focused on environment, the air, the safety. And then she observed. It's not only she did that, she did not only implement that, she then observed. Yes, because of these interventions, there was a lot of difference in mortality and morbidity among the soldiers. So that was the evidence-based practice. The infection rates were very less, because infection was one of the important hallmark, very important cause of causing death among our soldiers. So now, and it is from there the infection control services have come up, from that concept in medical sciences, from that nursing person. So when you go to the hospital, you are giving medication to the patient, or you are giving oxygen therapy to the patient, or you are giving, checking the vital signs. And if you find two patients are of same diagnosis, they are getting same medicine, they are getting same nursing care, they are getting everything same. But patient A responds to your treatment in a different way than the patient B. So you must realize, you must be realizing when you are working alertly in the hospital, you will be realizing that why this patient is behaving differently, why that patient is not behaving that way, why this patient is responding to the treatment differently, why that patient is not. So that why, when it comes to you, when you identify that, otherwise by closing your eyes you will distribute the medicines and injections and everything. But when this why comes to you in your mind, then what happens? You think, you do critical thinking, you analyze. And when you analyze, it becomes a research, it becomes evidence-based research. You analyze, how do I handle that patient so that he becomes, he responds in a way the other patient becomes. He responds in a way the other patient progresses from his disease. So you will use certain interventions at your level, or also discuss with the seniors. Then if you find that something has worked out well, that becomes evidence-based research. That is what is evidence-based research. So you should never think, you should be very confident at all activities of your life, whether it is inside the hospital, inside the college, talking to the people. You have to be communicative. You have to express your concerns. You have to show your confidence, and you have to also learn. It's very, very important that you learn, because till the COVID-19 also, the COVID-19 has really revolutionized nursing, because till that time everybody would not give that much of respect to the nursing, but all over the world the COVID-19 has revolutionized the image of nursing. And it is after, because there are so many success stories where they did certain interventions. They didn't have any orders from anywhere. They could do many things which they did of their own, and there are success stories you must have read also. So that was the evidence-based practice, and then that was acknowledged, and that was also approved by the authorities. And with that result, though there are so many challenges, with the result, all the governments, even Indian government also, how much respect they gave to the nurses, and all the governments across the world have put them in the policy. They have put the nursing funding in the policy. They have started investing more in the nursing. And they have also started investing in India as well as, and it has been reported in the report after the COVID that the healthcare system does not have any meaning without the nursing care. Without the nursing, the health system does not carry any meaning. And you have an example of our community health officers. Under the Government of India Ayushman Bharat scheme, the community health officers were, as a part of community health officers, and in IGNU, I took the initiative to develop that program across the country for Ayurveda practitioners and nurses. And the studies have shown that nurses are doing very well. The other day I was listening to the health minister saying in some of the, I think during the parliament session or somewhere, he was talking that he was going somewhere to the cancer hospital there, and on the way there was the health and wellness center, and where our PSC nursing person who had undergone that community health officer's post, and she was doing very well there. So that means, you can do many things. You have the potential of doing many things. That is very, very important. So when we do something, you will be appreciated. As Dr. Dubey was also telling, that you have to be willing workers to do the things. That is very important. The other thing, for anything, for anything what we do, for anything what we plan, the focus should always be on governance. The focus should be on the governance, which we had talked in the first session. It should be on the leadership, and it should be on the empowerment. So governance, all the institutions, and I think the governments should be very vigilant that we said that governance is nothing, these are the practices and procedures which are in operation to deliver. Any organization can deliver. So those systems and practices and procedures should be healthy. That is the responsibility of the institutions and the governments. There should also be the leadership. Leaders should be, I think I can say that Simriti is the best leader, which has brought so many people all over the world together to talk their wisdom. And all those people who have been invited are really very senior and knowledgeable persons. Across the UP also I have seen, I was not knowing them, but I have seen across the UP also very legend nursing personalities were there. So that is the leadership. So we must select a leader which has the capacity to do, which has the capacity to deliver the knowledge. The empowerment is very important. Unless and until you are empowered, empowerment is not the power. Empowerment is the power, is when you get knowledge of everything. Then when you are empowered, then you can discuss, you can empower others. That is very important. So the governance, empowerment and leadership is very important for delivering the services or delivering anything. The most important, other important is the regulations. The regulations and accreditation. We have been talking that as per present educational policy 2020, all the institutions will become the self-governing institutions. How can they become the self-governing institutions? Unless they are validated for that. They cannot just become self-governing institutions. Nursing institutions can also become self-governing institutions, but when they have graded accreditation, then only they can become. That is very important. And whenever you work, because I said that nursing research or clinical research, you cannot learn anything in the classroom. You cannot learn anything in the classroom. Even if you don't go to the classroom, but you go to the clinical along with the teacher. I would request all the teachers also, please, you cannot teach anything in the classroom to the students, and neither then this becomes only just a formality to talk about the clinical nursing. It's very important, if you don't teach anything in the classroom, but teach in the clinical area, make them to do in the clinical area, then I think nothing, you will have wonders in the nursing research. Therefore, the linking of research with teaching is very, very important. Linking of research with teaching is very, very important. Communication is very, very important. So all these things, and after you have done that, the feedback is very important. That means performance evaluation is very, very important for any institution, for anything to develop. That is very important. And then, the last thing which I will say is that if any institution or if any agency wants to start any institution, they have to focus on morality, they have to focus on ethics, they have to focus on justice, they have to focus on equality, they have to focus on equity, and then take the professional ethics should be the part of the clinical activity. Thank you so much.
Thank you, ma'am. Now request Dr. D.S. Negi sir. So please kindly come and address the gathering.
Good evening, everybody. Bharat Mata ki jai. So, the dignitaries on the dais, Chief Guest, Colonel V.K. Singh, Dr. Chairman of this institution, Dr. R.S. Dubey sir, then Madam Kaul, Rajesh Gupta ji, Dr. Tiwari, and Principal of this college, so Deepthi Madam. So first of all, मैं आप सब लोग को धन्यवाद देता हूँ कि आपने मुझे यहाँ पर बुलाया, क्योंकि मुझे बहुत अच्छा लगा, क्योंकि ये जब इंस्टीट्यूशन जब मैं बन रहा था तब से मैं यहाँ पर आता हूँ, तो इसको मैंने जिसे कहते हैं कि एकदम शुरुआत स्क्रैच से बनते हुए और आज इस लेवल तक पहुँचते हुए देखा है, तो बहुत अच्छा लगता है। और डॉक्टर आर.एस. दुबे साहब हमारे साथ में, जैसे उन्होंने कहा कि चोली दामन का साथ, तो हमारे सर्जन थे, मैं एनेस्थेटिस्ट था, तो यहाँ के भी इसमें काफ़ी ऑपरेशंस मैंने इस हॉस्पिटल में कराए हैं। फिर उसके बाद में अभी वर्तमान में मैं म्यू इंस्टीट्यूट ऑफ मेडिकल साइंसेस में डायरेक्टर एडमिनिस्ट्रेशन के पद पे हूँ। तो बात ये हो रही थी कि क्या चीज़ कैसे ये करें, जैसे मिशन निरामया लिया गया, मिशन निरामया लिया गया, तो इसमें क्या है, इसमें ये कि एक हर कॉलेज का एक ग्रेडेशन होना चाहिए कि कौन सा कॉलेज किस तरीके का है, तो उससे जो कॉलेज बेटर है तो एक आपसी प्रतिस्पर्धा होती है, जिससे कि वो कॉलेज दूसरे उस पे उसके अगले कॉलेज के लोगों से आने के बराबर पे आता है। और दूसरी चीज़ ये है कि अगर कोई कॉलेज ठीक तरह से अपनी टीचिंग वगैरह नहीं कर रहा है तो वहाँ के स्टूडेंट्स के लिए वो ठीक नहीं है, तो ऐसे कॉलेज को बंद करने के लिए भी एक जो यहाँ के मुख्यमंत्री जी ने इस मिशन निरामया का शुभारंभ किया, और उसके हिसाब से मैं जैसे भी देख रहा था आते समय, तो इस इंस्टीट्यूशन के समर्पण इंस्टीट्यूट ऑफ नर्सिंग एंड पैरामेडिकल साइंसेस के सभी कोर्सेज को ए ग्रेड प्राप्त है, और ये बहुत अच्छी बात है। आप लोगों ने इस कॉन्फ्रेंस में कई तरह के वक्ता आए होंगे, कई तरह के लोग आए होंगे विभिन्न प्रकार से, जैसे बता रही थी कि जम्मू कश्मीर से लेकर केरल तक और इवन कुछ विदेश के लोग भी थे। तो जिन्होंने अपने अपनी बातों को यहाँ पर शेयर किया, तो उसी के साथ साथ क्योंकि हर जगह की चीज़ों को, कुछ चीज़ें कहीं की अच्छी होती हैं, कुछ चीज़ें कहीं की अच्छी होती हैं, तो हम लोगों को उन जो अच्छी चीज़ें हैं उनको फॉलो करना है। तो उस तरह से अगर हम फॉलो करेंगे और अपने जो टीचिंग में या उस पर लाएंगे, तो वो इंस्टीट्यूशन जो है आगे की ओर बढ़ेगा। रही बात इसकी नर्सिंग की, जैसे कि आप सब लोग जानते हैं, क्योंकि मैं इसी लाइन में रहा, तो मैं देखता हूँ कि डॉक्टर्स का क्या होता है कि डॉक्टर्स आता है, सुबह राउंड लेता है और उसके बाद में वो चला जाता है। 24 घंटे पेशेंट किसके, नर्सिस के संपर्क में रहता है। तो जितना संपर्क नर्सिस से होता है उतना डॉक्टर से नहीं हो पाता है। तो आप लोगों का सबसे इम्पोर्टेंट काम यही होता है कि जो भी पेशेंट आए, आप सबसे पहले किस तरह से आपका बिहेवियर किस तरीके से है, अगर उसकी कोई प्रॉब्लम है तो उसको आप किस तरह से सॉल्व करते हैं, ये बहुत इम्पोर्टेंट होता है। क्योंकि सिंपल सी चीज़ मैं अपने जहाँ हॉस्पिटल में डायरेक्टर था, मैं वहाँ भी बताता था कि एक बात ये है कि कोई पेशेंट का अटेंडेंट आया, उसने कहा कि डॉक्टर साहब हमारे मरीज को ये है, तो आपने एक तरीका ये होता है कि भाई आपने कहा चलो भागो यहाँ से, हर समय दिमाग ख़राब कर किए रहते हो, और एक तरीका ये होता है बाद में आप जाते हो, और एक तरीका ये होता है कि चलिए भैया हम देख लेते हैं। तो एक जो आपका जो एक पर्सनल टच आप देते हो, दैट इज़ वेरी इंपॉर्टेंट, क्योंकि वही पर्सनल टच, और ये एक ऐसे प्रोफेशन है, मेडिकल प्रोफेशन एक ऐसा प्रोफेशन है कि जिसमें आपको जॉब तो मिलता ही मिलता है, लेकिन उसके साथ में अगर आप उस पेशेंट को, आप लोगों ने अभी जो पुराने लोग हैं उनको पता है, लेकिन जो नए लोग हैं उनके लिए भी कि जो आपको जो सैलरी मिलती है वो मिलती है, लेकिन आपके जो उसके पेशेंट के प्रति काम करने से जो जब ठीक होके जाता है, जो उसके रिश्तेदार जो आपको दुआएं देते हैं, वो सबसे इम्पोर्टेंट है, क्योंकि वो दुआएं जो हैं वो आपको और आपके परिवार को लगती हैं। तो ये चीज़ ये मान के चलना चाहिए। तो अगर आप इस तरह से करोगे तो कभी भी किस तरह की कोई दिक्कत नहीं आएगी। अब ये
Thank you, sir. So now I request our Honorable Chief Guest, Dr. Colonel Vinod Kumar Singh. So please kindly speak a few golden words to the gathering. Honorable Chief Guest, Dr. Colonel Vinod Kumar Singh. So please kindly speak a few golden words to the gathering.
On the dais, ladies and gentlemen, good evening. It is my proud privilege to be here amongst you today. I have been an eye specialist, so I don't have much to say, but still a few lines will be here. A lot of knowledge has flown from the brilliant and the contemporary minds. The deliberated subjects have been digested by the hungry minds. There is not much or hardly anything which has not been covered. Thanks to the organizers for giving me this small opportunity, and my special thanks to my dear friend Dr. R.S. Dubey, and our friendship is nearly in the 6th decade now. I will like to extend my hearty congratulations to the organizers and all the participants for making this evidence-based nursing care 2003 a roaming success. In medical field, a doctor is only as good as the resources and the team at his disposal. And the team in turn is only as good as the knowledge, skill and the training it has received. In army, a soldier is put through a very, very hard training with the dictum that the more you sweat in peace, the less you bleed in war. With the same analogy, in nursing care, the harder you train, the better will be the results of the outcome of the patient care. Hands-on simulated based clinical practice is just the right stepping stone. Similarly, the continuous research in nursing is sure to enhance the learning of the nursing professionals. Such academic and practical sessions as organized here elevate the standards of the nursing care, thereby benefiting the patients and the society at large. Few tips I would like to share with the young minds of all ages. Firstly, keep the curiosity and student in you alive, as the learning has only begun. 2. Keep your upper faculties, eyes and ears open to new ideas and skills. 3. Keep a soft and empathetic attitude. Always stand in the patient's shoes and you will never go wrong. You are the extension of the doctor, his executive hand, and also an observer on his behalf. Always do justice to your patients, to your profession, such that justice should also seem to have been done. With these words, I wish you the very best in your future endeavors, and thank you for lending your ears.
Thank you, sir. Now I request our volunteer kindly pass the mic to the audience. And we want one or two feedback regarding the conference, what you feel, what you experience, etc. So if anyone want to share with us.
Good evening to all those who gathered here, respected dignitaries on the days and off the days. I am coming from Himachal Pradesh. I am working as a principal at HIMCAPS College of Nursing. As a participants, I have started to register myself. Then afterwards, my friend was coming here as a resource person, Dr. Sunita Verma madam. Then I planned to do the research presentation, and before I was doing this registration, I would like to know the details that I was collecting from madam. It was organized in such a manner that everybody can understood the value of their trends and the current evidence practice. It need to be discussed in these 4 days. So I was amazed to see the prospectus first of all. Then I would like to, next step I was thinking that why can't I do the paper presentation? Next step only I was asking madam, then shall I do the paper presentation? Then that time it was closed. Then luckily I was having second brochure that it's been extended up to 1st of this September. Then finally I have decided and I have applied for it, and they have immediately responded within 24 hours, and it was like correctly they were saying the rules and regulations, how many slides it need to be prepared, how long the font size need to be prepared. So each and every guidelines, whatever it's been given through this online, it was more comfortable for me to proceed without inquiring anything about through this Samarpan College of Nursing. Through the online itself, they were giving good interaction with all the delegates, not only me, all the delegates. So I was feeling very happy to be the part of this Samarpan group, and I was really gained lot of knowledges from the day one. It starts from the simulation till now. I have gained. I have not only myself, even I'm interacting with other people. They were very enthusiastically, they are participating, they were raising the questions and they are clarifying. Already have discussed most of the state it's been covered. They were giving various knowledge. Even I was not aware of these midwifery practices which is there in and around these central portions of this India. We are in Tamil Nadu, we were not aware of these midwifery practices, independent practices and all. After coming here, forensic nursing is new for me. Even this midwifery practices is new for me, and so many things I have learned here. This is a very good platform for not only for the juniors, even for the senior faculty people also to get to know each other. And this, I would like to congratulate each and every person. Those are day and night they have put more effort towards success of this one. So I would like to congratulate. I am very happy to be the part of this. First of all, I would like to congratulate the madam and her enormous team effort. Day and night they are working. Even rain is coming, they are working. It is like positive effort and motivation. I felt myself to be like this in future. So thank you so much for your wonderful opportunity to give the feedback.
Thank you so much.
College. I've already met Deepti ma'am when I was working in SR as a tutor, and I was knowing how affectionate and how much she's just inspired. She's an inspiration for me. So this whole conference was very, very knowledgeable for me, as I was aiming for PhD, but now I'm aiming, after listening to so many delegates and important persons, I'm just thinking to publish 2 of my research papers, because I have gained lots and lots of knowledge and ideas which I was not knowing as a graduate. But and I would also like to congratulate and praise the anchor ma'am, because I have also performed as an anchor in national conference when I was in BSc. It takes a lot of courage, ma'am, because audience does not pay attention to the anchors. So I was, from first day I was waiting, I will compliment you. It's a great thing.
Thank you so much.
I feel it the pressure. And second thing, I would like to tell something more, that it is very, very important for the youngsters when they are going for higher education to take it seriously. When they are going for PGs and PhDs, they think that अरे job नहीं मिली government तो चलो MSc कर लेते. So that is lacking in the youngsters, because they are just coming and listening. They are not focusing. So that this conference has done that work, and I am hoping for future also, because I will attend it when Samarpan will conduct it. So thank you Deepti ma'am, and thank you everyone sitting over here. It was very, very great.
Thank you so much. Anyone want to share? Yes, please pass the mic here.
Good evening, everyone. I'm a student of SINPS college, and I'm really grateful, and thank you, Dean ma'am, and our college for giving us the opportunity to be here and learn so many things in our field. And one more thing, that thanking Dean ma'am for giving us the opportunity to meet so many high personalities here. It's not really easy for everyone in our field to be here. So I would really like to appreciate my college, and especially my faculties and everyone who is working behind the platform, behind this stage. Thank you.
Dignitaries on the dais and off the dais. Myself, Dr. Sunita Verma, and I came from Himachal Pradesh, and it is Sister Nivedita Government Nursing College. I am working there as an associate professor. So the most important thing which I wanted to tell, of course, means it was very well organized. By all means every words everyone has spoken out. But the most important thing is for the students, I wanted to tell, as I have told earlier also, whatever sessions been taken over here, so be very, very serious about those sessions. And many practical things, how you are going to implement in your day-to-day life, that is very important, because all the topics which were being discussed over here, it is very much useful for each and every student. And I must say, means you people are so fortunate, because many eminent personalities are here, and they have explored their views, shares, and explored many experiences also. So please be very, very careful, as Sir has also told, and many all the eminent personalities, they have told about the empathy. The most important thing, don't study for that sake, like only you people have to earn the degree and to become a teacher. That is not sufficient. First, you become a graduate, thereafter you work in the clinicals, at least for 5 years. It is my humble submission to all the students, those who will become, those who will pass out from here, work in the clinicals, then only you will be able to clarify all the doubts of your students if you will work in the clinicals. So please, don't go for MSc even. Afterwards, you go for MSc when you will have at least 5 years of experience. Otherwise, so many errors are occurring when we are working in the clinicals, because students, they are after passing that BSc, because all are very much enthusiastic that we have to go for MSc and we have to become teacher. And why they have to become teacher? हमें night ना करनी पड़े as a staff nurse इसके लिए. So please, you don't do that. Be passionate towards your profession and be professional and be empathic towards the patient, and never hesitate. Again, I will repeat my words, never hesitate to ask any question from anybody, but don't do anything wrong, because the life of patient is in our hand. Okay? And thank you so much, each and everyone.
Thank you, ma'am. Thank you. I request
here on the dais and off the dais. So it was wonderful to be here. We just registered the last moment. We were just in dilemma whether we need to attend it, whether it is in the online or offline. So when we came here for this conference, we feel how much we are privileged to be part of this conference, and the way it is being organized, and the team, the full vigor that they have organized it. It is also a learning experience for each one of us, that to organize such a wonderful conference and very elaborate way to be part of that. And one of the important things I want to express it, all these resource persons are from a nursing fraternity. It was so wonderful to know that so many eminent personalities are with us, and their experience, their expertise to share here. And when we hear them, even though we are here with many years of experience, but we feel how much we are humble enough that we don't know anything. There are so much to learn more. So dear students, you are so lucky. Now itself you are able to get so much privilege to get all these experiences. Utilize it, as ma'am was telling. The core of our nursing is empathy. All our certificates will not bring it, but the most important is empathy with which we deal with each individual persons, either in the hospitals or in the teaching setup or in the community setup. Wish you all the best. May God bless you all.
Of GNM first year, Pushpanjali College of Nursing, Agra. I am glad to present here and see this international conference for the first time. I am very glad to hear. It's my lucky time to attend this conference, this international conference. At the starting point, I am started at the GNM staff nurse. as a. So it's not my ending point, it's my starting point. So that the sir says the beginning, the greater will be end. I'm not stopping to the GNM, and I'll teach and I'll see the honorable guest, and they spoke so many inspirational words. All topics were so inspired me, and I'm very glad. I have no word to say that it will be more inspirational to me, and I'm glad always.
Request a volunteer to.
Good evening, everyone. This is Khushi Mishra from Nirmala Institute of Nursing and Paramedical Sciences, Hardoi. Ma'am, all the panelists, all the teachers, juniors, seniors, firstly, I would like to thank all of you to give a chance to us to present here, and this is our first chance that we are attending any international or any conference. So thank you so much for Samarpan Institute that you give us a chance for attending a conference like this. Thank you.
Thank you. Now I request our principal ma'am, Dr. Deepti Shukla ma'am. Ma'am, please kindly come over.
Thank you. Then GSVM Kanpur, then Nirmala, then Pushpanjali. Please be alert, you are there in the script. Thank you so much. College of Nursing Azamgarh, AICCEDS, please come forward. So sir is here. सारे सर्टिफिकेट इसमें नहीं होगा. Rajendra College of Nursing. No one is there. GSVM Kanpur. GSVM Kanpur, anyone? Yes, please come. आप सभी आ जाइए. एक साथ पकड़ लीजिए. Nirmala Institute, आ जाओ बेटा. You all can come on the stage together. There are nearby 18 students from Nirmala College of Nursing. But इसमें है सभी. पुष्पांजलि का डायरेक्टर साहब को देना है. पुष्पांजलि टीम आ जाए. अच्छा, निर्मला से कौन आए सर? ये निर्मला के बच्चे सब लोग खड़े हो जाइए. निर्मला के स्टूडेंट्स हैं. आई रिक्वेस्ट ओनली निर्मला कॉलेज ऑफ नर्सिंग के स्टूडेंट हैं. वन पिक्चर विल बी देयर. बेटा इधर आ जाओ. सभी का पुष्पांजलि थोड़े निकालो. Cultural extravaganza, let's be enthralled by a captivating group dance that will showcase the power of unity in diversity. On this stage, we have BSc 4th semester students for the group dance performance.
Moving on, our next performances take us into the world of solo dances.
करता हूँ कि ये पुराना गाना है, लेकिन मेरे ख्याल से म्यूजिक वगैरह आप लोग को पसंद आएगा और बोल भी पसंद आ जाएंगे। तेरी निगाहों पे मर गए हम, क्या करें क्या करें क्या करें, तेरी निगाहों में जुल्फों में लेके काली रात चले, सारा जमाना लिए साथ चले। जुल्फों में लेके काली रात चले, सारा जमाना लिए साथ चले। ऐसे में जीने का मजा है सनम, आंखों से तेरी मेरी बात चले। वल्ला बेघर हूँ बेनाम हूँ मैं, दिल ने जो भेजा वो सलाम हूँ मैं। वल्ला बेघर हूँ बेनाम हूँ मैं, दिल ने जो भेजा वो सलाम हूँ मैं। साकी की जिस पे नजर न हुई, ऐसा ही प्यासा एक जाम हूँ मैं। तेरी निगाहों पे बाकी अदाओं पे मर गए। तेरी अदा का तो जवाब नहीं, मेरी वफा का भी हिसाब नहीं। तेरी अदा का तो जवाब नहीं, मेरी वफा का भी हिसाब नहीं। सूरत तुम्हारी बड़ी खूब सही, दिल तो हमारा भी खराब नहीं। देख ले तेरी निगाहों पे मर गए, बाकी अदाओं पे मर गए हम। क्या करें क्या करें क्या करें, तेरी निगाहों पे मर गए। थैंक यू।
Thank you.
உள்ளம் கவர்ந்தானே, தகுணனி அனந்த என்ன
Is a reminder that even in a vast global conference, each one of us played a unique role contributing our individual strengths. Moving on to the next performance, here can I have BSc 4th year student for her solo performance. 4th semester, sorry.
नम्रता पुनित अवस्थी अभी अभी पधारी हैं। आप राम मनोरैया मेडिकल साइंसेज में मेडिकल के हेड ऑफ डिपार्टमेंट है और हमारे समर्पण ग्रुप के चेयरमैन प्रोफेसर डॉक्टर आर एस दुबे की सुपुत्री हैं। और अभी बहुत देर मुझे से एक शिकायत जरूर है कि इनको और पहले आना चाहिए था। ये बहुत देर से आई हैं, इसलिए मेरी शिकायत है। लेकिन मैं नम्रता से चाहूँगा कि एक बार यहाँ पर आए हम लोगों के सामने, और देर से आई हैं उसके लिए कुछ भी नहीं कहना, लेकिन दो शब्द यहाँ जरूर कहें। नम्रता अवस्थी। बुलाया मैंने उसी ने। क्योंकि हम सब एक घर के हैं तो मैं तो बचपन से जानता हूँ, बहुत अच्छी गायिका भी हैं, अच्छी डांसर भी हैं, तो डांस का समय, लेकिन ये कम से कम 2 लाइन गाना जरूर गाएंगी। जो भी कहना 2 शब्द कहें, उसके बाद 2 लाइनें कम से कम यहाँ गाकर तब नीचे जाएं। नम्रता।
थैंक यू वेरी मच। एंड मतलब बहुत इनफॉर्मली बात करेंगे यहाँ पे। फॉर्मेलिटी आप लोग 2-3 दिन से पढ़ रहे हैं, बहुत कुछ सीख लिया। सो आई अंडरस्टैंड इट इज़ कमिंग टू एन एंड दिस ग्रैंड इवेंट। तो मैं तो यहाँ अपने पापा से मिलने आई थी, एज प्रोफेसर नहीं आई थी। संडे है, अपनी मम्मी पापा को मिलने आती हूँ, तो मैं मम्मी से मिलने आई थी। पापा को फ़ोन किया तो बोले मैं तो इवेंट में हूँ। मैं कहा अच्छा, उनको प्रणाम करते हुए चली जाती हूँ। तो मेरा ड्रेस कोड भी आपको फॉर्मल नहीं दिखेगा। अब यहाँ आई तो पकड़ लिए गए कि स्टेज पे आ जाइए, तो नॉट प्रिपेयर्ड फॉर इट, बट स्टिल मतलब आई एम इन अ मेडिकल प्रोफेशन, प्रोफेसर हूँ, टीचर हूँ, क्लिनिकल काम बहुत करते हैं, रिसर्च करते हैं, एकेडमिक्स में पूरी तरह इन्वॉल्व हैं। तो मैं देख रही हूँ अपने सामने किस तरह से समर्पण प्रोग्रेस करता चला जा रहा है, और ये बहुत ही सम्मान की बात है, बहुत गर्व की बात है, जहाँ से ये शुरू हुआ था और जहाँ तक ये पहुँच गया है। एंड इट इज़ ऑल टीम वर्क, इट इज़ ऑल टीम वर्क। और ये इस तरह का सक्सेस अचीवमेंट किसी एक बंदे के से नहीं होता। डॉक्टर आर एस दुबे, माई फादर, ही इज़ द पिलर, बट देर आर देन अदर पिलर्स एज वेल। डॉक्टर वीपी तिवारी, दीप्ति शुक्ला मैम, एंड उनकी पूरी टीम, उनकी भी पूरी टीम। So it is always a teamwork, and it is wonderful to see this tree which has become such a huge thing. And I congratulate all of you and thank all of you for being here, for coming here and attending this event. Although बारिश ने थोड़ा मज़ा किरकिरा ज़रूर किया होगा, but चलता है. And जिस तरह से प्रोग्राम अभी यहाँ चल रहा था, that is amazing. वो बच्ची ने बहुत अच्छा डांस किया और आई एम श्योर आगे पीछे के सारे इवेंट्स भी बहुत अच्छे रहे होंगे. सो दिस इज़ फ्रॉम मी. और अब जैसे वो मेरे पापा हैं, वो मेरे जीजा जी हैं. तो डॉक्टर दीपक तिवारी मेरे जीजा जी हैं. तो फैमिली के लोग ज़रूर हैं. अब इसीलिए उन्होंने पकड़ लिया कि गाना गाएंगे, ये गाना गाएगा तो कोई वो बनता नहीं है. बट चलिए मैं 2 लाइन गाती हूँ. बिल्कुल ही 2 लाइन गाऊंगी क्योंकि उसके अंत का याद नहीं आ रहा. और लेकिन ये बहुत पुरानी मूवी है और देखें गेस कौन कर पाता है कि कौन सी मूवी है और किसने गाया है ये गाना. नहीं, कोई ट्रैक नहीं, नो प्रोफेशनल सिंगिंग. पुराने लोग पहचानेंगे. ये नयन डरे डरे, ये जाम भरे भरे, जरा पीने दो, कल की किसको खबर, एक रात होगे निडर, मुझे जीने दो. Any guesses? Wonderful. नई जनरेशन अगर बता दे इतना पुराना गाना, तो ये हेमंत कुमार ने गाया था ये सॉन्ग. टोरा मूवी है, आई थिंक 1964 की मूवी है. तो चलिए गाना भी हो गया, क्विज भी हो गया, एंटरटेनमेंट हो गया. नाउ यू कैन कैरी ऑन. थैंक यू सो मच.
Thank you so much, ma'am. Okay, so following these solo performances, we have vibrant group dance performances in the row, for which I would like to call JNM first year group girls.
जाओ जी, हमारा गीत कराओ जी, अरे क्यों तरसावे हो, हमारे शकल दिखाओ जी, थारी शरारत सब जानू मैं तोहरी, हर चले उन्हें बंगा दी ने कह लगे, मर टुकड़े में जागी तो कमी है चंदा में थारी, चांदनी पड़ता मर में बात खुशी झुम 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 झुम. ओ हमारे टुकड़े में जागी तो कमी
Just as this dance unites performers in graceful harmony, our conference has united us in a common pursuit of knowledge and collaboration. Moving on, we have a performer from Puspanjali College of Nursing. It's again a solo dance performance.
We have finished our sessions. We have ended the second international conference. So to announce it officially, I would like to invite Director of Pushpanjali College of Nursing, CMA, Mr. Rajesh Gupta, to deliver a vote of thanks.
हेलो एवरीवन, वोट ऑफ थैंक्स एक इस तरह का काम है कि लड़की की शादी के बाद जो विदाई है तो लड़की का पिता दरवाजे पे हाथ जोड़कर खड़ा है।
बहुत समय से इंतज़ार करना पड़ता है कि ये वक्ता हमारा समय खा रहा है, वो वक्ता हमारा समय खा रहा है, हमें कब मौका मिलेगा बोलने का, हमें कब धन्यवाद ज्ञापन करने का मौका मिलेगा। खैर एनीवे, सब कुछ होने के बाद मिल ही गया। तो सबसे पहले तो डॉक्टर साहब का बहुत बहुत धन्यवाद कि उन्होंने इतने अच्छे प्रोजेक्ट को कंसीव करने के लिए अप्रूवल दी। क्योंकि आप लोग मेडिकल के स्टूडेंट हैं तो कुछ थोड़ी बहुत ओबीजी, थोड़ी बहुत कुछ ना कुछ मिलाते चलना चाहिए। तो अब जब प्रोजेक्ट कंसीव हो गया तो उसके बाद फिर बहुत सारी चीज़ें होती हैं। तो रोल आया दूसरे डॉक्टर साहब का, तिवारी साहब का और प्रिंसिपल महोदया का। तो उन्होंने उस प्रोजेक्ट को, उस बेबी को बहुत अच्छे से किया। अब इस अच्छे से करने के लिए कि देखिए, जैसे क्या होता है कि हम दूध में से मलाई निकालते हैं, मलाई से मक्खन निकालते हैं, मक्खन से घी निकालते हैं, है ना। तो वो घी क्या था, जितने भी रिसोर्स पर्सन थे वो देसी घी थे। और ये जो बच्चों के ऊपर चमक देख रहे हैं ना आप कि दे आर नॉट टायर्ड, वो इसीलिए है क्योंकि इनको जो मटेरियल मिला वो बहुत अच्छा था और जो बाकी का एंटरटेनमेंट था वो भी बहुत अच्छा मिला। और सबसे बड़ी बात है कि आराम से एसी में बैठे हुए हैं। तो आप लोग भी बहुत धन्यवाद के पात्र हैं। और सबसे पहला दिन जो था उसका सिमुलेशन का, स्किल ट्रेनिंग का, वो भी बहुत अच्छा था। लोगों को अभी चूँकि चीज़ें तो पुरानी है, ऐसा कुछ भी नहीं है कि नया है, पर जब कोई चीज़ सामने आने लगती है तो हमें लगता है कि ये नया है और सीखने का मौका मिलता है। अभी जाइए मत, क्योंकि इसके बाद भी एक परफॉर्मेंस है। जो जाएगा वो मिस करेगा। हाँ, पिक्चर अभी बाकी है मेरे दोस्तों। तो वो दिन बहुत बढ़िया था। दूसरा दिन जो हमारे सचिव साहब आए थे, मुख्य सचिव साहब, उनका बहुत बहुत धन्यवाद, क्योंकि उनका चयन भी बहुत अच्छे से किया गया कि ऐसी ही पर्सनालिटी को ऐसी कॉन्फ्रेंस में लाना चाहिए। आपने सुना होगा जंगल में मोर नाचा किसने देखा। तो हम जंगल में नाच रहे हैं तो हमें नाचते हुए कोई ऐसी पर्सनालिटी देखे कि वो हमारा गुणगान करे, तो इसलिए उनको बुलाया गया। तो वो भी बहुत धन्यवाद के पात्र हैं और उन्होंने कोई कमी नहीं छोड़ी आप इस प्रोग्राम की सराहना करने में। उसके बाद जो 3 दिन हमारी कॉन्फ्रेंस चली, उस कॉन्फ्रेंस में जितने भी मंथन हुए समुद्र मंथन की तरह था और बहुत अच्छा समुद्र मंथन था। कभी मेंढक के रूप में, जो समुद्र मंथन किस पे हुआ था, मेंढक की पीठ पे हुआ था, कछुए की पीठ पे हुआ था। तो कभी कछुआ तिवारी साहब थे, कभी कछुआ प्रिंसिपल मैडम थी, कभी कछुआ मैं था और बड़ा अच्छा समुद्र मंथन हुआ। समुद्र मंथन में से जितने भी रत्न मिले, लेकिन बच्चों देखो बहुत काम की बात है और अभी पिक्चर बाकी है। जितने भी समुद्र मंथन से रत्न मिले सब आपको बांट दिए। अभी ने ले जाओ, जो थोड़ा बहुत विष बचा है वो मेरे और तिवारी जी के हवाले है। खूब डंडा मारना दोनों को, ठीक है। जो भी कमियां हैं हम उसको ओ करेंगे, हमारी जिम्मेदारी है कि आगे वाले समय में वो कमियां ना हो। अच्छे से मजा किया, 3 दिन सब कुछ किया। वैलिडिक्टरी सेशन भी आया। वैलिडिक्टरी सेशन में देखिए कितनी अच्छी पर्सनालिटी थी, पूरी आर्मी थी। एक कर्नल थे, एक मेजर थे, और वंस ए कर्नल इज ऑलवेज ए कर्नल। और कर्नल के लिए क्या है, वो डॉक्टर साहब की मूंछें नहीं थी, पर कर्नल का तो सब कुछ मूंछों पे ही है। तो और मंच पे कर्नल और मेजर थे और सामने कौन था, सामने हेल्थ सोल्जर थे। आप सब लोग हेल्थ सोल्जर हो, आप लोग किसी उससे सेना से कम नहीं हो, है ना। आप डेंगू से बचाते हो, आप मलेरिया से बचाते हो, आप हर चीज से बचाते हो। तो आप लोग का भी बहुत बहुत धन्यवाद है। और सबसे बड़ा इस बात के लिए आप लोगों को धन्यवाद है कि ये जो दूसरा इंटरनेशनल कॉन्फ्रेंस है, एक बच्ची ने अभी वो गाना गाया था जब वैलिडिटी सेशन हो रहा था कि हम अगले साल फिर आएंगे, है ना, समथिंग गणेश जी का कुछ वो था। तो वो उनका जो इशारा था वो ये था कि चिंता मत करो, तीसरी इंटरनेशनल कॉन्फ्रेंस में भी आपको आना है। और मैं समर्पण इंस्टीट्यूट के चेयरमैन साहब से और बाकी जितने भी पदाधिकारी हैं, प्रिंसिपल महोदय हैं, इनसे निवेदन करूंगा कि तीसरे इंटरनेशनल कॉन्फ्रेंस की मेजबानी करने के लिए आप हमें जिम्मेदारी दें, वृंदावन में करेंगे। तो कुल मिला के सब कुछ अच्छा है, सबके लिए धन्यवाद है, क्योंकि धन्यवाद के साथ साथ कुछ कुछ रेवड़ी बटती रहनी चाहिए, है ना, तो मुंह मीठा रहेगा। और एक कॉन्फ्रेंस ऐसी की जाएगी पुष्पांजलि कॉलेज के द्वारा, और जो उत्तर प्रदेश में प्राइवेट नर्सिंग कॉलेज एंड पैरामेडिकल कॉलेज एसोसिएशन है उनके तत्वाधान में, वो स्पिरिचुअलिटी के साथ की जाएगी। आप सबने एक नाम सुना होगा माउंट आबू में ब्रह्मा ईश्वरीय विश्वविद्यालय ब्रह्मा कुमारी इसका, तो वहाँ पे आपको 4 दिन की वर्कशॉप मिलेगी, सॉरी कॉन्फ्रेंस मिलेगी, जिसमें दीप्ति मैम इसी तरह के लर्नेड लोगों को बुलाएंगी। वहाँ भी समुद्र मंथन होगा। साथ में आप सबने शिवानी दीदी का नाम सुना होगा, बीके शिवानी दीदी, वो और उन जैसे बहुत सारे अच्छे स्पिरिचुअल लोगों से भी आपको हर रोज शाम को एक लेक्चर सुनने को मिलेगा, जिससे कि आप अपने अंदर मोरलिटी, एथिक्स और अपने कार्य प्रणाली को, अपने सोचने के नजरिए को बदल सकें। तो बहुत सारे यूपी में बहुत सारे प्रोग्राम होंगे। एक बहुत पुराना गाना है, आप लोगों ने कहीं गूगल पे ढूंढ सकते हो, वो उसका थोड़ा सा मीनिंग ये है कि अब बदल चुका, अब मेरे गांव के लोग बदल चुके हैं। तो इसी तरह से नर्सिंग भी अब बदल चुका है। नर्सिंग में बहुत स्कोप है। नर्सिंग में जितने भी कॉलेज हैं यूपी में, सब बहुत कुछ अच्छा कर रहे हैं और बहुत कुछ अच्छा करना चाहते हैं आने वाले समय में। जो इस तरह से आज जॉइंट उस एफर्ट्स में प्रोग्राम हुए, इस तरह से सारे कॉलेज वाले मिलके जॉइंट प्रोग्राम करेंगे, जिससे कि बच्चों को, फैकल्टी को अवसर मिले और वो अपनी नॉलेज को एनहांस कर सकें। और मैं तहे दिल से पुष्पांजलि की ओर से समर्पण का, पूरे समर्पण भाव से पुष्पांजलि अर्पित करता हूं कि उन्होंने हमें जिम्मेदारी दी अपने साथ जोड़ने की। देखिए, कोई भी अपनी सफलता में किसी दूसरे को सहभागी नहीं बनाना चाहता, पर ये इनकी दरियादिली है कि इन्होंने अपनी सफलता में हमको भी नाव में बिठा लिया। तो अब ये इस धन्यवाद ज्ञापन को यहीं समाप्त करते हुए एक छोटा सा, अभी जाना नहीं भाई, पिक्चर बाकी है। एक निवेदन ये है, एक गाना है, क्या गाना था भाई? आज जमीन पर उतरे कितने सितारे हैं। शाहरुख खान का एक गाना है, शाहरुख खान और दीपिका पादुकोण, आज जमीन पर उतरे कितने सितारे हैं। ये किसी भी प्रोग्राम के, सफल प्रोग्राम के एंड में होना जरूरी है, क्योंकि आप सब सितारे हैं और ये आसमान है। तो इसका रूल क्या है? पहले तो एक दीपिका पादुकोण चाहिए। कौन है? चले आओ। देखिए, जब ये सॉन्ग शुरू, सुनिए, जब ये सॉन्ग शुरू होगा, लेकिन बच्चों, जब ये सॉन्ग शुरू होगा तो सबकी नैतिक जिम्मेदारी है, नैतिक, कि इधर से चढ़ेंगे और कैटवॉक करते हुए इधर से वापस अपनी सीट पे बैठ जाएंगे। और जो शुरुआत होगी, सुनो, जो शुरुआत होगी वो डॉक्टर साहब से शुरुआत होगी। सबसे बड़े सितारे तो डॉक्टर साहब ही हैं। फिर ये जो लीजेंड्स बैठे हुए हैं इनसे होगी, बारी बारी से, अपने आप कहना नहीं पड़े, देयर विल नॉट बी एनी इनविटेशन, ठीक है। जो नहीं आया मंच पे, इसका मतलब है वो ये 4 दिन के प्रोग्राम से खुश नहीं है। और सारे बच्चों को विद्या रानी की कसम है, जरूर होना। यस, चला दीजिए।
किसी को नहीं आना है ना? आप लोग डाउन अरे आएंगे मैम एक मिनट दे देंगे जरा फोटो कर लें।
ये रुक नहीं सकती।